now with our media team. It is very, very, very important that they do that. We did an opening section. Again, that was also very rewarding. But I need to quickly tell us what happened yesterday. Every activity here that happened was streamed live. And I want to encourage us all to go on the YouTube on your phone and type Decrew. Just type Decrew. Every activity. It was very commendable the way doctors comported themselves, seated and not moving around. Please, it is very, very encouraging. And we want to plead with us that we should exhibit similar ability and character today. We are not saying you shouldn't joke, you shouldn't visit, you shouldn't greet, but I'm telling you, the way you comport yourself yesterday, it was very resounding. And that was one of the reasons why we said, if we are streaming this thing live, we will not allow our colleagues to queue for either tea break or food. It doesn't speak good of us. We are equally arranged for that system today. Please be seated. Your tea break, your lunch will be served while seated. The ticket will be given to you. They will collect it at the point of exchange of that service. So we want to thank you very much that we're looking forward to your active participation today. It is also very important that we announce two important things. Yesterday, because of our process, we didn't tell us enough. At least we didn't repeat the announcements severally. We have a partner with FitSyn. They are giving all the delegates and the spouses here a free glaucoma test. So they are still outside under the carport for all the delegates. All you just need to do is go with your tag and you'll be checked for free. It is important that we mention that to our colleagues so that you can visit that stand. It's under that carport. Today, we are also having support from the A's. They are emergency ambulance services. And like we always pray, we don't want an emergency. But in case there is any, the stand is there for that services. And that's what we are going to be giving. Our business class is going to start immediately after this announcement. We have the lead. They have been here even before most of us. Safe Care and MCF. And the two leads of that team, Dr. Mrs. Ibiroke Dada, has been here. Please, can we put our hands together for Dr. Ibiroke Dada? And the lead for the MCF, my very distinguished brother, Uzo Osisiogo. Please, can we put our hands also for her? We have also recognized the presence in our midst, Dr. Faduyile, the human resource for Lashma. Please, can we put our hands together for him as well? Ladies and gentlemen, you are all recognized. Okay. You are all recognized. But I want to quickly plead with the national president of Healthcare Providers Association of Nigeria to just sit beside our chairman. That is where you belong. Please, can we put our hands together so that we can support him to sit where he belongs? Thank you very much, Mr. President, for partnering with ANPMP Lagos. We recognize the presence also of the past vice president of our association, the national vice president, Dr. Shola Ogunleye. Thank you very much for being with us. We recognize. This vehicle, EKY 963JA, is a Corolla. Please, the owner of this vehicle should kindly repart. Please, it is very, very important. I think with the permission of the chairman, we can have an opening prayer, then we start the business section. If the team, the business class team are available right now, can I get a wave if I have your permission, Dr. Dada? You have your permission. Thank you very much. So we start this section with an opening prayer. Let me see. Yesterday prayer actually helped us. But before we go into an opening prayer, let me just quickly recognize that our spouse was very amazing yesterday, and we can't do this without them. We thank you very much, our spouses. Those that are here, please tell others that we appreciate you for your support always. God continuous support will be upon you. Thank you very, very, very much. We appreciate you. So we're going to take the opening prayer. I think Dr. Faleti is in the appropriate place to give us that opening prayer today. Dr. Faleti, please, can you mount the podium? Thank you very much. Please, can we encourage him with a round of applause, please?
Thank you. Praise the Lord. Please, can we rise as we pray? Let's honor God, the ever-present. He doesn't sleep, he doesn't slumber, he watches over us. Faithful God, we thank you. Thank you for this association. Thank you for the officers. Thank you for the planning committee. Thank you for day one. It was awesome. Thank you because there was no mishap. Thank you for your abiding presence. Lord, we commit today into your hand, knowing fully well whatever is committed into your hand, you are well able to preserve it. We just ask, oh God, that Lord, let today the information that will be coming to us, let it be well processed. Let us all live here a better person with greater hope for our practice and for the nation. And let your name alone be glorified. Thank you for the officers, the planning committee, and everything that has been put in place. Thank you for the exhibitors and the partners. Lord, no one will regret being a part of this. And we return all the glory to you, Lord, in Jesus' name. Amen. Thank you.
Thank you very much. I know that if we start this program and we put it in the hands of Almighty God, things will work. It is not by oversight, but I just need to recognize and appreciate all the members of LOC. I can tell you, they are, in fact, I want to work with that team once again. Please, can we put our hands together for all the members of LOC? Thank you very much. I think Mr. Chairman needs to say something to us before we start the business class. Mr. Chairman, sir, please, you want to speak to your members, and they are very committed. I can tell you that. Please, can we put our hands together for Mr. Chairman? While doing that, I quickly cite the immediate past chairman of Lagos State, Dr. Makinde Akin. We are recognized. Good morning. Good morning. Thank you.
Good morning, good members of ANPMP Lagos. Good morning. I want to welcome you to the activities of day 2. Yesterday was awesome. Today promises to be much better. So permit me to express my profound gratitude and appreciation to every member of this association. And I say this with every sense of responsibility. I am not given to flattery. In fact, I don't have enough words to describe the response, the enthusiasm, the overwhelming support that we have received since the inception of this administration, even up to this moment. So the activities of this convention further reinforces your attitude towards the activities of this association since we came on board. And it is a singular privilege and opportunity to use this time to show appreciation on behalf of all the members of the executive committee, my very, very cooperative, supportive members of the ESCO. We want to say a big thank you to all of you. So thank you. I say thank you. I'd like to place on record the very formidable role that have been played by our forebears, our predecessors in office, particularly my IPC, Dr. Akin Bola Makinde. He has defined a new trajectory in relationship between past leaders and those who are currently handling the affairs. Since we came in, this man has attended every meeting, ESCO meeting, state executive meeting, and general meetings. And even committee meetings, like the building committee meetings. He is always there to provide guidance, to tell us the pitfalls that probably he went through so that we don't fall into the same pitfalls. So please, I want to crave your indulgence. Please help me give him a round of applause. Thank you so very much. I truly appreciate all of us. I would that this attitude, this thinking about our association, about one another will continue. It has always been my prayer, goal, and aspiration that we break down every wall of division and create bridges all over the entire zones of Lagos State ANPMP. We are one big family. And together, there will be nothing that will be restrained from achieving by the grace of God, including that project. And everybody knows my heartbeat. This is the reason I campaigned and I came for this position. And I know that together we can do it. I'd like to use this opportunity to thank those of us that have been donating over and over and over again. May the Lord bless your giving in Jesus' name. And we also want to encourage those who have not identified with the project to please do so. I know that a lot of us see the project and say and begin to imagine how long will it take? Can we pull it through? And I tell you, that project is not beyond us. Right from inception, when I was vice chairman to Dr. Akin, I told him, we are the ones that will do this thing. And we started the foundation. And that building is standing as it is now. We have finished the carcass, roofed, and everything. What we are doing now is finishing. If we could lay that foundation in a refuse dump, in a burrow pit, very solid foundation. If you were there when we were starting, you would think it was Julius Berger that was constructing it. And that is as solid as it is. So if we could do that, we can also finish it. So the slogan now, or the mantra, is that we build, finish, and furnish the doctor's house. Our number is our strength. If we come together, we will finish that project in the next 10 months. All in favor say aye. Oh, that is too cold. If there is any doubt in your mind, please clear it. All in favor say aye. Thank you so very much. I cannot drop this microphone without appreciating members of the organizing committee, those that worked day and night to put together this beautiful conference. This is a conference of international standard, you will agree with me. And okay. You will agree with me. My deep appreciation and gratitude goes to the LOC chairman, Dr. Akin, a man of ideas, very versatile person, full of energies, indefatigable. And you know what amazes me about him is his ability to occupy the very high seats, and when he comes down, those that were his lieutenants will now ask him to come and play one role or the other, and he does not hesitate. He fits into any position at any time. And this is the spirit. I would that everybody will emulate this kind of spirit. And if we do, there will be less talks, there will be less criticisms and all of that. And all we will be seeing is how to arrive at our destination. Please, let's put our hands together for this man. And my appreciation goes to every member of the team. There is no time. I've been told that there is no time. I would have more time so that I could mention you one by one. But permit me to mention specifically members of my ESCO, two of them, Dr. Oluwaseun Olushola, the secretary. That woman does not sleep. I can call her any moment, any time, even at 12 midnight, when a lot of married women will frown. Why is this man disturbing me? Does he not know that I'm married? Please help me appreciate this woman. Thank you very much. And she doesn't get angry. I wonder why. I wonder whether, in fact, I will have a discussion with the husband. Does she get angry at all? Or is she just... Okay. Another one I want to appreciate is our treasurer. With her, our money is safe. I don't think whether anything is happening. I know any figure she gives me is correct. Please, a round of applause for Dr. Iyamale. And indeed, every member of this current ESCO, I appreciate you. For lack of time, I'm sure during the AGM, I will show more appreciation to all of you. Thank you so very much, and God bless you. And I wish you a very wonderful day 2 of this conference. Thank you so much.
Thank you very much. I think my chairman can get more appreciation, please. Can let us encourage you, please. There's a big masquerade that is coming in. I need to recognize him before he comes in, because he has said he wanted to take a tour of the stand first before coming in. When I asked him to send in his profile, he just sent 2-3 paragraphs. He's a member of the panelists. He's a strong enemy stalwart. He's a founding member, maybe not founding, but at least the protégés of founders. And that is no any other person than Dr. Akin Akinlade. He's in the house. Dr. Akinlade. So when he comes in, I will quickly recognize him. But as he's coming in, he's seated beside the chairman. I think on these notes, maybe I won't be coming down too much, because as soon as I step down, I was advised that we should encourage our members that when they visit stand, they should try and pick 1 or 2 products. That is good for continuous collaboration, but let us buy what we need in our stand, please. Let us try to encourage them to support us. So thank you so much. I have the singular honor to invite a brother, a friend, a progressive person, and a manager who have serious interest in the private sector. And that is no other than Mr. Uzo Osisi. Please, can we put our hands together for this lead from MCF? As a present. Please, continuous appreciation. Thank you very much for coming and partnering with us. Thank you very much. I really appreciate it. Thank you.
Good morning, distinguished ladies and gentlemen. It's an honor and privilege to stand here before you to, start this master class session. Let me stand on all existing protocol that has been duly established. I think this morning my job is very simple, to stimulate your minds into our master class that we'll be putting through today. Just a minute, let the slides come up. But hopefully that, I know that healthcare, the business of healthcare is always one with too many stories of difficulty, sometimes sad situations happen, but they're always the bright side of everything, especially if we know. And today we'll be having distinguished speakers who would do due diligence on various topics to be able to stimulate your thoughts in and establishing our healthcare businesses better. And for us, we call it business unusual, thinking out of the box, basically, on how I can take one step forward to making my business better. 1 second, please. We've not... Okay. All right. So basically today, business unusual for preventing private sector practice is what we want to look at. So let's stimulate your minds and think of it as this way. What one step can I do to make my business a bit better? I'm talking about sustainability and growth today. So business unusual today, we'll be looking at various session topics, and after which you will have deep dive into your Know Your Customer by Dr. Shola Pitong. We'll have Winning Patient Back, which will be handled by Dr. Faduyile. Quality improvement and better outcomes. We'll also deep dive into that, and Peggy Monov will be speaking on this. And finally, hospital design aesthetics will be something that will be how to get an advantage of, having better hospital design and aesthetics. And that architect, Oluwatobi, would handle that session. Now, what do we want to talk about? This session topic basically looks at highlights of competitive realities. So basically, what do we see in our modern healthcare market in private sector in Lagos? What challenges, what are the myths there that we need to try to demystify, in the sense that it has probably eaten a lot of businesses and people consider it as the norm? How can we talk? We need to talk about succession planning, basically community engagement, and also insurance drive. How can we take advantage? What do they really mean to our businesses in our various locations, and how can we take those such advantages? And then we'll also look at what are the practicalities in terms of tools to be able to improve our quality and our business. And then finally, we inspire practitioners to start to think outside the box and be able to see how I can take one step forward to improving my business despite the situation of my business. So the first thing we need to talk about is Lagos reality. Of course, in Lagos, I know there's a very strong public sector presence in our Lagos community. It's cheaper. Could it be cheaper? Could it be better? Could it be more affordable? Then second reality that poses is patients. The patients actually bypass hospitals, and pharmacies and PPMVs have become first point of call. What can we do to take such reality on board and be able to have better outcomes? Then we have rising expectations. Basically, irrespective of the economic realities, patients still have rising expectations in what they expect in terms of services. And then there's issues surrounding affordability and quality. These are real terms, not just in writing, but in what it impacts on our business. And of course, we now talk about escalating cost of diesel, power, human resources, and even consumables and supplies. Then, of course, sole proprietorship struggling to compete. So we have different formats and different types of businesses and business structure. But one thing is common. There will always be competition. Can we compete or can we cooperate to make our business move forward? Is this a time to cooperate, come together, or is this a time to keep on pushing competition? What do we really want to achieve, and how can our business thrive and take the next level or the next leap? Now, basically, there's an age-old myth that transcends too many bounds. So people believe that in this age-old myth, that my business is old, my facility is old, and therefore newer facilities, newer technologies have come to, take over. And because of that, I don't think my business necessarily can move forward. But that's not true. Your facility may be old, your facility may look dilapidated, but there's room for rebranding, there's room for restructuring. I know the oldest private hospital is somewhere around 57 years. In fact, I think I was born there. But if you look at what it is today, history has proved otherwise. If I take a cue from that hospital, they provide 90% of healthcare, ranging from medical, emergency services, and the likes. And of course, they have international accreditation. So some of us have already the mindset that our businesses cannot go beyond what it is doing now. But that's not true. It only takes thinking and looking at the differences or different areas where we can put our mindset towards and make that business become, better than it is currently doing. So the business unusual mindset is basically looking at 5 pillars. We'll have to look at restructure and rebrand. So basically adapting to today's patient services. So how do we restructure? How do we rebrand? Where am I in my community? What are the patients looking for? What are 1 or 2 things that I can put together to rebrand? Rebranding doesn't necessarily, could just mean a simple paint job. And the paint job will do the magic. But it's looking at those uncommon things that are not necessarily everything about the financials. The second pillar we need to also look at is engaging communities. I've had opportunities to speak with some private healthcare practitioners, and they don't necessarily, even though they are doing well, they don't necessarily feel that the immediate community has a very vital role to play in improving what they are, in becoming their marketing agents, in becoming their mouthpiece to telling people the level and quality of service there. But we need to look at our communities. What can we do, better to engage them, to make sure they understand what we're doing here, and to be better to pull friends and family, to let them have the necessary trust and loyalty, and of course the necessary connection to keep on keeping my businesses afloat. The third area will be the top pillar to really look at and consider is leveraging health insurance. I know we talk about health insurance and there are various insurance pools, insurance models that are running, or insurance that is being ongoing, but I'm not sure that we realize that we have to engage more and more into insurance in terms of all the necessary private and even the government insurance. A lot of people might have their different models, which is good, but how can we really look at insurance, bringing back patients, especially from the informal sector, and making them a bit more formal? What can we engage? Do we want to just discard the low-level insurance premiums that are being paid? What if we reconsider it, reposition our business to be able to serve them? Would that not increase and improve our profit? The other pillar to look at is investing in aesthetics. In fact, for me, this is one of my biggest, call to action, in the sense that aesthetics is very important. No matter how old our facility is, there is room to improve the aesthetics. Now, when I talk about aesthetics tries beyond just the painting. It can also be a process change in terms of your queue guides, in terms of your different service area. How can I just change the aesthetics and people will have the look and feel? Starting from, when I go to hospital, it starts from the gate, the entrance. Your security personnel, how do they look? Do they look welcoming, or they do look like I'm walking into, the mortuary? Because I'll go in and I'm not sure if I'm coming out. So those kind of processes, those kind of trainings are actually needed. So first impression really matters, because I think I was speaking with a friend some days back, and they were telling me how their father entered a particular hospital, and when he came out, he swore never to go back. That's because apart from the service he received there, the aesthetic was so bad, and he'd rather stay and die with his ailments if he could not go back to a proper environment. So it's very important. And the last piece of, our mindset is we should think of it, succession planning. Now, this is not a new theme or a new conversation, but succession planning involves the next generation. And when I mean next generation, it doesn't have to be family-owned business. It's time for us to look beyond blood and see the importance of, training someone who can actually elevate the name of this business in the next generation. Could it be a younger staff that has the enthusiasm, drive, and willingness to do it? Why don't we start looking inwards and see who we can invest with if we do not have, a blood relationship with any of our offspring? But it's important that succession planning goes beyond having the family members, so that it can protect our legacy and, of course, move our business to the next generation. I mean, Coca-Cola can do it. I mean, why can't we? There are a lot of hospitals that have those examples. They've lived for years. I mean, I think it's possible to do it if only we have that mindset to actually change this. Then there are possible business models we can adopt. This is just a tip of the iceberg of what is to come. But we talk about the low and high volume. We can also talk about subscription, cluster, partnership, and public-private partnership. So if you look at the low cost, high volume, basically looking at how do we have a lot of pool from the low cost community. So you can provide affordable cares and then you have numbers. Insurance could also be a driver. And what that ultimately means is that at some point you have profitability, because you are managing your cost very well and you have the pool of volume. Of course, it has to be well balanced for low cost, high volume to work. And then the next one will be subscription and retainer partnership. So basically, do you have models that you can look of high volume businesses, organizations, churches, cooperatives, schools, and the likes, and provide them those immediate and special care that they will use, and probably you adapt. So there are school communities next to where we are. There are churches, there are mosques are there. How are we able to work with them or work with an insurance pool to be able to be the go-to service care provider within our community, because there are a lot of this around our community. But it's a question of, have we thought about it? Have we looked outside of it and see that we can actually pull this and make it work? Then we talk about the cluster hub and spoke. Similarly, some years back, I know the banks that are thriving today, there was merger and acquisition. But in this case, we're looking at where are the possibilities of not dying alone, but having a merger with a bigger facility. And then businesses can thrive. Solutions can be provided at different levels. So one doesn't have to manage care or manage healthcare solutions that's beyond them, and you just refer out. You can actually work, have agreements with as partners. And what will happen is that every referral system is within an organization. I don't have to refer out. I can only refer to my bigger practice. So can we start looking at hub and spoke methodologies to be able to make our business thrive, or to be able to keep our business sustained up to the next generation? You don't have to have a business and you leave it to die alone. It's important to start looking at where can I work with, because there are many big time businesses that have died, either by through succession planning or non-succession planning, or not being able to open up and have partnership where they can actually do more and get more. Then, of course, the last one will be in partnership also with the PPMVs. And then the last one will be public-private partnership, where we look at doing things with public sector as private providers, where the public sector can give us opportunities to serve within the scope of our practice or within the scope of our services. And that ultimately impacts the larger objective of the government agencies and so on. So these are things that we need to start thinking, as entrepreneurs, as private sector owners, and as business owners, to be able to see how our models can move, they can help us to move forward. Then just to talk about the surrounding pressures coming from HR and cost, a lot of questions arises. We're having brain drain issues, which HR such we have high cost of energy and power. We have unqualified staff, maybe as a result of brain drain. So there's increase in risk. How do you respond to this as business? Thinking about business being unusual. Of course, we can optimize roles. So while you're having brain drain, you might have staff that you're able to train and optimize his or her role to be able to provide X service. Of that, I know also comes with a remuneration, which will be, better managed. So you can optimize their roles. There are nurses there. You can give them more responsibility to be able to provide this. However, as long as the staff is being trained and assured that they do not do beyond what their training and licenses have allowed them to do. Then I talked about shared services before. So you can have shared services that that are required but are not primary, but are important to running the business. Procurement, you can have partnership for procurement. You can have billing systems and so on to be able to bill adequately and properly. Because sometimes you walk into facilities, they do not have the adequate level of billing. It's just guesstimates of what were we billing last month? Okay, let's just give him discount. If you need to have those kind of things, there should be proper documentation and systems to be able to manage who you give discounts for and how you bill. So that at the end of the day, you know your bottom line. Then, of course, we have to outsource non-core function, like I previously said. If it's not your core function, security service is not your core function, you can give it to the security service team if security is your biggest challenge within your community. Ambulatory service as well. If you have high turnover of ambulatory services, you probably don't need to have, your ambulance. You probably have to, outsource it out so that people can actually handle it and you do more, rather than face more pressures from maintaining the ambulance and what. And then finally, to embrace technology. That this guy cannot overemphasize. Technology is very important to embrace. As little as WhatsApp can actually help to guide, and everybody I think is on WhatsApp these days, so can actually help to guide and build up a solution community using technology to be able to keep your clients in check and keep them closer home to you. So let's quickly look at, in all of this, let's look at the path to growth. Basically, if we look at business unusual and how what we consider an opportunity to look outside the box and look at the small wins we can gain. If we have higher patient volume through affordable models, it's possible. So it means that if we structure our model and we have higher patient volume, it means that brings that our returns becomes a bit more. We can have greater trust and you have quality and aesthetics if we actually look at it. Once your quality is there, your aesthetics is looking good, obviously trust will be reaffirmed. Then, of course, it also helps us to pull down, lower operational costs through partnerships. So basically, you share your costs and then you keep your business running, the core engine. Then insurance-backed models help us to predict our revenues. So you know what's coming. If you need to invest in an area, you know where to invest and you know how you get the funds. It also gives you an opportunity, even if you need to maybe take a loan or something to be able to improve an investment area. Surely, with models like this can help. And then, of course, it gives opportunity to open up to the likes of SafeCare, MCF, which is the medical credit fund, to be able to look at your models and look at financing solution or quality solutions that can help up them. Very important to see how we start to think in areas where we can look at quick wins. We can look at those areas. So imagine when you go back to your facilities, look at areas that are not being used. Look at the halls, the waiting areas. Can it be better? Can I restructure them better? Not necessarily even putting money down, but putting a process down. And that will make people, they feel more comfortable to even wait if need be. Do you understand? How do I look at the small margins of cost that I can make by, reducing certain services? How much savings can that aid me? If I invest in the power solutions such as solar energy, where can I adapt them to that probably will help me reduce my cost of burning diesels and fuel and probably improve my cost of providing services by increasing the cost of reducing the cost of power, which I have. So these are different pathways to start to think about how we need to operate, take the marginal edge to improve. So our call to action on this, I want to vehemently say that it's never too late to reestablish our business and make it look much better. It's a myth, it's a concept, it's a mindset that can only limit us. Secondly, we need to re-image our practice. Basically, look at your practice. Do I need to do a paint job? Do I need to put some tiling jobs? So in those days where I used to work somewhere, somebody said that how we are judges a good facility to come to or to continue with, he goes to the toilet. Once the toilet services are very poor, he knows that he cannot trust the quality of care that comes through that facility. And so maybe those are the little things that people are actually reading. The ones that have to pay, whether via out of pocket or through insurance, probably that's one of the reasons they're looking for your little mindset towards adapting and improving quality. Then, of course, restructure your business structure. Look at key personnel that can be elevated to handle better things, and look at, structures in terms of your consultation rooms. Can I do a bit of change? And I go to a bit of facility, and they've done that. And I kind of tell them, what took you so long to think this way? It didn't cost anything to change their facility or patient journey pathway within the facility. Then engage your community. Do not think because you're probably doing well within a small community, the immediate people do not have a say. I can tell you vehemently that there's a particular facility I know within a very good community, but because of one or two things that have happened, the community, the first thing when you approach, I'm looking for a hospital. They say, can I use this hospital? They tell you, no, people that go there, the percentage of death is higher there. So that is then succession planning. Let's plan for succession. Succession planning not to be restricted by blood, but be restricted by capacity to build and on a particular personnel. Then build trust and loyalty. Will compete and thrive. And finally, it's important to know that business unusual really starts now. Thank you for your time.
Thank you very much. Well, to me, I still much believe that he deserves another round of applause, please. He has stimulates our appetite. And that is very, very important. We're going to take the next person. But before that, let me quickly recognize the presence of our past chairman, past president, and a BOT member, Dr. Anthony Omolola. Thank you very much, DMP. You're welcome. I also want to take that opportunity to recognize the chairman of Lagos branch of Guild of Medical Directors, Dr. Omoniyi Fagbemi, my very distinguished friend. Thank you very much. We also want to recognize that iron lady, the chairman, HCPAN Lagos, pharmacist Biola Paul Oze. Thank you very much for gracing this occasion. We missed you yesterday, but thank God that you're making it up today. Thank you very much. You're welcome. The Logema of Egbaland, our own, Dr. Folarin Williams. You're welcome. Thank you very much for recognizing the Logema. Mm-hmm. Of course, I won't drop that mic without recognizing my teacher, my mentor who put me through in the obstetrics and gynecology, Dr. Segun Akeredolu. You're well recognized. Thank you very much. He always liked to sit in between the crowd. Another very distinguished DMP of this association, who is hibernating and supporting us from the back. My spirit said I should delay it till the next picture because I need to say one or two things about him and his children who are also in medicine and doing very fantastic. Ladies and gentlemen, let me welcome Dr. Quito to come and take the slide for the next presentation. Please, can we encourage him as a fan? My friend yesterday, my friend today, my friend tomorrow. I hope you will not abandon me again. Thank you very much. Please, can we put our hands together for you once again?
Thank you very much, sir. Okay. Well, good morning, ladies and gentlemen. The distinguished chairman of today's occasion, very distinguished leaders and members of the Association of Nigerian Private Medical Practitioners. Thank you for the opportunity to be here to share some of my thoughts on knowing your customer and the competition. You will agree with me that a lot has changed over the last, we can say 40 years in our healthcare system in Nigeria. And there's need for us to be very conversant of what's happening around us and how we need to respond as private healthcare practitioners, even as healthcare practitioners in general. So this presentation is just going to share some of the thoughts. I've been told I have much limited time than I thought, so I'm going to do my best to rush through the slides, at the same time try to pass on the message. My name is Shola Piton. I'm the MD of General Hospital, Lagos. Okay, so we will run through a bit of evolutionary history of what healthcare system has gone through in Nigeria over the last couple of years. We'll talk about the healthcare customer. We'll talk about competition in healthcare marketplace, and then we'll round up with some tidbits on how to be successful, maybe some of the ideas that private medical practitioners can borrow from in order to survive in this new healthcare marketplace that we found ourselves in. So we know that there's a lot of transformation in the healthcare sector. Many things have changed over the years. And indeed, as we go on, if we look at the pre-1999, many years before then, a lot of things were going on. Oh, I'm sorry. I kept changing this slide. I didn't follow. Please forgive me. Okay, this is where I am now. So, pre-1999, there were many public healthcare facilities. Oh, okay, but I can't pick up. It's too far away. I'll just use this one, but I'll follow. Many healthcare facilities that were not able to meet the demand of a growing population. So, and we had so many, our population was increasing, but our public healthcare facilities was not able to meet up. The government of the day then, pre this current democratic dispensation, were not building enough primary healthcare centers, secondary healthcare centers, or even the tertiary healthcare centers. And so we had poor funding of healthcare infrastructure back then. Of course, with poor funding, not enough equipment as well, decaying infrastructure that existed, and everything started going down. We had the great institutions like UCH that used to receive medical tourists from all over the world. Over the years, started going down, unfortunately. Significant decline in quality of service delivery, multiple bottlenecks within our healthcare system. There were many, many bottlenecks. You go to an average public healthcare facility, you have to spend 5 hours on the average in order to get access to care. That was what was existing. Of course, extended wait times, poor staff attitude, unethical practices of all sorts. In certain instances, you have to tip people, pay healthcare workers, doctors, nurses, public healthcare workers began to sell their services before you would get services that they were being paid for in terms of their salaries. Then, of course, the customer was being dissatisfied continuously. All our patients were unhappy. And then, of course, what that led to was poor health outcomes. Well, the private health sector, the private healthcare practitioners sprang up and took up the gauntlet, saw all the gaps, and started, trying to meet those gaps. So many doctors started opening private hospitals and clinics to meet the demand. There was better doctor-patient communication and interaction. So, and then you kept seeing the same doctor over and over. So the care continuum was better. There was timeliness of service that was improved. Better ambience in all the private clinics that we had then, compared to the government hospitals that existed then. And then, of course, that was only accessible to those who could pay certain premium or certain money for those private hospital services. So those who could not pay still had to resort to the government hospitals. Well, during the democratic dispensation, things started improving. Not that the military didn't try at all. It was just that it was a drop in the bucket. But during the democratic dispensation, I guess because people voted them in and they needed to impress all the people that voted them in, they started investing gradually. We had a lot of primary healthcare centers that were built all across the nation by the Obasanjo administration, investments in the tertiary healthcare facilities all across the nation, at least the major ones. They re-equipped them, they refurbished many of them. Yaradua administration, Jonathan administration did similar things. And we've seen continuous improvement in the Buhari and our current president, Bola Ahmed Tinubu's administration. Now, it's not uncommon to go to many of our public facilities and see the state-of-the-art equipment. Yes, maybe not yet enough, but if you go to the federal teaching hospitals, you'll realize that the equipment now that exists. There might be some PPP things happening, but they exist. Unlike many years, take it 15, 20 years back, you couldn't find many of these things. You have a lot of improvements in even how they are giving the services, the delivery of those services. The wait times are improving. The ambience of the hospital environment has changed in many, many, many ways. And so there's a change in the direction. Many more patients who would normally patronize private hospitals, private health facilities, are now beginning to tune to the public health facilities. Of course, if we take the Lagos State study as a case study, the same thing happened. Pre-1999, we had just about 12 public general hospitals. Today, we have about 30. It means the number is increasing. We even have some that are now getting specialized. We have about 8 or 9 maternal and child care centers focused and dedicated for maternal and child care. We have Massive Street General Hospital being currently built right now. They've been on it, but we are talking about a very, very world-class, purpose-built hospital facility. Then we have General Hospital Ojo coming up, again, purpose-built. So in another year or two, this number 30 will increase to maybe about 32 or thereabout. And if we go down to the primary healthcare level, many primary healthcare centers have been built, have been refurbished, and even now the local government authority are beginning to invest in primary healthcare centers. Some of them are building primary healthcare centers that are well equipped. I have been to a few of them and I see monitors there, and I'm wondering, who is going to now run these monitors? But it speaks to what they are trying to say. They are beginning to equip those healthcare facilities, primary healthcare centers. They are beginning to repaint, refurbish them, and that is now making our people to begin to patronize those public healthcare facilities now. Of course, along with that, we have the upcoming University of Medicine and Healthcare Sciences that Lagos State is working on, where multiple public healthcare facilities owned by the state will become teaching hospitals. So that plan is ongoing right now. So, and they are working on it. So a lot of improvements are coming. Why am I going through all of this? Now, if you have improved infrastructure in the public healthcare facilities, that is comparable to what you are beginning to have or what you've had in the private hospitals, if you have expansion of the capacities of these public hospitals in terms of the locations where they are situated, so there's increasing accessibility to people. You don't have to go too far away from your homes anymore before you access even primary health care now. The government is trying to have one primary health care center in every ward. They haven't achieved that, but there are already over 300 primary health care centers. So they are inching towards it gradually. Then that increases the accessibility. Of course, they are charging lesser and cheaper fees for the services being rendered. Now, what about the customer itself? The customer is getting more and more enlightened and demanding more from healthcare workforce. A nurse can't just speak anyhow to a customer anymore, to a patient anymore. A doctor can't just be patronizing to a patient anymore. They will ask questions. They will question why you are speaking to them like that. So things are changing. Now, another major challenge in the current market dynamics is that we have an eroding middle class. The purchasing power of many of our people is reducing. What 10 naira could buy 20 years ago, it can't buy it anymore now. You probably have to spend 500 naira for. And their own income is not keeping pace. So now they are struggling with affording the services of private healthcare practitioners. And now they are resorting more to the public healthcare workforce. When you marry those two, improving services, increased access, better quality on the public side, and then reducing income, purchasing power of the customer, you begin to find out or get answers to why there seems to be reduction in patronage on the private private hospital side. So now, who is the healthcare customer? It's just an individual who is ready to receive medical attention or support, or an entity ready to receive medical care and support. Now, we know that healthcare is different. It's a sensitive service that we're rendering, not just any other service. So, of course, there is need for quality in that service that we're delivering. There is need for effective communication, and the customer also demands fair treatment from those providing services to him or her. And, of course, the customer is expecting a positive experience. Some will say the customer is now expecting a wow experience when they visit our hospitals. So that defines the kind of customer that we're talking about now in this day and age. Unlike before, when people didn't want to ask questions, they would just listen to whatever the doctor or the nurse says, take whatever service and how the service is delivered. They didn't used to question a lot of things before. Now it's different now. Whether you're in the public sector or in the private sector, they would have expectations. They have expectations, and they expect you to meet those expectations. Now, there is need, therefore, to understand and segment the customer, to have an understanding of who the healthcare customer is. And in order to better prepare oneself to approach things. Okay, there's need to understand the healthcare customer. So we have to look at the demographics of that customer. What are the different demographics that constitute the healthcare customer? What are the their clinical or health status? You can categorize or segment them along those lines. And then psychographics, and then you can talk about specific health needs that they have. So you can segment the healthcare customer along these various lines. Okay, so if you look at the demographics, you can, stratify healthcare workforce by age. You look at pediatrics patients. They are different from adults, so the services you give them will be different. Young adults, they need more preventive health care. Then, of course, the much older adults, the geriatric patients, they have more chronic conditions and they need long-term care. So as you think of your business, as you think about the kind of healthcare service you have to provide, you have to think along these lines. Who do I want to target? The young, the children, the young adults, or the older adults? Or do I want a mix? And why do I want a mix? Okay, then you think about the gender. Some you may just want to focus on women and issues related to women. Income and education of that customer has to be a thing of concern to you, the healthcare provider. There's no point in providing services that people cannot afford. Okay, then because it influences, their income influences how they procure healthcare services. Then, of course, their geographic location. If you are located in the urban center or rural center, how you approach your service delivery would be different. Okay. Next, you look at the clinical health status. Some are healthier individuals. They just need to have checkups versus those who have acute health care versus those who have chronic health conditions. So you have to be able to understand who you are trying to target along those lines. Or the risk level of all your patients, all your customers. Some you need to identify if they are high risk. Those of all of our insurance people, those HMOs, they understand this very well and they try to go after various segments. Sometimes they cut across, sometimes they try to target the very healthy ones or those who have less risk, So, and they try to market their insurance products to them. So, and we as healthcare providers should begin to think along those lines. We have to think deeply, what kind of customer do I want? Is this a likely person who will keep utilizing my services? Or will that be something positive for my business? Or will it be a negative for my business? If you keep targeting young people, for instance, and they don't get ill, you don't wish anybody to be unwell, don't get me wrong, but then it's still something you have to think about as a business owner. Specific needs, patients needing elective surgery, emergency care, long-term care. So what are their specific needs? Of course, the psychographic insights of those patients, understanding their lifestyle, their values, attitudes towards healthcare. Some people are much more health-seeking than others. Their preferences for how they want care to be delivered. Some people don't mind, being in open wards where you have 6 beds, 8 beds, 10 beds, depending. But others will tell you, no, I want my privacy. So who are you tailoring your services towards? Then, of course, service utilization patterns. Which healthcare services are most in demand? So as a healthcare provider, you have to begin to think along those lines. People are beginning to be more eating healthy, health conscious, preventive health is something that is becoming a sing-song. As a healthcare provider, as a private healthcare practitioner, I would want to start thinking along those lines. Can I do wellness clinics? Can I think about preventive healthcare services? And then how do I now begin to attract people, to come and patronize that service when I create it? Okay, then of course, very important to look into the feedback mechanisms. Feedback mechanisms from patients. So surveys, direct interviews, online reviews, it provides valuable insights. And when you get this information, there's so much more you can do with it. If you are into healthcare services provision, whether public, whether private, this is a very, very important tool that you have to deploy. Many of our public hospitals do this routinely. Every quarter, they invest in surveys and they get information from those surveys and use it to do capacity development, capacity building, to train all their staff to keep improving. So how much more private healthcare providers? How many of us are doing surveys for our patients? Yes, the ambience is nice. Yes, we've delivered a wow service according to us, but is that really what the patient wants? Is there something else they would rather have? We should be able to get, or did something go wrong along the line that we, the owners, are not aware? So with our surveys, we'll be able to know. Of course, the payer mix analysis of your class of patients, you have to be able to define. Okay, let's talk about competition a bit. Of course, competition in the layman test is a contest, is a rivalry between any two entities that are trying to get market share, fighting for the same products or services, similar target audience or customers and so on. So we see from this little definition that we are all in a marketplace and we are all in competition. Everybody sitting here, if you're a business owner, you are a private hospital owner, you are in competition with the next person right next to you, one way or another. And we need to be very conscious of that and be well aware of that. And because if we are not, we are likelier to lose market share. Other people will get ahead of us in providing those services, including the very many people that I will talk about very soon. And it will shock us because sometimes we may not be thinking about them. Competition in healthcare encourages health facilities to innovate. Where is this? Oh, please forgive me. I keep talking to my slide. So it allows people to innovate. And when you innovate, things will keep improving. That's what happens with competition. So competition in healthcare is not a bad thing. I think that's something very instructive that we need to take home here. It's not a bad thing. It works for everybody. It just means that overall, our healthcare delivery will improve, because the benefits, it will lead to lower prices ultimately, because if you are not competitive with your prices and your competition is, providing optimal service at, the right price, people will gravitate towards them. So you have to think about that. Of course, better quality of the services you are rendering. There will be differentiation in the services you are rendering. People will begin to be ingenious with how they deliver the service. And you'll see some examples. People will begin to add a few things to how they deliver the service. And it will make a lot of difference. Let's just consider the hotels. You go to some hotels, the way they serve you is different. The way their dining looks is different. And they might be the same category, but then there's just something different. In another place, they are really nonchalant. In another place, they are always smiling, always greeting you. They can greet you from 10 times in a day. And it makes a difference to customers. And that's why they keep coming. So some of this concept we have to understand. So product differentiation, market penetration and awareness is another benefit. People become more and more aware of what you do. Once you are aware that, I have other competitors around the corner, you have to do something, make your product, market it to other people, directly or indirectly. And that marketing part, I think we always confuse it when it comes to healthcare. That we can't market, we can't disseminate information. I think it's a big myth. Well, we have medical elders here, but there's so much going on now. There's so much going on now that I think those original old concepts we have to do something about, because people have already crossed that Rubicon. People have moved on. So if we are still here as a private medical practitioner and we are still having that concept, I can't advertise. Well, the world is leaving us behind indirectly. On our TVs, every day, you see adverts about healthcare. Every day. Every day. And I'll give examples. Okay, so ultimately there will be improved patient satisfaction. So to further dive into or analyze our competition, I think we can easily use something we are familiar with. Many of us are familiar with this SWOT analysis we always use. So it's just something simple to, use to help us out. But I'll make a little tweak of it because I won't follow the same order for a certain reason. Okay. So for the strengths, for private medical practitioners, there's operational efficiency that we all bring to the table. Operational efficiency. Because we are the ones who hired our staff, we are the ones who are paying their emoluments, their salaries. You are able to provide, what they should follow, what they should do, and they are likelier to comply. Also, many are smaller systems, smaller operations, so it's easier to monitor people. So the next is timeliness of services. It's another strength of private facilities. There's care continuum. There's tailoring of the services to meet the patient's needs. There's better ambience. Many offer a lot of hotelier kind of services. And then, of course, there are very many private healthcare facilities all over the state and all around the country. So anyone who wishes to go to a private hospital, before you go from your street to the next street, there will be one. Before you go 3 streets, there will be one healthcare facility close to you. So those are strengths for private healthcare practitioners. What are the weaknesses? There's this issue about one-man syndrome, which can lead to service disruption when that one man who is running that system is not available. And unfortunately, this has been an age-long problem. The previous speaker spoke about, succession planning and other business models that you can use to sustain your business and all that. This is something that I think we all need to think critically about for the sustainability of the business and the continuity of the business. And even while many of our private medical practitioners can't take a leave. They can't go on leave. You own the business, you are the owner, you are the one that hired everybody, but then you cannot step out to do other things. Some people will argue and say, if you have a business and you cannot, and the business cannot run if you are not there, then you are not a business owner, you are a worker of your business. You are an employee. So it's something for us to think about, Okay. Staff attrition continues to be a problem. It's affecting public hospitals. It's affecting private hospitals even more. It's a bane of our healthcare system in Nigeria, I believe in Africa in general. But because of our huge population, it's worse. You hire somebody today, within a short time, that person leaves. Doctors and nurses especially. There are even other healthcare staff that we don't seem to pay attention to. Sometimes radiographers you can't find. 5 minutes. Okay, I'll leave now. Reduced revenues, dwindling, inconsistent patronage, then limited access to capital. Because we are smaller operations, the financial institutions don't want to engage us. Because we are smaller operations. So these are weaknesses. Of course, because of all these problems, because we can't scale, and because we have attrition of staff and so on, patronage drops. When patronage drops, of course, we many times find it difficult to even maintain payroll. I have had the opportunity of meeting with some of our senior people who have opened hospitals many times. That the hospitals thrived back then, but they struggled to meet payroll right now for many reasons. So what are the threats? This is a very interesting slide that I want to juggle everybody's thinking. Public hospitals, of course, are a major threat. I'll show some pictures here. Because sometimes we may not even think about it. After all, is it not those same public hospitals that people used to die? Those same public hospitals that they will delay you before they give you service for a long time. They will treat you like trash. People don't like to go there, you know. That is a myth that is being debunked, that is changing by the day. By the day. And there are some people here that are the pioneers or the advocates or people pushing for that transformation and change of those public hospitals. So, public hospitals is one. The big private hospitals, of course, the bigger they are, the better they are at absorbing things and making changes. They are more robust. Of course, the expanding private primary healthcare centers, the tradomedical practitioners. Many times we used to deride them. They are TBAs, we call them, traditional birth attendants. They are not learned. They are not this and that. Well, they are getting better. And there are many more of them who have gone to school, who are fine-tuning and applying the knowledge they've gained, you know, adding the traditional knowledge that has been passed down from their forebears and refining things. Some of their centers are looking nicer and nicer. And some of them are going into other aspects, including medications and so on, pharmaceutical products that they are using to enhance their services. And one thing we cannot take away from them is that people believe in them. How do you explain to a woman that you should come and let's do normal 40 weeks, we'll deliver you, but the person is telling you, no, I have to go to the church clinic. I have to go to the mosque clinic. I have to go to the Baba in the corner because Essien Ekong is chasing me. Because I dreamt that they've told me that I will not deliver this baby. There's just no way you can convince that person otherwise. So it's high time we recognize them and integrate them. I think that would be the better approach. Then medical tourism, of course, people are leaving to go and get their healthcare services abroad. Diagnostic centers are a major competition. They are a major threat to your business. If you go to every major diagnostic center now, even the not so major ones, you will find that they have preventive health checks. The ones needed, the ones not needed. The ones relevant, the ones not relevant. They will run all the tests on the client, and then they have a doctor in the corner that will review it and prescribe something to that person. So, you know, and there's no control yet. Because now, the moment they do that, they've turned it into a what? Hospital. And they shouldn't be permitted to do that. But it is happening. And they are a major threat right now. So people will ask, why should I come to you in your private clinic, pay registration, pay for this and that, only for you to say, oh, go and do tests. Is that same center you send me to go and do the test anyway? And then I bring results back. Let me go there and do the test and then see their doctor in one corner. And that's partly why we're losing customers in our private hospitals. I mentioned the pharmacy chains. Some of them just give out medications pharmacists are turning themselves into prescribers and doctors indirectly. And they have a BP machine right at the corner. They have a glucometer right at the corner. And they say that one is free for the... In fact, you can just be driving on your way home, just branch in any pharmacy. And then, do your BP. And then walk out. Don't buy any drug there. Just enter, do BP, free, and go. Of course, if you did the BP and your BP is high, they say, buy Fensic now. Buy this now. You buy. So that's part of the competition. That person will choose not to even bother coming to the hospital. Okay. Home nurse services. This has been existing long time before now. Home nurse. Some of them are trained people, but many are the auxiliaries that work with some of us in our hospitals. They have their own corner in their homes, in their shops. They are running their own business. And they have this one-on-one with those patients. And they keep coming back. So they are a threat. Urgent care centers have not really taken foothold, but they are coming. They are going to happen in Nigeria. So we better start preparing for it. In fact, it's an opportunity for private medical practitioners to look into. Pharmaceutical companies, they are now making products that are direct to end user devices. So they don't need to come to the doctor. In fact, the thing takes as you are doing your blood sugar, is sending information to certain center, and then somebody is advising you via your phone. All those things are beginning to happen. Why should the person want to bother coming to see the doctor in the hospital? Wellness apps are on our phones. Different things happening there. Social media influencers. How many people remember Aproko Doctor? How many people know Aproko Doctor? Okay. He's doing a fantastic job helping to inform the public, debunk several myths, educate the public. But there are many others, different professions, those who are not even qualified in anything in healthcare, who are dishing out information on a daily basis. If you just look on your TikTok or your Instagram, every day you find information there from people, and they are talking like they know. Now, there are people who are paying attention to them, who are getting that information, and they don't bother going to the hospital. And if they now need healthcare by force, they will now contact those people to go and meet them and go and procure services. So these are threats. Dr. Google is there for everybody. Dr. Google. Everybody now has access to that. They already know the information before they come to you. They are arguing with you in your consulting room. Of course, AI is there. And then telemedicine. Telemedicine can be another aspect where private medical practitioners can look into to expand and change the whole landscape. But right now, it's a threat. It's a threat because there are groups, medical groups, doctor groups, healthcare groups abroad who want to give back to society, but they don't want to leave America or leave UK. So they just want to set up something and then be able to remotely provide consultation, provide healthcare services. And some people are beginning to set up businesses along those lines to take advantage and to get people to pay. So many of them is not even free anymore. Okay. So I just wanted to show some pictures about some of the threats. These pictures are from a public hospital in Lagos. Ladies and gentlemen, these pictures are from a public hospital here in Lagos. What you have to the upper left is a consulting room set up to see patients and is kept neat like this. To the upper right is a diagnostic set in every consulting room in that public hospital. Lagos State-owned public hospital. In every consulting room in that public hospital, it has this. We are talking about your competition as a private healthcare provider, private hospital, private clinic. This is major competition because while some of us have it, things like this in our hospitals, many do not. Now, think about that patient, that potential client. If he's aware of this one, will he come to you, the private hospital, or go to the public hospital where he will be cheaper? So competition. The picture to the lower picture is a waiting area. It's AC'd up, TVs in there, providing entertainment. Another one providing health education. There are 2 TVs in that waiting area that sits about 90 people. Next slide. In that same, okay. Can I get 5 more minutes? Okay. So in that same hospital, this is what they do to every new. 10 minutes. Okay, I can use 10. 10 minutes. I'm sorry. In that same hospital, they provide hot chocolate and biscuit to every new patient that shows up. In this Lagos, somebody says, am I sure? I'm very, very sure, sir. I'm very, very sure. 100%. If you go there today, you'll get it. I'm sure. They've been doing it for 3 years now. Every day. Public hospital in Lagos. This is ANC clinic in that same public hospital. This is a private lounge. There's something they call fast track clinic. It's a VIP clinic. When you come here, are you familiar with Lomara Jembe? Yes, because when you come in here, everything comes to you except radiology. They will bring the phlebotomies to you. After the doctor's consulting room is right next to you. You are not going to mix with everybody else. You come in here by appointment. You pay a little extra more, yes. You come in here by, as you are sitting, you have tea, coffee, water, malt, anything you want. In a public hospital. And then if you need radiology, they will chaperone you. There's a patient care coordination unit set up. They will chaperone you to that radiology and chaperone you back. When you get there, it will look on. They've been doing a Milocon in that hospital before Baba made it popular. Yes. Public hospital. That is your competition. And that's just one. Many things in many other public hospitals. Some you have heard about, some you haven't heard about. So it begins to juggle your thinking. Private rooms in there, Look at, what do they call? Patient monitor in that private room. Whatever, fridge, microwave, anything. Cupboard is there. And there are some bigger and better than this in looking, in how it looks. So they have this thing. This is a meal plan for that private room. It's an a la carte diet. A la carte, like what they give you in a restaurant. In that hospital, public hospital, that is your competition. So we have to put things in proper perspective. The frequency has changed. The public hospitals have raised the bar, and so the private hospitals must step up. They must go higher. Another meal plan. Okay, so the things to do. Identify both your direct and indirect competitions, service portfolio specialization. Those are things that you can begin to do. I will try to rush through it. Identify the pricing and payer contracts that your competition has. Those are things you have to look into to see where the gaps are that you can meet up with. Is there a gap in technology that they don't have? Things that should be happening that they don't have. That's how you begin to position yourself as a private practitioner now. And reputation and patient experience. How well are people perceiving those hospitals that are your competition? So whether public or private, that are around you, you have to analyze in this way. And then for the opportunities, the things that my own thoughts that private hospitals should begin to think about. Number one is begin to think about offering outpatient services only, rather than full-fledged hospital, because it's beginning to be more and more difficult to run those full-fledged hospitals, to turn on the lights, pay all the staff, but the patients are decreasing. So if I'm a specialist cardiologist, private practitioner, why don't I run my clinic? Let my patients know. Let them come to me. Then I have privileges in the big private or public hospitals. The public hospitals are getting better. So I can have a mix of patients. Those who are heavy hitters who have money, they come and consult me. Those who don't have that much, they still come and consult me. The ones that have a lot of money, I have privileges, contracts, MOUs with the big hospitals, the big private hospitals. And then I take those, my patients there when they need institutionalization. If they need to be admitted, I take them there. I can either do collecting the money directly from the patient, or they pay the hospital separately after paying me. Same thing for the not so affluent. They can go to the the public hospitals. I think it's something that we have to think about it differently. These things exist already in other parts of the world. Okay. Sorry. Strategic alliances, identify service gaps, invest in high demand specialties. So the things that people are not investing money in, telemedicine. I think I provided more information about it later. Specialized services, medical equipment, focus, change the business focus. There are so many areas in healthcare that private medical practitioners or providers can look into. Capacity development is one. There are many things we're doing that we're not well trained for. You can meet that gap. Rather than run clinical practice, you can choose to meet that gap. Then, of course, clinical research is another very important area that we've not paid so much attention to. Many other countries, even in Africa, benefit from this. They do a lot of these researches from pharmaceutical companies in those countries. They believe they are better organized. We can provide, a private medical practitioner can provide your facility as a clinical research site. And you will make money from there. So I just broke these things down. Those things I highlighted, and I'll just run through them. More details, the staff training. Okay. So, the benefits of clinical research. Other things to look into: QI, enhancing governance and transparency, talent retention, and so on. These are all other things that we need to pay attention to. And then have a first to 6 months plan, and then another 6 to 12 month plan on how to make changes, incorporating some of these ideas, and decide what you want to do, segment your customer, and then define your competition, and then decide how you want to approach it. But definitely something has to change in order for our public hospitals to survive. So the takeaways: it's the end of an era. A glorious era indeed, yes. But the era where small private healthcare providers thrived and proliferated, that era, unfortunately, is long gone in Nigeria. It's gone. We have to come to terms with that as private healthcare providers. We have to come to terms with that and pivot and change using some of these ideas and many others that I didn't mention here. Okay, so that we can compete better, so that we can take advantage of what's happening. Of course, there's public healthcare renaissance. Customer base is changing. And then it's important to scale. One of the things I talked about is alliances, partnerships. If I'm a cardiologist or a physician, internal medicine, if I have a pediatrician as a friend, we can get an OBGYN and then get a general surgeon. Rather than each one of us opening our different clinics, we can come together, get the lawyers involved, because it's important to do it right. Get the lawyers involved, get a bigger 60 to 100 bed facility to 150 beds. The bigger, the better, so that we can survive. And then we can even hire managers, people who will help us with management. We will focus on the clinical part. Those people will serve as the administrators. They will manage. And then legal entities will come into it so that nobody feels cheated, nobody feels... But then the resources will be pooled, and then we can also attract funding. Before, the banks used to say healthcare is not bankable. Now they've changed. Over the last 5 to 10 years, they've changed. They've been funding healthcare now. But they won't fund something that they feel is not viable. So if you are a single practitioner, they are not likely to listen to you. But if you come together, have a great business plan, they will provide the funding. And you can scale, you can expand, and then you can survive. The bigger you are, the better it is likely for you to survive in this upcoming market. Or you subspecialize in a focus area. Do the super specialist thing that we don't have right now. That is only you that can do it. You understand? The very super specialized care, if you are so trained, then you can focus on that. The people will still come to you because there's nobody else that has that. So this is just a summary of all the things I've said. I want to thank you for listening. Thank you so much.
Please, can we continuously appreciate Dr. Peter? Very fantastic. In fact, that lecture is meant to be, not to be a subset of a lecture. Thank you very much. We appreciate you. God bless you. Thank you. Lagos Business School, you can see that's the... Thank you very much. You have actually used all Dr. Faduyile's time. But before we call on Dr. Faduyile to come to the top table, we want to quickly announce that this vehicle, Camry, is actually obstructing movement for the last 30 minutes. SMK 507HY, Camry, SMK 507HY. During that presentation, we have in our midst Dr. Akin is now within the hospital. Can we put our hands together for Dr. Akin? And also, a very, very distinguished senior colleague, somebody that knows how it all started. I call him my boss, Dr. Leke Oshunoyi. Please, can we put our hands together for him? He's actually my boss. And again, a very distinguished personality, a friend from the College of Medicine all the way, a former CMD of FMC Ebutemeta, and now he has stepped higher. In fact, all what Dr. Peter actually presented here, he has actually implemented that. And that was how he brought clinical governance and administration completely into the public hospitals. Distinguished ladies and gentlemen, I have the singular honor to introduce another consultant orthopedic surgeon, Dr. Ademola Dada. You're very welcome to our midst. And of course, I was saying that somebody who have benefited, who have contributed, who have also produced a replica of himself as children, who has attained the level of a professor in medicine, is in our midst, is a distinguished medical practitioner and a very, very big brother is in our midst. And he's been with us since yesterday. Permit me to introduce Dr. Dako, DMP, please. I am going to be a little bit biased. I've been biased anyway, you don't know. I was biased when I was introducing my teacher. But I also have a mother in the house. She has been with us since yesterday. And I think she deserves recognition. Dr. R.I. Modile. Please, can you stand up for recognition, please? If I have wronged you at any point in time, that's the only person you can report me to in this association. Dr. Modile, you're welcome, ma. I think on these notes, I want to also recognize, and finally, Dr. Tunde Aliu. Dr. Tunde Aliu. These are founding fathers of the Surulere branch of this association. Very fantastic man. Thank you very much for coming. Dr. Gbenga Faduyile, you know the last speaker has actually exhausted your time, but we're going to bring you up so that we listen to you. I know you can speak without this time. Ladies and gentlemen, permit me to welcome on the podium Dr. Olugbenga Faduyile, the HR of Lashma. Please, can we continuously applaud him as he planned the program. Dr. Faduyile.
Okay. Good morning, distinguished ladies and gentlemen, senior colleagues in the practice. We're very glad that Lashma was invited for this program through Safe Care. So all protocols duly observed, please. I'm here to speak a little about health insurance because the world is moving towards that route now. Okay, I know that there are a lot of challenges in Nigeria as it currently stands, but I can guarantee you that that is the way to go, especially with the economic realities of the country that we are in. So I will talk briefly about how can we win patients back through health insurance. Many of us are concerned that our private paying patients are leaving and joining an HMO. So how can you get those patients to pick your hospital as their service provider? So we're talking about the challenges that we're facing. I'm sure that has been mentioned earlier, so I won't dwell on that. At Essien Ekong, what are we doing for providers? That is important for you to know. And now you can build trusts and then strategically purchasing stuff to reduce your costs. How you can grow your patient numbers and your revenue, strengthen your patient relationships, and then the conclusion. All right, so what are the challenges that are facing private hospitals? These have been discussed by the previous speaker, so I won't dwell on that. There are competitions from public and other private hospitals. Then patient expectations are increasing. You are seeing that patients want you to give them quality within the shortest possible time and at the most affordable rates. Succession challenges are also a problem. The first speaker mentioned that. We have a lot of private hospitals that close down when the owners retire without any succession plan. It's actually a tragedy when a hospital closes down because you don't only the staff there don't only lose their jobs, that community loses access to that particular healthcare facility. So succession is something that is big and we need to start thinking about it. Really, very, very important. Then there's a growing demand also for healthcare financing. How can I make my business continue to thrive while I continue to, make revenue? That is important. And then patients generally gravitate towards facilities that guarantee them value and gives them, trusts. So what do we do at Essien Ekong? For those that don't know us, because I know not everybody here is aware that the Lagos State has a social health insurance scheme that is called Essien Ekong, that is mandatory for all residents that live in these states. Whether you are employed or you are not employed, you are expected to subscribe to that particular social health insurance scheme. And it follows through the fact that there's a law that backs this, the Lagos State Health Scheme Law, and then the NHIA Act of 2022 as well also puts this into perspective. We expect providers through the social health insurance scheme to provide quality and affordable health care. That is basically what it does. So everybody has access to health care that is qualitative and also affordable to their pocket. Currently, we have about 287 private hospitals in our network. That's about 67% of the total number of hospitals that we have. That is excluding, dental and eye facts, because we have that as well, including diagnostic centers and pharmacies. So this is just private hospitals that are health facilities. In the last 12 months, 60 private hospitals have joined us. They've joined the scheme. We're still looking for more people to join. I would say that as we go. And then the goal is to expand coverage to everybody. Everybody. You don't have to wait till somebody comes to pay your services. The reality is that as things continue to show, less and less people are able to afford your services. That is the reality. Then, how can you provide quality services? Because the first thing is quality, what you provide. It is quality that gives trust to your patients and gives them the the confidence to pay for your services. Now, there's a Safe Care accreditation. Safe Care accreditation was created for resource-constrained countries like Nigeria. It allows you to be able to improve your hospital systems, improve the safety of the services you provide, and improve your patient experience as well. And we actually, as an agency, pay hospitals according to their quality services. So let's say I pay you 1 naira for a particular service. If you have a higher quality services, I'll pay you 30% or 50% more for the same service, even though all those hospitals are under our scheme. It is because we want people to strive towards quality provision of services. Then the next one is strategic purchasing. We complain about cost of medicines. Equipments are expensive. Drugs are expensive. There's no regulation of the drug markets. Today I buy paracetamol 1 naira. Tomorrow I go back, paracetamol is 10 naira. How do I maintain that? The reality is that costs cannot continue to rise to beat up with the services that you provide. It is impossible. So how do you now do that? There's a way through partnerships with manufacturers and distributors where you can do pool purchasing, negotiate products, and bring down the costs of the services that you provide. And Lashma is currently doing this. We are talking to a lot of drug manufacturers, talking to people that provide equipment, and we are trying to do strategic purchasing. Very soon, all our hospitals, let's say by December, we're going to be engaging our hospitals to let you know that this is what you have done. You will send us a requisition of the drugs that you need. We'll pass it across to them. They will supply you those drugs. And I can guarantee you at prices that you will not get anywhere else. Not in this Lagos, at least. That is a guarantee. And, we're already moving forward with that, and that will soon be done. By the time you have the cost of your drugs, the cost of your equipment lower than what you buy it with, then your services, the cost of your services will automatically reduce. All right, so this is what we're doing now. Then, in the scheme, if you join the scheme as a provider, I can mention health insurance. It's all about numbers, really. I know people will say, we always say insurance about numbers, but the cost that I treat malaria for 5,000, you are paying me 1 naira. That doesn't mean, it doesn't follow. The reality is that it's actually about numbers. There was, in 2023, I always say this story. In 2023, there was a particular provider that is under the Ilera Eco scheme that wanted to pull out because they felt that the number of patients they get and the cost of their services outweighs the amount that we're reimbursing them for. So I went to meet with their management team, and I said, I understand their concern, but the reality is that this thing takes time. Today, the population has increased from about 3,000 lives to about 18,000 lives, just within the space of 18 months. So I'm just trying to let you know how things can change. The revenue of that hospital now is not what it used to be. And I'm just speaking from my own angle. They still have their own private patients and other HMO patients. But from our own hand, that is exactly how it is. So we encourage our hospitals under the scheme to be a enrollment point. We have already mentioned that there's a law that backs the social health insurance scheme to be mandatory for all residents of Lagos states. From January, there's going to be enforcement because the governor has set up an enforcement or a task force that will be enforcing, which means that when you want to procure public services, you might need to provide evidence of social health insurance before you can access them. Now, being an enrollment center means when someone walks into your facility and the person is unable, the person does not have health insurance, you are able to allow the person to register in your hospital. So what happens is that, I always tell people, it's very simple. They will pay you for that service that they have come for since they are not enrolled. Then you, in the billing that you are giving them, you add the money for their enrollment into it. So as they're paying you, they're also paying you for their enrollment and leave. So when next they come, they're already enrolled. It's very easy. So it's not something you have to sit down and start discussing. You just put that bill in their postal bill. They pay it at once, and then they're enrolled. And for every hospital that is on our network as an enrollment center, they get a commission for every enrollment that is done. So the more people that you enroll, the more money you can make. There's actually the hospitals that actually make millions of naira per month from this thing. I can guarantee you that. And it's very easy for you. Then the next one is we have an arm of the agency that registers the vulnerables. It's not only people in Lagos that can afford to pay for health insurance. There are people that cannot afford it, truthfully speaking. And we ensure that no one is left behind by ensuring that they also get enrolled into the scheme. The arm responsible is our Eco-Social Alliance. That's Ikeja. They participate in community engagement. They're currently doing community engagements in the different areas, in Ibejuleki, in Makoko, different places. We always reach out to our providers to say that, are you willing to partner with these people? Because when we are registering the vulnerables, we register them under a hospital. We can register 3,000, 4,000, 5,000 in a day. And we have to register them under a hospital. So all the hospitals that participate, they are the hospitals whose names those people will appear on. So when we register them this month, by the time next month comes along, the money for those patients are paid to those hospitals that are registered. Okay, so more patients you enrolled, more money that you get. Now, part of the way that you can ensure that patients keep coming to you is that they have a way for them to complain to you about their experience at your facility. How were your services? Did they like it? Was this something they would like to tell somebody else or come back? Many hospitals do not have a complaint redress process where enrollees can come. Something as simple as a complaint box at your waiting area or your front desk can go a very long way. Let enrollees be able to tell you how their service was. How was your experience at the hospital? Was it good? Was it bad? Let them rate you. Because you might think that you are the best hospital, and enrollees, your patients will tell you that you are the worst. Let them tell you how you are, so you can, objectively know how you are doing in terms of the services that your patients are getting. Then, internal quality assurance units, there can be bias when you are trying to investigate your own self. So we always encourage hospitals to have their own internal quality assurance units that can be independent to objectively assess every complaint that they get and then give the management a report of what they have found. So when patients feel heard and they feel that their concerns are addressed, they will trust you and they will come back, because you need your patients to come back, really. So what's the final thing? Again, I keep telling people this. The poverty rate in Lagos is set to about 66%. What it means is that almost 7 out of 10 patients that come to your hospital will not be able to pay for your services. So how do you continue in business if 7 out of 10 patients cannot pay for your services? People will come in and beg you, doctor, please, after you have given them bill, they will tell you to give discounts. They will tell you to please waive some money. You have overheads. You have to pay salaries, isn't it? There are so many things you have to do. There's power. There are so many things you are doing with your money. How do you continue without health insurance? Health insurance ensures that every patient that steps into your facility will be able to pay for most, if not all, of the services that you are providing. That guarantees a stream of income. So even though there are issues with health insurance, it is the only way we can go. Especially now that disposable income is beginning to erode. People are becoming poorer every day. How can they? Health is a right. People fall ill every day. How will they be able to pay for services? So to ensure that hospitals continue and remain in business, then this is where health insurance comes in. So we are calling everybody to embrace it. Now, there are issues. There is nowhere in the world where currently you can say, oh, they have a fantastic health insurance scheme, that there were no issues at the beginning. Dialogue and stakeholder engagement is how we can progress. We discuss, we find a way forward, we take the action, and we move on. That is usually how it works. It's always about how much money you are making, because that's always the bottom line. How much money am I making? Conversations and certain actions can help us to resolve that. So what we are saying now is that to win back your patients, hospitals must deliver quality services. Let us key into the safe care accreditation. Like I said, it is made for resource-constrained countries like Nigeria. Okay? Let us... Lashman also does their own internal quality accreditation outside safe care, because we took the safe care tool and adapted it to our own. For every hospital that we sign on, we always take them through a quality accreditation that helps you to fulfill some level of safe care accreditation. It is what we do. You have to engage communities through the Ikeja arm, because vulnerable people are a constant stream of income, and there are many. Like I said, we generally enroll like 5,000 a day. Now imagine if you are getting 5,000 every 3 months. That's a lot of people. All right? And then through Lashma, like I mentioned, the strategic purchasing, we're already working on that, bringing down the cost of drugs, cost of equipment, to ensure that the services you provide are cost effective, and then your bottom line is still a lot. So we're saying that we are encouraging everybody to know that health insurance has come to stay. It is the only way we as healthcare providers can continue to provide the services that we provide and make money doing so and continue to be in business. Because, you can't always depend on out-of-pocket payments. It's just not sustainable. So making sure the scheme grows, improving on the laxities of the scheme is what will ensure that we also benefit from it. So thank you very much.
Two applause we are going to give to him for that very beautiful presentation and timely. Thank you very much, Dr. Faduyile. And of course, Peggy Imoniovu is going to speak to us on quality. Thank you very much, Dr. Peggy.
Thank you so much. Good morning, distinguished ladies and gentlemen. Permit me to stand on already established protocols. My name is Peggy Imoniovu. I work as a program manager for Safe Care Farm Access. It is my singular honor to be here in the midst of greatness. I am here to do very easy work, to sort of make sense out of everything that has been said so far and appeal to our consciences to see why quality is very important in healthcare. Okay, while that is coming up, I just wanted to ask, by show of hands, please, who amongst us here believe that patients are harder to please now compared to before? Do you agree? Show of hands, please. Great. I don't even know who gave them the name patients. They are probably the most impatient humans. The same people who will queue for US visa for hours and be denied are the same people who want to see the doctor in 5 minutes and get all of the treatment. Regardless, we need to meet them at the points they want to be met, and we need to do what we have to do. Next slide, please. Oh, I have this. Aha. Okay. So we always talk about universal health coverage, but we cannot achieve this if we are not considering quality. So quality is everyone's business, and it's something that we must do. So how do we even go about this? Before we even talk about how to achieve quality, it has been said several times that there's a lot of competition. It is real. The harsh reality of competition cannot be overemphasized, which is why I am presenting it again. So we have the government facilities that are in quotes cheaper. I put cheap in quotes because I'd rather consider it affordable than cheaper. You have the pharmacies for convenience where patients can just leave their homes and go get medications and treat themselves. And you also even have, whether we appreciate it or not, we are competing against quacks that for some reason the patients sort of even trust better than us. So we have a lot of work to do as healthcare providers. Now, when patients shop for healthcare, they're considering a number of things. But some of the ones I want us to remember today is that, one, they are checking for affordability. In the midst of that affordability, they want quality, they want safety, and they want convenience. All of these are dimensions of quality, so we must ask ourselves, are we providing this for our patients? Do our patients consider us affordable? Do they think that we provide quality care? Are we convenient when it comes to their quest for healthcare? Now, there is this myth that quality is a luxury. I'm not sure how that came to be, but it is not true. It is a right, especially if you are talking about Nigerians. We like good things. If you are standing here where I am today or this morning, you will know that Nigerians like good things because what the gentlemen and ladies before me look so beautiful, nicely dressed. And then these are the people you want to give poor quality care. It's not going to happen. So we must put all of that into consideration. And then there's the perception that I'm too old. Some of the MDs are in their 50s, or even in their 60s, and maybe even slightly older, and are thinking it's already too late to do anything when it comes to quality or succession. But it is not true. We have real examples in this world to tell us that life probably begins at 60. Now, Colonel Sanders, the founder of KFC, started KFC in his 60s. But KFC is here today. Aliko Dangote, my personal best friend, right? Anytime you see him, say Peggy says hi. You'll be amazed. You'll be amazed. Don't look at me less. You'll be amazed. He started his refineries in his 60s. That's to tell you there is still time. As long as you have life, there is always time for you to do better and for you to improve, if improvement is what you desire. So then how do we do all of these improvements? And what is this quality that they always talk about? Luckily for you, you have an organization called Safe Care. It's a quality improvement methodology. These days, we like to see ourselves like a movement. And we were born in 2011 for several reasons. For us, we believe that everyone should get quality and affordable care, regardless of where they live, who they know, their association, their creed, and so on and so forth. So when we were born in 2011 by three organizations, Farm Access Foundation, COSASA, and JCI. Does anybody here know COSASA? Does anybody know JCI? Yes. Does anyone know Farm Access? Great. So these three organizations came together to birth the Safe Care standards, to bridge a gap, a quality gap that was obvious that we needed to bridge. Now, we've been in existence for about 14 years. Our standards are designed for resource-poor settings, and this resource poorness could be as a result of even lack of knowledge, not necessarily lack of funds, could even be lack of manpower. So the standards, even though we say they are designed for resource-poor settings, have not been watered down. They are international standards. The only difference is in achieving these standards, in achieving compliance with these standards, we allow for local solutions, which is why our slogan is international standards, local solutions. So please bear in mind that the Safe Care standards are not watered down. They're international standards, but allow for achieving them using local solutions. So we are currently in over 24 countries, including Africa, the Middle East, and India. We have offices in Ghana, Kenya, Tanzania, Nigeria. Our head office is in Amsterdam, and very recently we opened an office in India. We have well over 35 partners, private and public, put together. We've conducted over 9,000 hospital assessments since our inception. And if you count the patient visits of the facilities where we are active, we record a minimum 8.3 million patient visits. So you can see that our coverage is far. So what then are these standards? The Safe Care standards look at both medical and non-medical performance of the hospital. So unlike other standards that just focus on clinical aspects, we do beyond that to look at your non-clinical aspects, because let's face it, if you focus only on the clinical aspects and ignore the non-clinical aspects, it's only a matter of time before the non-clinical aspects affect the goodness and all of the good work that you are doing in the clinical aspects. So our standards break your hospital into 13 areas. In fact, our assessments start from the street leading to your hospital up onto your waist point. So we look at governance and management of your hospital. We look at human resources. We look at patients' rights and their access to care. We look at management of information. We also look at risk management, where most hospitals perform the least. And you can almost understand why. No one really teaches you about risk in your medical school or in your nursing training and so on. And then we also look at your outpatient service, which is the core of every hospital's business. If you offer inpatient care, we look at your inpatient service. We also look at surgery and anesthesia. We look at your laboratory service if you offer. We look at your diagnostic imaging service, so your X-ray, your ultrasound, your CT if you have, your MRI and PET scans. And then we look at your medication management, which some people argue is the money bringer in every hospital. And then we also look at your facility management, so your building, your environment, and your machines. And lastly, we look at support service. So if you offer food service, we look at your kitchen and how you organize food. We also look at your laundry, and then we look at cleaning. So you see that the Safe Care standard is really holistic and not just focusing on only the clinical aspect of healthcare. So how do we support you? We come to your facility after we've had an understanding and agreements and contracts are signed, and then we apply the safe care standards, and then we measure your compliance against those standards. And based on your performance, a quality improvement plan is developed, direct and unique for you. So no two facilities will have the same quality improvement plan. So your quality improvement plans are specific to your gaps, and then we give you a period to work on those quality improvement plans, all the while holding your hands through this process, and then come back for another assessment, maybe after 1 year, to see what has improved, and then the process continues. Throughout the hand-holding period, you can have support in different ways, training, mentorship, and so on. And of course, you get a certificate to indicate your quality level, which is where we're going. So at Safe Care, we have 5 quality levels. We have level 1, which is the weakest level. At this point, we consider you to be offering very modest care. In fact, the only thing you need to come on a Safe Care level 1 is that you have a pharma license, if you are a Lagos facility, or if you're another state, you have the license to practice as a hospital. So when you get a Safe Care level 1 certificate, you just know that you are just starting and there's a lot of work that needs to be done quality-wise. After that, we have Safe Care level 2, where you are slightly better than the facility on a level 1, but there's still a lot of variance and there's still a lot of quality gaps. At level 3, you are now working towards offering good quality care, but there's some variance still, but better than the facility on a level 2, in that you have started setting up systems and processes for continuous quality improvement, I beg your pardon, but there is still room for practice. At level 4, quality is almost maybe 80% a culture in your facility. So systems have been embedded, SOPs are in place, and staff are using them. Staff can talk about the SOPs, but there is still some work to be done. At level 5, you're considered to be offering excellent quality care, in that in fact, anywhere you are in the world, you know that your facility is doing well, whether you are there or not. So audits are happening even before organizations like Safe Care or COSASA come to you. By yourself, you are self-auditing systems and processes to see what is working, to see what needs to change and what needs to improve. In Nigeria currently, we only have 2 level 5 facilities. And it's a shame because Nigeria, we know they carry last. But now for quality, for some reason, we're taking last, but I'm confident that this story will change very soon. But regardless, we are happy that the first Safe Care level 5 facility in the world came from Lagos, Nigeria. However, clap, it's not easy. However, we've been stuck at 2 level 5 facilities for the longest time. So we encourage and we're appealing that please, we need to work to get more facilities on a level 5 so that we as hospital owners are even confident to access care in our own facilities and not go somewhere else because we are afraid of the care that we may receive in our own facilities. So why quality? Because that's the question we get asked many times when we approach facilities. What is in it for me? It's simple. What is in it for you when there is absence of quality? I usually like to say, if you think safety is expensive, try accident. If you think that quality is not expensive, it's not relevant, take out quality and see what happens. The reason why today we are comfortable flying, getting on planes and flying and going to different destinations, because somewhere in our minds, we are sure that someone has done something to ensure that there's quality and not just any mechanic going on into the cockpit to start the plane and fly the plane. So we must always ask ourselves, if other sectors are doing all of this, why are we allowing something different in the healthcare space? Why are we employing quacks and empowering them? Why are we letting all of this happen? If you were to go to Abuja this evening and you see the pilots shaking hands and the pilot is your vulcanizer, would you still fly that plane? So why then are we employing male nurses and calling them doctors and empowering them? No disrespect to the nurses. By all means, I'm a nurse, but I'm just saying, just so anyone is offended. I didn't mean any harm, but I'm just passing a message. We need to do what is right, and we need to do better as a healthcare industry. But don't take my word for it when it comes to what the benefits are for quality. I have taken a screenshot of a case study. This is real. And in fact, it gladdens my heart to say that the MD of this facility is in our midst looking at me smiling. I'm not going to call your name, sir. But this is to show that there is a connection between quality improvement and profitability. If you quickly look at this slide before us, you can see the progression in percentage for different years for this facility, starting from when there was no quality improvement at this facility up until they adopted the safe care quality improvement and have started working. In fact, I'm not even going to go into the story of FMC Ebutemeta. That's a horse that has been overflogged. We all know the profitability and how he shot 800%. If I were you, I would sit beside Dr. Adedamola Dada, hold his garments, so tell him to show you the way, so that we can all have that much percentage in profitability. Thank you so much, sir. So what is the take home? We need to change. The healthcare industry in Nigeria, we are slacking. We are behind. The hospitality industry is going in leaps and bounds. You see the restaurants in Lagos, don't you? There's no restaurant. Well, there are many restaurants in Lagos that can rival some of the best restaurants in the world. It's because people are deliberate and are conscious about quality. We need to do the same for the healthcare space. So we need to find and align with quality improvement systems and methodologies that can help us be better. Hopefully you do that with Safe Care. We have partners. In fact, some of us may have been approached by one of our licensed partners, Dr. Femi Oguremi, the MD of Monitor Health Care Limited. Please, when it comes to you, listen to him. He's not a fake. He's one of us. He's our licensed partner. And see how you can partner with him to improve on your services so that we can eat off the pie, the national pie of quality in healthcare in Nigeria. We're hoping that this, 14 minutes of my presentation has appealed to you to look inwards and see how you can partner with healthcare organizations and quality organizations that are focused and are concerned about quality. Because at the end of the day, we talk about succession, we talk about legacy, but legacy is not a building, right? Legacy is the lives you touch, the number of lives you touch. It's the business that tries whether you are there or not. And one thing quality will do for you is help you build trust. And trust equals more patience. And more patience equals more money. And more money is profitability. So in conclusion, quality is not, there's no destination. It's a journey. There is no end. In fact, the only time you know about your journey in quality is when you enter. You never know when you get to the end because there's no end. Even the facilities that have COSASA and JCI today are still working on their quality improvement initiatives and activities to ensure that they remain where they want to be quality-wise. Thank you so much.
I'm just behind you. Okay, thank you. Please, can we put our hands together again for this beautiful damsel, Peggy? Thank you very much for that. There are two things she said that we do not intend to keep because it's our pride. And he said he's not going to expose that level of quality. He's our member. We need to popularize it. And that is no any other person or no any other hospital than Shubor. There's a Shubor. Please, can we put together our hands for Dr. Bello? Dr. Bello is within us. Please, can you stand up for recognition, please? Thank you very, very, very much. We are proud of you, and we need more of our members to be in the process. And the person to lead it is seated right here with us because we need to scale up our services. The second thing I'm going to also respond to before I call on the next speaker, who is going to round up the business class, is this consultant orthopedic surgeon that is with us, is a member of the panel, is still coming to sit down here, transformed FMC. transformed FMC. And I'm glad that I'm confirming today that it's 80% income transformation. We are very, very, very proud of him. Dr. Dada Adedayo, please, can you stand up again for recognition, please? We're proud of you and we continue to be. But the most important thing is that he is listening, but the brain, my thoughts, the brain behind it is another Dada, but this time not Adedayo, but Dr. Mrs. Ibirunke Dada. I think it's very, very, very important to recognize that when I'm still going to recognize Dada, but she's been a very beautiful wife for us, and we appreciate her for that. Please, can we put our hands once together for Dr. Ibirunke Dada? Thank you very much. And on that note, I want to call on Architect Oluwatobi Aderoju Oluwa. Yes, architect. One will be wondering what is an architect coming to do in a scientific section. But I can tell you, if there is an accident in your facility, you bear the legal consequence. And it's going to tell us how that can be improved. Architect Rotimi, thank you very much.
Okay, good afternoon, everyone. I would like to, it's my pleasure to be here. Good afternoon to the distinguished ladies and gentlemen here. Please permit me to stand on all existing protocols. And like you said, an architect in the midst of professionals. It's my pleasure to be here today to be able to discuss. And I have learned a lot. And again, Oluwatobi Adedayo, I am the principal architect of Nest Spaces Limited. It's a design, construction, and development firm. And what we are very passionate about is how we reimagine spaces. Because we believe that space is a place for wellness, is a place for care, is a place for trust, and is a place for engagement. And within the context of what the space is designed for, it can be designed to benefit whatever context it is meant for. So I'm here today to discuss about investing in hospital design and aesthetics as a competitive advantage. So is a hospital design a luxury? First, we have to look at design in itself. When you're looking at the entire design team, you have your architects, you have your structural engineer, you have your mechanical, you have your electrical engineer. They are all involved in the entire design process. So, for example, let's take, most of the time when people say design, everybody's always thinking about an architect, but he has other consultants that he works with to ensure that the space is fit for purpose. Take, for example, this hall. You can see that, yes, the architect did the design, but you can see that there are no columns in between the building. If we had columns here, it is going to obstruct view, it's going to obstruct circulation, it's going to obstruct movement of people. And this design was not done by the architect. It was done by the structural engineer. And I can see that everyone is sitting here comfortably. We are all having comfort. Nobody is feeling too hot. Nobody is feeling too cold. That was done by the mechanical engineer. And if you could look at the lighting system of the space, if you want to take a book and read, you can see properly and read properly. That was designed along with the electrical engineer. So when you talk about design, it's not just about, pretty pictures and the building looking good. There's a functionality part of it that is really important to ensure that the space is designed and is fit for purpose. And when we are talking about, a competitive advantage, it means you are taking it a step further. And there's this saying that nature heals. And as a practitioner, you would ensure that you make sure you use all of the different things that can help in the healing process and the patient experience to work in your hospital building. The reason why I'm saying is that you can look at, even to the extent of landscape architecture, ensuring that there is green space from the outdoor to the indoor and the flow. It helps in the healing process. So, taking taking a look at it, as other people who have said, today the space is very competitive. I've been opportune to be involved in the design and construction in some of the public institutions like FMC, like LUT. We were involved in things like a 120-bed maternity ward. I was involved in the design and construction of a medical lab. So I have seen how these things play out and how they impact. It means how they impact. And you see that they are also, as they mentioned, the public sector is also increasing in their service delivery. And they are offering better care. So how do you, as a private practitioner, compete with them? In the competition brackets, you now have technology that has been put into that bracket. Today, if a patient is feeling sick or having some symptoms, the first thing he goes to is ChatGPT to type what is there and to be able to self-medicate. That's a competition for you. Another competition too is your AI, because from anywhere, there are some apps. If you look at NeuroCare, with some apps, you can begin to seek medical advice, and at any part of the world, you can engage that. You're also looking at virtual care. That means somebody in Brazil, somebody in Netherlands, somebody in Germany can engage your own patients and begin to speak with them. So the thing is, how do you compete? What is your own competitive advantage as a person? Hospital services is requesting more than just having competent doctors and good equipment. It's a lot more than that. You have to look at what is the next step of ensuring that your hospital has patients and is profitable. One thing that is becoming very, very prominent, not just only in the medical sector, but in all other sectors, is user experience. Because even from other commercial buildings that we have designed and executed, you can see that user experience is at the heart of it all. If you go to some banks, they have experience centers where you can self-service. You go in there, you type in, you can register, you can create a new bank account, you can pay in cash, you can do some certain things by yourself. But that entity was just designed to ensure there's better quality, there's better speed of service. And in the heart of it all, as a hospital, it's the patient that you are giving service to. So the patient, our design approach from the doctor and also to the architect is to be patient-centric. What does the patient need? What does the patient require? And most of the time, the relationship between a hospital and a patient is a business relationship. And that relationship has to be catered to be able to build that relationship. And most of the time, what's the most impactful thing about a relationship? It is how the person makes me feel. It is how I've been able to engage with the person and how I feel when I'm with the person, when the person is around me. So the question is, looking at it from a design perspective, how does your hospital make people feel? So 2 days or 3 days ago, I was at the hospital and I got a phone call from someone. And I told them that, I am at the hospital. The first reaction was like, I hope everything is well. I hope everything is. So from there, you could see the psychology of when somebody hears hospital and what is the experience for them. How do they engage? And how is your hospital able to respond to it? Because a hospital is actually a place of giving hope for healing and for wellness. But you need to understand the condition, the psychology of the patient as he's walking through the door. Now, the reason why we are going this route is to be able to, we are talking about you being competitive and you having a competitive advantage. So you need to understand, one of the presenters mentioned before, is that you know your customer. By the time you know your customer, you can begin to understand the psychology of your customer. Most of the time, hospitals get their patients too late. Too late in the sense that they come for care at a very later stage when, the healthcare issue has gone too far. So at what state of mind is that person in? That person is probably has anxiety. That person probably has stress. The person is probably worried about too many things. And is worried that, is the care that is going to be given to me, is it going to work? So they need hope. So how does your building respond to the psychology of the patient that is walking through your door. And all of this happens right from your exterior. All of this happens right from your exterior. During the process of the construction of your hospital, people are already forming opinions about your hospital. Even from the way it is being built, if it is being built poorly, if it's being built well, people are already forming opinions about it. And even if you have an already established hospital, like many of you have here, people are already making opinions about your hospital. Recently, about 8 months ago, I was driving around with my wife trying to look for a hospital for maternity care. And there were some hospitals that immediately we got to the reception, what we said was that, we will come back, we want to get to the car. And right from there, we turned and we never returned. So before we even saw a medical practitioner, we already made a decision. Most of you don't know how many patients you have lost or you have gained just because the way your hospital is set up. And from the exterior, people are already making impressions about it. So that is very, very important. And when I was doing my research for this presentation, they said one of the key things for hospital as regarding access, because access is very important. When you say access, people will talk about, okay, you need to have a ramp, you need to be able to move people, you're talking about your elevator to move from one floor to the other. But from research, they said the most critical issue concerning access was your car park. Right from your gate, your car park. So you have a situation where, again, patient psychology. I already have anxiety, I'm already feeling stressed, and I am coming into your car park and I can't even park properly. To come out of the door is an issue. Maybe the patient has a challenge and cannot even come down from the car properly. Then there's not enough car park. Then emergency is coming in. Then services is also coming in. And there's a lot of chaos within your car park area. What have you done? You've increased the stress level of that patient. So all of these little things matter in the delivery of service to your patients. And how can you solve that? That can be solved through design. So, again, a hospital is a business. And when you're talking about, when you look at it from a business perspective, I think me as an architect, so we have that same challenge to be able to cut the divide between business and profession. You know, sometimes it's complicated wearing both hats. But when you begin to look at it as a business, you begin to put certain things in place. Branding for a hospital is very, very important. As I was saying before, your hospital can speak along the road, along your community, and along your neighborhood. But branding can go places without a visa. It can go to all, even outside of the country. And thankfully today, you have a lot of people who are coming into Nigeria for healthcare services. If from some of my friends that I spoke with, December period, you have a lot of people who are even coming in for dental care. There are people who are coming in for quality healthcare because, one, it is affordable for them and it is quick. So yes, there's increasing competition, but there's also increasing demand. But how does this apply to you? It applies to you to say, how are you competitive and how are you able to take advantage of it? One of the ways to do that is branding. And branding is more purposeful for you when your building is speaking the same language of your brand. What is your brand communicating? And what is your building communicating? If maybe on social media or somewhere I saw your brand, I saw your flyer, I read about your hospital, then I come to your hospital, then what you have put on your brand, on your branding and your hospital are totally at par. What is it that you have done? You have cut trust with me. Because brand is saying, I'll do what I say and I'll say what I can do. But if I see your flyer, I see it presented well, and I see your services, and I come to your hospital, and your hospital building is even delivering far more than you have put on your brand, you have built trust with me. I would say that this hospital, whatever they say they are going to do, is what they will follow through and do. So branding is very, important. And there needs to be a harmony between your branding and your hospital to ensure that there is improved service delivery there. So let us try and touch base with branding. If you are saying efficiency is your branding, what is that going to look like? It means that when I walk into your building, the car parking is clearly laid out. Once I come in, access is clearly defined into your building. I should be able to move from point A to point B within your hospital without necessarily being assisted by a healthcare personnel. I should be able to know where the reception is. I should be able to know where the lounge is. I should be able to know where the consulting room is, where the visitor's toilet is. And that is done through design. So that's efficiency. Sometimes you can even color code to say, oh, follow the red line within my hospital building. It will lead you to the consulting room. Follow the black line. It will lead you to the toilet. So design can help in solving this problem. If your hospital brand value is care, how does that translate to a building design? First thing, as you're coming in, when it's care, you could have automated doors. So as the person is coming in, the door opens for the person and he goes in. When he goes to your lounge, he has very comfortable chairs to sit down and wait. He probably has a TV on. He has good lighting. He has good ambience. He has good paintings on the wall. That is showing care. So brands can really translate into your building. Sorry, I don't know what's happening to you. Okay. So now when you're talking about hospital design, it's not only about the patient, because you have a support system around delivering services to the patient. One thing you need to take about is also talk about your staff personnel. And you have that in two categories. You have your admin staff and you have your nurses, you have your doctors and your medical practitioners. Again, from the flow of if I'm designing a ward, the position of your nurses station is very, very important so that the person has a good view to be able to see and respond to any patient that is having any issues. But just imagine if the nurse's room is on the ground floor and you have the ward maybe on the second floor. Before the person even gets up or thinks to go to that place to attend to the patient, the person is already defeated physically because he's thinking about the journey at which he would take to that space. But in designing and doing your layout, you need to understand properly the connection of the different spaces. You need to know what room needs to be close to the next one and how the spaces flow. And from research, a good hospital layout would save a nurse about 10 to 15 minutes every hour. And if that nurse is doing a 12-hour round, that comes to about 10 to 12 hours daily of working saved for that particular nurse. So she's able to conserve energy. She's able to administer care to the patient. And what does that do over a long period of time? It improves service delivery and it builds loyalty with your patient. What it also does is that it ensures that you retain your staff, because these days, it's very, very hard to retain staff, even in other businesses. Talk less of, where nurses and doctors are hotcakes now in Nigeria. So retaining them is a very big issue, and making them comfortable, ensuring that they have proper changing room, ensuring that they have a proper lunch room, even their breakout rooms, make sure it is designed properly and let them feel comfortable to be able to improve a higher retention of your staff. The other part that, we also need to take note of is that the caregivers who come with the patients are also important. In some cases, it's the caregiver that decides the hospital that the patient is going to. If a child is going to a hospital, it's the parents that decide where the child is going to. If an aged parent is going to a hospital, it's the children that decides where the patient is going to. So you also need to give care to the person who is bringing the patient. You need to make the person feel comfortable and relaxed because he can impact the patient coming back to your hospital. If he doesn't feel comfortable, he will look for the next hospital that he will feel comfortable in. So we need to pay attention to the patient. We need to pay attention to the caregiver. We also need to pay attention to the hospital staff. So after speaking all of this, what does it come down to? It comes down to Naira and Kobo. And we understand that, in the hospital, funds, you have a very tight budget. And so the question is, how are you able to manage this budget to be able to achieve all of this and to improve patient loyalty and trust in your hospital? What I would recommend is to have an idea of who your target market is, know who your customer is, and understand their psychology. Because you have limited resources, so make sure that 1 naira will count for you. Because if you diagnose your customer wrongly and you don't understand his psychology and you spend on something that does not connect to his psychology, that means it's wasted money that has been spent. But if you engage a professional, an architect, and his consultant team, they are able to help you manage that process. One of my experiences in the design and construction process of one of the medical projects I was on is the engagement of the architect. When you are coming out with a design brief for the architect, you must ensure that the hospital management engages the different departments in that process. Even if it's a small thing as renovation, updating the space, there needs to be that engagement. One of the projects I was on, which was a medical lab, we had already gone maybe 50% into the construction. And that's when some of the head of the departments knew that there was a renovation going on at that medical lab. And in that process, a medical lab, you must follow a process, you must follow a layout. And at that point, that's where they began to make changes. Some of the changes we could accommodate them, some of them we couldn't. And they will now have to live with that till the next time they want to do another renovation. So the hospital management, the admin staff, and the doctors, they need to come together in coming up with that brief, understanding their brand, understanding their customer, and understanding their psychology. And in that process, engage with the architect. Then you need to ask the pertinent questions to your design professionals. How will your design improve efficiency in my hospital? How will your design bring in more customers? How will your design ensure that my staff will feel comfortable in the hospital? How is your design going to retain staff for me? In asking those questions, it stimulates the creative ability of your design professionals to put it to use. And yes, architects can actually design this. All you need to do is to push them and to ask them to answer these questions. So again, return on investment. If you're investing in your hospital business, the way investment works is that you put in money today and you have to let it lay out before you begin to see return on investment. And the issue about design is that for your hospital, if you engage a professional, you get the benefits of engaging a professional. It is an upfront cost, which is high, I agree, but you need to look at the cost of engaging a professional throughout the entire life cycle of that hospital. When a hospital is built, it's supposed to last for 50 to about 100 years. So if you spread that cost of design over 50 to 100 years, you will see that the cost is not much. But if you look, and what it does is that it even helps the performance of your healthcare services. It improves patient loyalty, it helps you to retain staff, and it helps you to save cost, because design can help in saving cost. In terms of power, in terms of energy, design can help you to control that. But if you don't do that, the cost of not engaging a design professional is very difficult, because number one, the patient doesn't feel good in your hospital, your staff would not also feel good. And if your staff doesn't feel good, it will impact on the care that is going to give to your patient. And some buildings poorly done, you as a medical practitioner, you now become an engineer and an interior decorator. You begin to maintain what is bad. You are trying to update your building. And sometimes renovation can be far more expensive than even building from scratch. So the value of using an architect outweighs the benefit of, doing it yourself. Over the long run, I assure you that you will get return on your investment for your hospital. So yes. Okay, I've spoken about this. Where do you begin? So where you begin is getting an architect, putting down to paper and articulating properly what you want to achieve, what your brand is, know your customers, detailing it out so that the design can fit into what your brand is, what your plan is, and the healthcare you want to give. And I'm sure many of you are looking at, how do I fit into this? Because most people have their hospital buildings up and running. It's not a new build. And some of us didn't build, we are remodeling our existing structures to use as a hospital. It was not purpose-built. So you're asking the question, how does this connect to me with an existing building? There are simple things that you can go about it. You can call in an architect. Let him take a whole scope of what your facility is like. Let him understand what you want to achieve. And let him come up with a design plan for it. For some of you who have your hospital buildings already existing, you can even call in an interior designer to say, this space, I want it to feel more welcoming. I want it to feel more inviting. I want to allay people's fear and stress. Immediately they come into my reception. How are you going to design my space to ensure that it gives comfort, it gives trust, and it gives hope to people, even before we begin to engage them? So it might have to do with painting on the wall, putting some painting on the wall, putting in some decor elements. Sometimes background music in your reception space can be a calming effect to be able to even allow patients to stay longer. Sometimes they have to wait 30, 45 minutes. But with background music, with good painting, with good artwork, with even air fragrance, a nice smell in your hospital can allay fears for them and reduce the psychology of wait time in your reception. So you can engage in an interior decorator to help you out. And you can take it from there. And the other part is that you can also phase your renovation. Ensure that you look at spaces that are patient-facing. What is the first thing that your patient sees? Those are the places you should pay attention to. And you can phase out your renovation. For it can be a 1-year plan, 2-year plan, 3-year plan. But you start with areas would have the higher impact. What area is going to give you an 80% impact? So from the layout to the entrance, those are areas you can focus on to improve on your hospital building. Okay, so in today's competitive healthcare market, patients are not only choosing doctors, they are choosing experiences. And that experience begins with your building. Thank you.
Honestly, because come, doctor. I don't feel like allowing him to go. 1, is soft-spoken. 2, he knows, prepare 10 slides to hit the point. And I think he has passed a message to us. For those of us that are looking forward to starting a specialized services, cancer centers, the architect is needed. Please, can we please put a very loud applause for him again? Thank you very much. We really appreciate you. God bless you. Of course, he's too handsome not to be... I won't say that. Distinguished ladies and gentlemen, this is where we're at. That's the last lecture for the business class. And the essence of that lecture is to expose us to some things that can change in our facility. Yes, like he said, it's coming with something, and that is money. That money, we are spreading it over a period of time before we allow more resources or income to come in. Please let us start thinking about it. Quickly, I want to announce that this vehicle has been disturbing a lot of people in the last 30 minutes. KSF 7976HX. KSF 976HF. It's a white RAV4. Please, kindly repark. And again, I want to quickly recognize that while that lecture was going on, we have a lot of guests that came in. Dr. Essien Ekong is an institution on his own and is a member of the panelists. He likes to sit hiding away, but he's a member of the panelists and is within us. Please, can we put our hands together for Dr. Essien Ekong, a past General Secretary, a past Secretary General of this institution. Also in our midst is another panelist. We have 5 of them. Very unassuming gentleman. He's been an head of departments of family medicine at LASUT. Soft-spoken, Dr. Jimmy Shodipo. And of course, as a teacher, as a friend, is a very pragmatic person. As a former NMA chairman, is a pediatric oncologist. Is very accessible. I don't know, we can go on and on and on and on and on. And is a classmate of our state chairman. We have the privilege to have him as a special guest of honor here. Professor Edamisa Temiye. Please, can you stand up for recognition? Distinguished ladies and gentlemen, we keep on recognizing members, senior colleagues that are here as the time goes on. But we want to tell you that this section is so important, not only as a lecture, but to stimulate our appetites. We will all guess the slide. The Secretary General, you will just allow her to attend to Wonka issues. By the time she comes back, the slide will be sent to us. First on the platform, then once our email is ready, we can easily pick it. Because we need to read this section. And the brain behind this business class, I'm going to ask her to come at this place, and we give her a very resounding standing ovation. Very, very honest colleague, a lady for that matter. Dr. Mrs. Ibirunke Dada, please, can you come to the front here? Please come to the front. Please come to the front. She's a very shy person. Please, can we give her a rousing standing ovation, please? Thank you very much. She's actually the brain behind Safe Care in Lagos. Thank you very much. We really appreciate you. Dr. Dada, please stand up for... Thank you very much. We really appreciate it. I think it's... she's very willing to work with the private sector. We actually got to 40% of engaging her with our association between the year 2016 and 2020. We remembered we were negotiating to have 500,000 to do the scaling up when the likes of Dr. Shubol was paying about 200, 300. And even that 500, we plan to pay it at installment. We got to that point. You understand? Dr. Dada, will you tell us that opportunity is still open for us? Thank you very much. I think she deserves another round of applause. Thank you very much. So, quickly on these notes, we want to call on Dr. Shukla, whom we are going to give 30 seconds. You know, this man is a doctor, and he has the power to speak. I think he has a degree in marketing. He accused me that when the sponsors come on board, now, in 2 minutes we'll stop them. Now we're giving Safe Care the whole time to speak to us. Yes, I said you are right. But the amount they give to us is bigger than what you give to. And that is the only difference. So maybe next year when you give us 10 million, you understand, we'll give you 1 hour to speak. Please, kindly welcome Dr. Shukla. Thank you very much.
Good afternoon to all of you. Before I proceed any further, let me welcome each one of you, all the young doctors over here in your own premises. You are welcome. Namaste. Yesterday I talked a little bit, but just to bring to your notice, sir, please be attentive. There can be some questions from my side. So you are not only supposed to ask me, even I will also ask. So be attentive. Sir, our principal companies, they have accreditations from NAFDAC. They are also accredited by US FDA, UK MHRA, FDA India, as well as good number of the authorities, they have accredited them. That means what? As a doctor, you may have a question. So what? If your plant has these accreditations, so what? That means the products will going to meet the clinical need of doctors. Sir, what are your clinical needs? When you consider any particular product, you have a sum of clinical needs. They have to be met by the product. And that is possible when products are coming to you from a good company. The clinical needs, yesterday we already talked, high efficacy, quick onset of action, good side effect profile, excellent compliance, followed by cost effectiveness. Hope you all agree. Have I missed anything? Okay, so you have decided not to say anything. Cost effectiveness. Okay, sir. Now, just I'll bring to your notice one technical aspect. Sir, you have been treating the respiratory tract infection, upper and lower, with some of the antibiotic, and more precisely, we select coamoxiclav in order to take care of most of the clinically important isolates which are likely to involve, such as Streptococcus pneumoniae, Haemophilus, Klebsiella, Moraxilla catarrhalis. Also, you must be worried about Mycoplasma pneumoniae, Chlamydia pneumoniae, Legionella pneumophila. All these bacteria which are likely to involve in upper and lower respiratory tract infection has to be taken care by antibiotic, and your preferred choice most of the time are nothing but coamoxiclav. Am I right, sir? In order to take care of the beta-lactam ring present in coamoxiclav, we have added clavulanic acid. And doctor, you know clavulanic acid is highly, highly heat sensitive. Now I'm coming to technical aspect. It's a highly heat sensitive. Where we keep the raw material in factory, we are supposed to maintain temperature less than 10 degrees because clavulanic acid is a highly heat sensitive. When I make a tablet, put in cotton, bring it to your country from India, 1.5 months on high C. And you know, doctor, on high C, temperature goes as high as 58 to 70 degrees. And I'm supposed to maintain temperature less than 25. 1.5 months, container is there on high C. So clavulanic acid is at risk of getting exposed to high temperature. And you see, sir, it's not moving. You know, sir, when the temperature goes around 58 to 70 degrees centigrade, also our warehouse temperature, container remains on high at a port for 2 weeks before we clear. Then we supply to your pharmacy. Now product is in front of you. Co-amoxiclav is in front of you. I have a question for you. Looking at the product without laboratory investigation, how you would come to know that you got a co-amoxiclav, not only amoxicillin? Clavulanic acid, when it gets exposed to high temperature, it will get decomposed. Now you are left with only amoxicillin. So beta-lactam ring will not be taken care. So compromised efficacy. So how you will come to know without laboratory investigation? Is it challenging? Can you come to know? Let us say yes or no. No. Let me say like this. On behalf of you, I say no. It's a challenging. Let me make your job very easy, sir. When product is in front of you, clavulanic acid will get exposed to high temperature. Suppose already it will liberate the gases. So you see the swollen compartment behind the tablet like this. Can you see? So when you see such swollen compartment, which is called a pillow pack, that means now you are paying for co-amoxiclav, but you are getting only amoxicillin, and therefore beta-lactamase producing strains will not be taken care, and therefore compromised efficacy, and therefore patient may change the doctor, which you may not like. So, sir, anytime it should be a flat compartment like this, Advantine. No swelling. Okay, sir? I don't have this product out of stock, but still I thought that let me bring to your notice. You may have a question. How we are taking precaution? We do airlifting. We bring through refrigerated container. Despite of challenging situation from NEPA, we maintain the warehouse temperature. Now I have another question for you, sir. In case of tablet, I gave you idea. In case of injection, how you will come to know whether injection contains a clavulanic acid and that is intact? It is not exposed to high temperature. Remember, sir, we are treating the insurance patient. We have to sometime go for the economical brand. But you know, sir, how? If I don't bring through refrigerated container, I bring through the normal container, product will get exposed to high temperature, and therefore you'll get a compromised product. So in case of injection, how you'll come to know, sir? You must be using co-amoxiclav injection. Huh? Right. Please remember, sir, when nurse will reconstitute with water molecule hydrolyzes clavulanic acid in 35 minutes. It's an exothermic reaction. In 35 to 40 minutes, color will change to dark brown. If color doesn't change, that means you are having only amoxicillin. If color changes, that means you have a right product, but don't use once color has changed. Use before color changes. I don't have this product right now, so I'll not harp much on that. In case of syrup, how you'll come to know, I leave it because my time will go. Now, sir, I'm happy to introduce you. I'm very happy to introduce you tablet Iraxin. Sir, Iraxin contains depoxitin 60 milligram and the sildenafil 100 milligram. You know, sir, the data suggests 60% young population aging more than 18 years, they are suffering with a male sexual dysfunction. It could be either erectile dysfunction or premature ejaculation. Serious condition. And sir, data also suggests that out of this 60%, 50% they have a comorbidity of erectile dysfunction and premature ejaculation. Both. So I'm happy to introduce you Iraxin. Iraxin contains depoxitin, selective serotonin reuptake inhibitor. As you can see here, sir, in normal situation, you see the concentration of serotonin between the synapses is adequate. But sir, when there is a compromised, there is a premature ejaculation, serotonin concentration goes down because reuptake has started. So sir, depoxitin, it inhibits the reuptake of the serotonin, and therefore concentration of serotonin is well maintained between the synapses. And therefore, the ejaculation period is prolonged. And therefore, even IELT also gets a double, intravaginal latency time. That also increases. So, depoxitin. You know, sir, with a depoxitin, it also improves the concentration of dopamine. That's the reason used to treat depression. So your patient will have a feel-good factor also. So premature ejaculation is taken care. Then, sir, we have added sildenafil. You know well that it is a PDE5 inhibitor. It's a PDE5 inhibitor, and because of that, corpus cavernous vessels inside the penis that gets dilated. So blood accumulation will be very good. So there is a tight, erected penis, and therefore erectile dysfunction is very well taken care.
45 seconds more.
As you can see here, sir, after Iraxin, patient does well. Then 81% of your patients are extremely satisfied. We have Algimet gel in antacid. There is nothing to talk. You know everything. Everybody is giving you, sir, aluminum hydroxide, magnesium hydroxide. They are also giving you, sir, simethicone or dimethicone along with the deglycerinated licorice, sugar-free, 200 ml bottle. You can extend the benefit to your diabetic patient also. And also, doctor, as you know, before patient come to you for hyperacidity, they have already gone to various places and they got a popular brand. So there is no privacy to your prescription if you are also writing the popular brand. Am I right, sir? So, if you prescribe Algimet, which is not popular, it goes only through doctor. So Algimet offers privacy to your prescription. Packaging is so good, your patient will fall in love with Algimet gel. Then, sir, just one more information and then I close because they gave me time. Sir, I have one more question for you. You know, sir, right from 1965, 67, when amoxicillin was discovered by SKF, on that time, till now, it is manufactured by using chemical method. We use diethylamine to manufacture amoxicillin. And doctor, you know diethylamine is a severely nephrotoxic drug. If I ask you a question, sir, when you treat a lower and upper respiratory tract infection, ear to ear, do you take a renal history of the patient? You may say no. And if your patient is a renally compromised, you are giving him amoxicillin manufactured by using chemical method, sir, your patient may land up to acute pyelonephritis. You may not come to know. But how you will come to know? Looking at the product that it is manufactured by using chemical method or enzymatic method. Sir, this enzymatic method. In last 18 years, I'm in Nigeria. I did my market survey. So far, I have come across only 3 brands. They are manufactured by enzymatic method. One of them is Advantine. Remaining 2, let them come and do the presentation. So, entire range is available for you. Am I contributing something? It will help you to treat your patient better. Tell him, no, he is saying 45 seconds.
But I'm going to send you another bill that you're going to pay.
Okay.
Because you've chopped into our time.
Yes, sir, finishing.
Thank you very much.
No company has so far this combination, levofloxacin with ornidazole, Impact OZ. Impact OZ contains a levofloxacin 500 with ornidazole 500 in the treatment of PID, such as endometritis, cervicitis, salpingitis, in the treatment of amoebiasis, shigellosis, in the treatment of giardiasis, trichomonal vaginalis. Sir, Licoria, 1 tablet 2 times a day, Impact OZ. And wherever coamoxiclav fails, use Impact. That contains only levofloxacin. Doctor, for you, it is a very difficult to make a differential diagnosis, whether it is a atypical pneumonia or it is a aerobic pneumonia. Can you make it?
Yes, I can.
Very difficult. Unless you send for laboratory investigation.
Together for Dr. Shukla. Dr. Shukla can speak from now till evening.
Just Impact. That will take care of atypical bacteria because you know, sir, coamoxiclav, cephalosporin, they act by breaking the cell wall. And atypical bacteria has no cell wall. So Impact. Thank you very much, sir.
Thank you very much.
Thank you.
I told you he has a doctorate degree in marketing. But one special thing they have said to us, which I believe that at least maybe as large as 70% of our members may not know, is the protection, or let me just say, a way to allow us to know drugs that are flat, as it were. The heat efficiency or heat compliance of their coamoxiclav. It is very, very essential. So we should be looking for that pillow. Once we have drugs that has that swelling, we know that it's going to be flat, even though your sensitivity test says it is positive. So let us put our hands together for giving us into the planning. It's very, very essential.
I left one question for you.
Don't worry.
In case of syrup, how you will come to know clavulanic acid is intact?
When it
If
changes
he
color.
gives me time, I can answer.
Thank you very much. No, but we're going to send you our second bill so that you will know it's mine. Thank you very much. No, he promised yesterday that every member here are going to get one sample. Every member. Please, can we put our hands together for that, CJ? Distinguished ladies and gentlemen, we're going to take a very fantastic lecture now. Very fantastic that, in fact, when we are debating this topic, there are quite a lot of reasons. The challenge in bringing the topic was enormous. But we are also looking for an appropriate person to speak to it. And that appropriate person today is here in our midst. Kindly put your hands together to welcome a consultant orthopedic surgeon and a former NMA Lagos chairman, Dr. Adedayo, as he takes his lecture. As little as
Good afternoon, everybody. Please permit me to stand on the existing protocol that has been established all day. I must first say that I'm excited to be here, and I'm happy to see quite a number of the very senior colleagues and friends, many of whom I've seen for the first time in a long while. And I want to congratulate the association. I know you have changed your name, so I don't want to try so that I don't call the old name and be thrown out of this platform. For this obviously very successful program. Sitting down there, I have also benefited a lot from the very interesting lectures that have been given. As I've been introduced, everybody seems to remember me only with the Federal Medical Center, Ikeja. So I've always made it a point of duty to announce anywhere I have gone since March that I am no longer of the Federal Medical Center, Ikeja. I am now of the Redeemer's Earth Village. So I'm happy to be part of you now. For people who don't know, this is the latest baby in town. And we have some of the best facilities in this city. Quite a number of you very frequently, even up till now, would call me to say, oh, please, can we get space in the ICU in Ikeja? In this hospital, we have a 16-bedded ICU. We have, 16-bedded. So you don't need to send your patients to the public hospitals with all the waits and all the crowd and all of that. Our radiological center is one of the best in Lagos, and you don't have to queue, and you get your results the same day. We are inside the redemption camp. So please send your patients to me. And I took liberty to advertise us because I'm not too sure Akin, who has been my friend for about 40 years, will pay me for this lecture. So I've taken my payment. So, yes, a very interesting topic, okay, and it's about quality. Now, the question many of us will ask ourselves is that, with quality, you are investing ahead. And quality is not cheap. And then you ask yourself, if I commit this much money into a particular program, am I going to get return on investment? And I'm saying to you that I stand there as a witness, okay, that even in a public hospital, we committed enormous resources into quality improvement. And we got bountiful outcome. I'm going to present to you some of the charts here. We were able to achieve over 800% increase in our revenue. And that is down to the quality improvement that we did. And so I want to appeal to you that you should take that, leap of faith. Today's patients are very sophisticated. The era when patients saw doctors as all-knowing is gone. And they start assessing you, assessing your capacity, assessing your capability from the very moment they step into your hospital. So quality has been defined. Many definitions, okay? It's been defined as the degree of excellence as measured against standards, which means that there must be standard. And standard is not created by a single person, okay? And then some have said is the extent to which an organization meets the client's need, all right, and exceed their expectation, which means it is the client in this instance now who is, giving the standard. He has a particular, a kind of care he expects. And if you are not able to meet that care, then your facility is deemed as not meeting standards. And when you have a lot of competition, like we have today, a lot of public hospitals are today competing with the big private hospitals. The primary health care centers that we have today are competing with the moderate private hospital. So it is time for us in the private sector to also up our game. I am sure we all remember that when we started off using our GSM, many people were using Nokia. In fact, it's the biggest of the biggest people then who would buy Nokia. And there were different designs of Nokia. But today, do we still find Nokia? That is because they refuse to respond to competition. And today, the private sector must respond to the competition that is coming from the private sector and also coming from the public sector. Okay? So, now, quality means different things to different people. Okay? To some persons, it means high standards. All right? To some, it just simply means a friendly reception. And I can tell you, a couple of weeks back, I went to see a friend of mine in his hospital. Now that I've left the Federal Medical Center, the high-pressure job, I have a lot of time on my hands. And I walked from the reception of that hospital, okay, somewhere in Aja. I walked right straight to my friend's consulting room, where I met him eating amala and ogunfe, which, by the way, I joined him in. But from the reception, in fact, from the gate of the hospital to the time I got to him, not one single person, and I met more than 10 persons, nurses, attendants, cleaners, receptionists, not one single of them said, "Good morning," or "Where am I going?" And that is the story with many of our hospitals today. Medical practice today is deliberate. It starts from your gate, and that is the quality that we're talking about. Okay? Your environment must be neat. It must be receptive. Okay? And we need to invest resources. We need to invest time. We need to invest energy to be able to achieve this. I'm sure many of you will remember the Federal Medical Center of 10 years ago. Okay? Even some of us who are working in the hospital then would find it difficult putting our hands on the door to open the door. Okay? But immediately we change the perception. Look at the kind of crowd. All right? UCH today, they see about 45,000, 50,000 patients every month. And look at the huge volume. The staff strength of UCH is about 5,000. But the small FMC, Butemeta, here, every month, we see almost 40,000 to 42,000 patients. Ideally, UCH should be seeing about 4 or 5 times the number of patients that we see. But they don't see even up to 150% of what we see. That is the power of quality. And so if it can work in a public hospital, tell me one reason why it cannot work in a private hospital. Okay? So it means, all right, different things to different people, availability of service, prompt service, right price, reputation, whatever. All right? And from the provider's perspective, and you are the providers, okay? All right? It means several things to you, okay? Medically safe, professionally ethical, accessible, acceptable, offering of the state-of-the-art service, all right? So, but what is the definition by the WHO, which is what should guide all of us, whether in the private sector, whether the client, whether the provider, all right? The definition is that quality of care is the degree to which health services for individuals and population increase the likelihood of desired health outcomes and are consistent with current professional knowledge, which simply means evidence-based practice, okay? And there are 7 dimensions to it. It must be effective, all right? It must be safe. You have to ensure that, even Hippocratic Code says, okay, that above all, please do what? Do no harm, okay? So it must be safe, it must be people-centered, all right? It must be timely, okay? The era when people come to the hospital and they sit down and wait almost indefinitely for the theater, for the patient doctor who they said is in the theater, and then they are waiting for when the surgery is gone. People are paying for health services now, and my experience has shown that if you have good services, people will pay. In Ebutemeta, a lot of our patients, we were charging more than most of the private hospitals, okay? The admission, ICU admission cost in FMC Ebutemeta is 1.8 million. How many private hospitals charge 1.8 million for their ICU admission? I'm sure very few. But you will find it difficult to still get bed. And it's a 14-bedded ICU, always filled up. Why? Good quality. People know that when they get there, okay, they will get value for their money. All right? So it must also be equitable, okay, and it must be efficient. And then the present Minister of Health also weighed in, all right, and says that healthcare access without quality is dangerous, okay, and it is wasteful care. And goes ahead to say quality can only be an arrowhead for transformation to realize a different future for health systems in Nigeria and in Africa. This statement holds true for the health system as it holds true for your own private practice. Okay? Because, for instance, if you want to treat a patient who has fever, and the patient, okay, you are not sure whether it is malaria, you are not sure whether it is a popular typhoid that all of us, all the majority of private practitioners treat, okay, and then you keep giving drugs and giving drugs and giving drugs to the patient. Meanwhile, maybe what you are dealing with is resistant malaria. But you don't have evidence. At the end of the day, is it not wasteful? You have given artesunate, you are a tablet first, you have given the injection, you have given the famous cocktail for typhoid, and you have given all sorts of things. And yet, the relatives of this patient are still telling you, this my son is still running fever, doctor. So it is wasteful. Absolutely. All right? Okay. So, and we now know, previously, the battle cry was, let us create access for patients. Let's build as many hospitals as possible. Even if those hospitals are of poor quality, let us have access. But research has shown now, all right, yes, access is very important, okay, but access is not the most important thing in today's world. It's actually the quality of our care, because 72% of those who die due to poor quality healthcare services. And those poor quality healthcare services are being rendered by us. That is just the blunt truth. Okay. And it is said that about 5 million people worldwide die every year because of poor quality of the healthcare services that we have rendered to them. So maybe it's even better for them not to have any healthcare service. Okay? And this basically, okay, this slide is not fully coming on. Okay, this basically talks to quality failure, what you get. And if you want to know what is happening, okay, it's common. On quality failure, please just simply open our newspapers. All right. Recently, unfortunately, I am told, I read in the papers, that a colleague was sent to jail. Very unfortunately. And increasingly every day, we are dealing with patients who know they are right and who are willing to push the boundaries. So even if it is only to prevent all the troubles, all the hazards, all the negative publicity, it's in our interest that we must enhance the quality of the care that we give. And there are organizations in the country now, like the Safe Care that I just presented, okay, that would be able to hold us. All right? And I will tell you the story of how Safe Care came into FMC Butemeta. Many people often think that it's because I am married to the director of Safe Care. Well, that contributed to it, okay? But, we were going to have our management retreat in our first year. I think, yes, second year actually. We're going to have our management retreat, and that management retreat was going to take place in, I think, Ijebu, okay? And I wanted them, we were very happy with ourselves. As a matter of fact, at that time, the social media was filled with stories about the transformation that was going on in Ebutemeta. So we were happy with ourselves. So I invited them on the bed, and I said, look, send your people to come and go around my hospital and, give us a presentation. And she said, you will pay. I said, I don't have money to pay. Just do this for me as a social service, okay? And don't forget that we were extremely happy with ourselves. The social media was filled up with stories of what has been happening and all the rest of them. And the young lady, Anire, came around. Unfortunately, I can't show you. I didn't bring those pictures. And went around our hospital, okay, and came out with a lecture on what she saw, quality failures, including the fact that some of my staff were cutting vegetable in, of all places, the CSSD. Okay? And our eyes opened that structure alone, infrastructure alone, does not make a good quality hospital. You need to put in processes. Okay? And that was how I invited Safe Care. And this time around, when the best thing for you is somebody showing you your picture. If your picture says you are black, you can't say you are yellow. If it says you are white, you can't say you are brown. So this time around, I was happy to pay because he had actually showed me that we were sitting on a cesspool of a very bad situation. And that was how we started Safe Care, and they held us in the hand and supported us and assisted us to ensure that we were able to achieve what we achieved. Now, okay, so unfortunately, we can't deny that fact. Poor quality healthcare, low quality healthcare is a reality in Nigeria. Now, I was telling you, this is one of the pictures that was taken at that time in our laboratory. Okay, this was our blood bank at that time. This was year 2017 or 2018. Okay, and the truth is that in many of private hospitals today, this same situation still exists. That is it. We may not want to admit it, but this same situation, 10 years after, still exists in a lot of the private hospitals. And these are the kind of things that we must break away from. Okay? All right. And so, because of inadequate investment in the health sector, yes, we agree. Okay? Ineffective regulation of the health care. Okay? If a farmer comes into any hospital today, yes, we agree that maybe sometimes they are too, enthusiastic. But the moment they come into any hospital today to enforce the rules, the phone call starts coming, the pressure starts coming, and people start shouting. Okay? So there's poor regulation in our environment. But for me, I think the most important regulation actually is self-regulation. And the people who can lead self-regulation are the owners and the proprietors of the hospitals. And it's just basic things. In those days when I used to go to Crown Hospital to operate, all right, when I'm going along with Dr. Akinlade on the staircase, I will see him. He will use his hands to rub the staircase and then check. Is there dust? And over time, his workers realize that he has zero tolerance to dirty environment. So those kind of basic things. So self-regulation still remains the best type of regulation. Okay? Of course, weak accountability and poor supportive structures and inadequate numbers and capacity of skilled workers. These are some of the challenges that are causing the poor quality healthcare services that we get in our country today. Okay. So, therefore, what is the solution? The solution is quality improvement, because evidence has proven, and I will show you some of those evidence as we go along. Evidence has proven quite clearly, even if you are using my institution alone or my former institution alone as a reference point, okay, that quality, okay, brings about measurable improvement in healthcare outcomes. And I want to add that it's not just outcomes, okay? It brings about improvement in the income that comes to your hospital. When we started in 2017, okay, before we took quality as a way of life, our income was, and I will show you the graph also, was 17 million per month. 17 million naira per month. As at the time when we were living, the average monthly income had jumped to something in the region of 750 million to 800 million naira per month. And you heard me well. Okay? We had jumped from 17 million per month to about 750 million every month per month. The data are there. The evidence is there. And the key thing we did was, in fact, so much so that the Lagos Business School, this same Lagos Business School, they sent a team to our hospital to come and first evaluate, okay, and confirm what we have said. And they spent almost about 6 weeks or thereabouts with us. And at the end of the day, okay, they wrote a case study on us, which they have circulated all over the world, which are being used, all over the world in business schools now. All right. So, if it can happen in a public hospital, the other day somebody sent a mail to my LinkedIn that, this case study, okay, we would like you to come some business school that they actually even want to ask me questions. Unfortunately, it came at a time when I couldn't travel. All right. So that is the kind of impact. And the major thing was the quality improvement. Okay. So if 1,500 workers, which is the number of workers we are in the Butemeta, and I can tell you that 50% of them, in all fairness, is public service. So if they can reorientate a system, then why not your system? How many workers do you have? The average private hospital, maybe you have 100 or 200 workers. So it can be done. Okay. So the components of the quality improvement program, which I am sure they must have bombarded you with since morning, okay, is commitment. That's one major thing, commitment from the top leadership. That is what is called political commitment. If you, as a proprietor of your hospital, if you are not committed to quality, I can tell you it is dead on arrival. And you must look at quality, as a business strategy towards achieving, financial breakthrough for your hospital. That was the perspective from which we looked at quality. Because when we first came in, unlike now, when there's a lot of funds in the public space, on an average year, when I first became MD, the government will budget maybe 30 million as our annual budget, okay? And they will release maybe 10 million or 13 million. Because the million is from the public sector. What will even if they had released the entire 30 million, what will 30 million do in an hospital? Nothing. So we had to strap our boots. If you want to make impact, we had to strap our boots, okay, and look inward. The only way we can bring in resources is to bring in patients. And that precisely was what we did. And the only way we can bring patients is for the patient to know that they are going to get value in our hospital. And I can tell you, I don't know, when we were young, there used to be this, this local comedian. I think they called him Baba Sue or something, who went to Onyibo, to go and went to meet an herbalist that he wanted them to do some medicine for him, that everybody who wanted an alaru, sorry, those who don't speak Yoruba, a kaya man, that it is him they should be calling. And the herbalist made the medicine for him. And everybody in Onyibo market, when they want to carry their load, they will go and look for him. Of course, he was overwhelmed. That was what became of our situation. We became completely overwhelmed with patients. Totally. In fact, we stopped advertising ourselves. But the words of mouth kept advertising. Unfortunately for us, we have a very limited space. So we had to start growing upward. And that is what quality brings into a business. Okay? So, high quality care, like I said, builds patients' trust in the health system. All right? I don't want Akin to come and chase me out of this. So, what are the benefits of improving quality and efficiency in healthcare? All right? And the benefits are quite clear. But, let us just go through the meals again so that we can remind ourselves. Okay? Is that one of the benefits is achieving predictable results. Okay? You are bringing about measurable improvements in healthcare outcomes. All right? Then, of course, you are improving the consistency of care. And it's important. one of the things lacking in our environment is consistency of care. If I ask today, how many of us, SARS, have SOPs and protocols in our hospital? How many of us? 3, 4. I'm sure Subo would have 5, maybe 5 or 6 out of about, 7. So, yes, sir, 8, 9, 10. At least we are 100 in this hall. Yes, 11. 200 in this hall. So, only 11 of us. Okay? So, it means that if you are not on duty and they bring malaria, whoever is on duty will use his whims to treat the patient. So your what do you call it cannot be consistent. Okay? And then reducing wastage and creating efficiency. We all complain that we don't, and with the coming of health insurance, Dr. Oshuni is here. Okay? With the coming of health insurance, okay, they are not going to pay for your inefficiencies, and they are not going to pay for your wastages. For them, they are going to pay for the right treatment that you are giving. But poor quality care, what does it give? You do an appendix. I'm just as an example. In a poor theater, and the patient sustains post-operative infection. It's on your ward for the next 1 or 2 weeks. You think you are making money. You are not. Because even the money will stop flowing after 1 week. And then you keep dressing the wound, and then you are using antibiotics and bombarding with antibiotics. And when you think you're about to win, the wound opens up again. And then you keep dressing. The patient is unhappy. You are frustrated. Okay? And your profit is being eaten into. That is wastage care. And at the end of the day, okay, most people in the Nigerian business space, they look only at revenue. All right? They don't look at expenditure. I once met a big brother of mine who runs a private hospital. And he has been running his private hospital now for maybe 30, 35 years. But on the 20th of every month, you find out that it becomes, confused, no, not confused, but worried, concerned, and is talking about staff salaries. Okay? He's talking about my staff salary will soon be due. My staff salary will soon be due. Okay? And most of the time, the staff salary is not available. He has to start scavenging, where he will get money. And then eventually, maybe by the 10th of the following month, he would pay the staff salary. And that is the story of many of us in this gathering. Okay? Are you really paying yourself? Yeah, you're not paying yourself because you need money. You go to your cashier, they give you, or you go to the hospital's bank, you write to meet your need. Okay? Are you actually doing a business analysis of your business? You that you have invested, shouldn't you bring out something as your dividend? Even if you buy shares, should be at the end of the year. Okay? They will pay the management now. So you pay yourself and pay the management. At the end of the year, where is your profit? That is the blunt truth. Your profit has gone with wastages. And you will blame the entire world but yourself. Nigeria is bad. Things are expensive. Pharmaceutical companies change. Of course, pharmaceutical companies want to make profit. Okay. So these are the hard questions we must ask ourselves. What of enhancing even patient satisfaction? When you treat a patient, I don't know, for me, I'm an orthopedic surgeon. So when my patients come to me, they can't walk most of the time because they have been involved in an accident. And the day they walk into my consulting room without their crutches, I'm always very excited, okay, with the smiles on their face. So when you treat your patients and you get it right the first time, the excitement is there. Unlike when the patient starts coming and then, he's still complaining of the same thing, you are not getting it right, he's frustrated, okay, and then he goes out and badmouths your hospital. So these are some of the, okay. So standardizing process, improving consistency, standard operating procedures. Every single hospital, you must know your disease profile. What are the diseases that come to you? And you must have a standard operating procedure as, part of the overall quality improvement program. That is the only way this thing can work. Medical practice has gone beyond somebody just jumping out of medical school, working with Dr. Molola for... in fact, Dr. Molola will not even expose him to his finances. I trust my Egmo, Okay, so you work with Dr. Molola for 5 years, and then you jump out and rent a one-flat clinic, and you start, no business analysis, nothing. It's gone beyond that. And if those of us in the public sector are now coming to challenge those of you in the private sector, then it means that the beat has changed, and then our own practices too must change. I'm sorry if I'm hitting you very hard, but I think it's the blunt truth. Mm-hmm. So, reducing waste. This is part of waste. Okay? And you know where this picture is from? Federal Medical Center, Ebitimeta. This is what led us to the EMR, the Popular Electronics Medical Record. As at the time we started it, there were private hospitals who were already on EMR and doing well. But there was not one single public hospital that was on EMR. Not one. Because of the volume of data. But what led us? How can you create quality? When you find an elderly woman sitting down, you go, by 8 a.m. she's there, 12 or 1 when you are coming back, she's there. Mama Kilode, one of the case notes meaning. And then by 1:30, you then say to this thing, okay, open another case note for him. They open another case note, they see her, the following appointment, both the old case note and the new case note cannot be seen. And then at that point, maybe the granddaughter, who will not broke nonsense, comes, abuses the medical record officer. The medical record officer abuses her back. Say, I'm not even looking for your mother's case note again. So that is the kind of conflict. And I said, for God's sake, can we continue this way? And look, medicine, there is huge business there. Okay? And I said, let us do electronics medical record. And I was getting figures, 200 million, 500 million from foreign companies and even the local ones. But somehow, I got a young man from Kaduna who came to this Lagos when I invited him. He was managing their payroll system. I ran into him, I interviewed him, and I felt, look, we could do this. So I brought him to Lagos. He came with a suitcase to Lagos with his Hausa cap, but very sand upstairs. They call him Abs Global. When you see him, okay, he has taken over almost 200, and he came and we sat down and we designed our EMR over 6 weeks, and we tested it and started testing it. Very experienced, and it worked. But like the rest of you at that time, I was not a businessman. In fact, it was Lagos Business School who told me that I have just lost a pot of gold. What was my objective when I called him? My objective was that I don't want government funds to go into the drain. So my objective is just make this thing work. Whatever happens after that, not my business. Make this one to work. Then it worked. Then Kanikale called me that he heard the EMR is working with me. I said, yes, so he's working. He said, can I give him? I said, yes. Habib, go and give EMR. Habib gave EMR. That one opened his own sense. You know me, I'm a typical doctor like you now. My own sense was not yet fully opened. Fully open now, with antenna. Okay? So you then know what happened? He gave Ganikale free. But after that, I didn't know. He started selling. He went and patented the thing. Nothing for, in fact, when Lagos Business School came, Professor Bankole said, 20% of this thing belongs to you. Today, that guy has over 200 persons in his employment. His office is in Victoria Island now. Okay? And military hospital, NNPC medical, federal government hospitals, many private hospitals, state governments, they are using that EMR now. In fact, I remember I was one that insisted that, look, I don't want us to do anything. Let us hoist this EMR on a standard platform. And we went and paid for Oracle platform. You know? But am I not a doctor like you at that time? So I wasn't smart. So I then told him, because it was too late, and I didn't want to fight him. In any case, was he the one that said I should not be smart? I told him, till thy kingdom come, FMC Ebutimeta will not pay you annual dues, because it collects 5 million annual, what do you call it? Annual subscription from everybody. So, as of today, I know categorically that there are more than 70 hospitals, including military hospital and this thing using him. So 70 times 5 alone, is that not 350 million every year? So that is the thing. So when we say there are no business opportunities in the country, there is no money in healthcare, just know that talk is limited to your sitting room. There is huge money. We just have to open. If somebody comes to me today now, and I participate in that kind of thing, I am smarter. Okay, so you can see enormous wastage. As a matter of fact, when we went, sorry, Akintade, I'm watching my time. When we went on, when we transformed to EMR, okay, we saved, as at that time, over 7 million naira on printing. And majority of the printing, what happens to them? That is what doctors and nurses put in their pocket. Some of their children will use to do their assignment or write love letter or write all sorts of things. And the same thing still happens in your private hospitals. That's the blunt truth. The same thing still happens in your private hospitals. Okay? So, equitable care. It is only quality care that is equitable. So that if the governor, the other time the King of England was sick, he was in the same hospital that every other person will go. Because the care is equitable. Okay? And nothing guarantees equitable care, whether you are a cleaner or you are an attendant or you are a king, more than quality care, quality improvement. All right? Patient satisfaction. This is a real life table. Okay? And because part of what we should do also is feedback. And it traced our monthly complaints from 2017, when I took over, to 2023, when this slide was made. And you can see that the complaints progressively and consistently went down. Okay. This is what quality improvement does. And it can also happen in your own institution. Okay. All right. Now, utilization and income. You can look at it. Okay? This is from 2018. This data is from FMC Ebutimeta. I wasn't the one that produced it. It was produced as part of the case study that I told you about. Look at it. 2018, 2019, 2020, 2021, 2022. Okay? The blue is the growth in total number of patients. The red is the growth in the total number of resources and income that is coming into our pocket. All right? Now, as at, you will notice the dip in year 2020, both in the revenue and in the patient care. What do you think caused that dip? COVID. But as soon as COVID was over, okay, we continued our journey. All right? So, I don't want to mention the figures, but you can see. This, what other evidence do we need? Okay. The major kernel of our business strategy was to improve the quality of our care. We did not spend a kobo on advertisement. It was the patients. Okay. Some other companies who would generate 700 million in a month. If you look at their annual, annual advertisement budget, it may be about 100 million or thereabout. But it was our patients, the words of our patients, okay, that generated or that acted as our own advertisement. Okay. And that can happen in your practice also. And it's happening in Subo because I've seen a few presentations, okay, that Subol had made in some of the conferences where we had met. You know, in fact, the last time we met in Abuja, I was going to tell him that he needs to adopt me, you know, so that maybe every month now that I'm retired, he can be sending. Yes, he can be paying me. So that is the kind of thing. That is the kind of thing that you see. Okay. So the overall benefits, all right, there's reduction in errors. And so reduction in medical legal issues. It may be difficult to totally eliminate errors, particularly in high volume practice. Okay? But you have a noticeable reduction. And all of these things, we have evidence for them. Okay? Part of what quality also do is to streamline your work processes. Okay? And make things easier for your workers. Okay? You build better relationships. All right? There are patients who have walked into my office. Okay? Some of them I didn't even know who they are. Okay? And I don't want to mention names. And they have built lifelong relationship with me. Because some of them used our ICU, some used our maternity to deliver, some were on the ward, and they could not believe that a general ward can be this way. Okay? So it builds relationship. It also builds relationship with the other workers. All right? Okay? And then maximize output. You get more. Akitade, I've seen you. You get more, okay, out of your workers. Okay? And then, of course, productivity. Don't worry, I've finished. Productivity is enhanced. Okay? So, key enablers of quality different, this thing. I've talked of political leadership, technological advancement. I've given an example. The EMR is an example of technological advancement, okay? And when you have the resources, you can use it for so many things. Look, in FMC Butemeta, and forgive me, I'm still talking about every single patient as a monitor. Abi, Professor Temiye, you practice there. All right? So we have over 400 monitors. It's not an idea of you are rolling this thing. And not only that, every single of those monitors are connected to a central monitoring system. Okay, that can be monitored, that the nurses are monitoring. So that is the thing. Technological advancement, strategic purchase, public-private partnership. All the private operators are coming to pursue us. We want to partner with you. It's not us they want to partner with. It's our money they want to partner with. And that is it. And it puts us in a good position to be able to negotiate. You know, you can negotiate better deals for your organization, including those who want to sell drugs to you. So, gentlemen and ladies, Quality is a journey. It is not a destination. I'm glad to be here. Thank you very much for the opportunity.
I knew you were going to deliver. Absolutely. I know this man is going to deliver. You can't go yet. All he has said, they are all true. But he made one lie. He said he's not smart. It's just that he has not opened the door of that smartness. But I need to remind you that over 30 years, when some of us are doing book and reading book and playing Nougat games, he started medical politics. Even before me. Over 30 years ago. Dr. Dada is an icon. Please, can we put our hands together once again for him? Thank you very much. So, I want to call on the state chairman and our special guest, Professor Edamison Temiye, to mount the podium so that we present our token of flag in appreciation to this. He's not going to send us bill, but I can tell you that slide. I am smart now. I will take that slide and I will be taking commission for it without... 84. 84. Oh, Dr. Ekong.
For photograph. All right, let me. Ladies and gentlemen, I'm sure we're all mesmerized by that lecture. And if we had more time, we would have allowed Dr. Dada to continue. But time is not our friend. I was just passing, somebody told me that, Chairman, God is with you. And I began to wonder, how do I know God is with me? Now I'm confident, and I know that God is with me. Because when you begin to attract and associate with highly successful people, and I look at the array of people that are here present, who have come to grace this occasion, those who have come to teach us one thing or the other, they are very highly successful people. I've heard the story of your performance in FMC, and today I'm seeing you flesh and blood. I'm so highly excited and enthralled that I have this privilege and opportunity to have you as a resource person. And much more than that, my internationally recognized professor of pediatrics and oncology is here with us. We were just planning towards the end of the day, and I told my LOC chairman, please, if it is possible, get Professor Temiye to grace this occasion, and here he is today. Please, Professor, you help us, because it takes a very highly successful person to give an award to a very, very highly successful person. So, Prof, please put your hands together as...
Ladies and gentlemen, I think we've listened to a scintillating lecture. Dr. Adedayo and I walked into each other during the crisis of NMA in Lagos. There are a lot of us who are seated there who participated fully. My brother, in it, and my very friend, I don't know where Akin has walked into now. We met and we were closer after, during that period. And I can assure you that he also drove me into FMC Butemeta. to help him establish the Pediatric Hematology and Oncology Center in that place. And, when I get there, when I see patients, I don't need to look for case notes. And I can follow what has happened to the patient over time because everything is in the EMR. I don't need to look for any case note or whatever at any time. And the walls are beautiful. I went to the theater. Oh my God. I thought I was in one hospital in the UK or in the US. It's one of the best organized theater that I've ever walked into. I'm highly impressed with him and the success he has made. On behalf of Association of Nigeria Private Medical Practitioners, I present this token to you, Dr. Adedayo, for a very scintillating lecture you're giving to us, and I'm sure it is going to benefit a lot of us who are here. I have not been to Subol, but I'm sure I'm going to visit Subol very soon. While I'm sitting there, I've not been, but I've Googled your address already, and I've seen the picture of your hospital there. I'm definitely going to come. I'm going to see what is happening there. I'm highly impressed, and I believe that all of us will move forward from now. Congratulations, and God bless you.
Okay, so
Hello? There's a small conversation that just traversed between the chairman, ANPMP Lagos, and Dr. Adedayo. There is a hall that is releasing for us freely with all these aesthetics in our next program. It's given to us for free. Please, can we put our hands together? At the Redeemer Hospital. Is currently the CMD in that place. Thank you very much, Dr. Adedayo. While the presentation was on, we have another special guest in this program. And that is no any other person than the immediate past president of HFN and a member of Lagos Island of this great association. Dr. Pamela Ajayi. We are so excited to see you. In fact, he ought to have been here since yesterday, but he was at the program yesterday outside Lagos. So as soon as he landed at the airport, just now, she drove down here. We appreciate you. Thank you very, very, very much. We appreciate you. I think on these notes, we want to call on the representative, the chairman of Agege Zone, Dr. Kemi Luagbemi, to mount the podium to receive an award on behalf of one of our subjects. And that is no any other person than Dr. Kayode Zoe. Please, can you kindly mount the podium while the state chairman presents this award to you.
This is a meritorious award presented to Dr. Kayode Zoe. I'm sure we all know him, or you all remember him. in recognition of your outstanding achievement and tremendous contribution to the growth and private development of ANPMP and private medical practice in Nigeria, dated the 10th of September 2025. Congratulations.
Thank you very much. Mr. Chairman, you still need an assignment to perform. I also want to call on the chairman of Mushi Zone, Dr. Adolphus Essien, to come to the table to receive an award for another subject of his, Dr. Abu James Oshio Mokai, popularly known as Dr. Abu Jimmy. Mr. Chairman.
Let me say at this time that, like I was saying yesterday when I was appreciating our members, the tremendous support, the solid solidarity that you've given us as we came in, and all that you have been doing. Everybody deserves an award, but you agree with me, we can't give everybody an award at the same time. But we'll find a way of making sure that it goes round to every deserving member of this association. But for now, this is a magisterial award presented to Abu James Oshomohai in recognition of your outstanding achievements and tremendous contribution to the growth and development of ANPMP and private medical practice in Nigeria, dated the 10th of September 2025. Congratulations.
Thank you very much, Mr. Ikeja. Yeah. So very quickly, we will take two goodwill messages from our two special guests of honor. And the first, like we always say, ladies first, is no any other person than the brain behind SynLab, the brain behind Bridge Clinic, and the brain of the immediate past HFN president, Dr. Pamela Ajayi. Please, can you mount the podium for your goodwill, ma'am? Please, can we keep applauding her? She will tell you she doesn't play politics. She wants outcome. And that's very important for me.
Good afternoon, my elders, my colleagues, ladies and gentlemen, all protocols observed. It is actually, indeed, for me, a real privilege to be able to stand here today and give this goodwill message. First, I'd like to apologize very sincerely, particularly to our Lagos Island chairman, Dr. Sanda, for not being here, not being present. I've been in Kano. I just got back. And so please forgive me for not being here as a member of this very, very prestigious association. I must say that it is wonderful to see how the ANPMP continues to soldier on, moving forward, moving higher and higher. The lecture I just listened to by Dr. Dada was truly enlightening, and it shows, for me, it's so exciting because quality has always been a focus of the work that we have done. Whether it is at the Bridge Clinic, where we're the first ISO 17025 just certified, ISO certified IVF clinic, and in fact we're the only ISO certified clinic, IVF clinic in Nigeria, and for PathCare, which is now SynLab, where we became the first ISO 15189 accredited laboratory in West Africa, not even just in Nigeria, but in West Africa. Now, the work that has been done, and I really want to commend Dr. Dada, because I think sometimes when you are a pioneer, not everyone appreciates the work that you do. But I think doubly, I would just like to say we need to give him an additional round of applause, not just for quality and for safe care, but the fact that he did it in a government institution. You see, it's one thing when you have your own private setup and you're working on it and you're delivering it and you know how hard it is. But it is doubly, triply, and so much harder to achieve it in a government setup. And he has achieved it and stands, and that the organization, FMC, stands head and shoulders above all others. But I think for me, what resonates and what I loved about the meetings that what I've heard so far is how ANPMP have taken it on and have said, thank you, Dr. Dada. They've called him in and they've listened to him, and from the comments that we heard, people are anxious to also go on that quality journey. So it's one thing to have a business, but it's another thing to have a quality care business. And I'm just so excited with the work that ANPMP is doing in pushing forward quality, in pushing forward standards in the country. And I want to say thank you very much for all the work that you have done, and I wish you successful deliberations in the rest of the conference. Thank you very much.
Thank you very much. My very senior colleague, my friend, my advisor, Professor Edami Santomi, for his goodwill message.
My dear colleagues, senior colleagues, I'm very happy to be here today, and I consider it a great honor to have been invited to this annual General and Scientific Meeting. As we can see, that quality health care involves cooperation and interaction with each other. Nothing stands on its own. And what my brother, Dr. Adedayo has presented here is having a vision and executing the vision. He had been in the system. He has seen what was happening. And when the opportunity came for him to execute it, he executed it perfectly. And everybody can see it. And I believe, and like I've interacted a lot with a lot of members in the private sector, I was there too before I went in. Dr. Olusegun Akeredolu of Royal Oak, we were together in MA Hospital in Festac. He was the obstetrician and gynecologist there. I met him there after running away from academic. From Ilorin. He was University of Ilorin. He ran away because of poor pay and came to Lagos. I met him there, and I told him, I'm running back to academics. Where you are living, that's where I'm going. I didn't have the nerve to do what you are doing. I can't pursue people for pay. I can't run after patients for payment. I can't do all those kind of things. That's what drove me back. And I can tell you that one of the hospitals that was well run, and I think it's still being well run today, is MA Hospital. That was the first place I saw somebody telling patient, I don't think you can pay my bill. For the first time, I heard that I don't think you can pay my bill. I will take you to a public hospital. There was no apology. You know, you see some doctor, I know it is difficult to pay, but I will see what I can do. No. He's not here today, but when you see him well-dressed, handsome and well-dressed, and he tells the patient, this is what I'm offering you, and you must pay. I don't think there's no apology there. Healthcare delivery is not cheap, and patients should be made to pay. And it's also the same place where I saw, I think we are earning 60,000 naira for CS then, as far back as 96, 97. But now you see how the bill is prepared. It's prepared in a very decent, very detailed manner. Needle, 5 kobo. Giving set, 5 naira. Paracetamol, 120. Theater drugs, anesthetic drug, so much. Anesthetic fee, 5,000. Obstetrician, 10,000. Assistant. So by the time you add up, you have 60,000. And it's difficult for patients to argue that, why are you billing me 60,000? And in other places, they will fight you. You want to kill us? Why are you billing us 60,000? But you assume your doctor is only taking 10,000 out of this money. I learned a lot, and I took it to an old man that I was working with then, Professor Rebi, Dr. Rebi of blessed memory, who had a very beautiful private practice, not looking very fantastic, but we were already saving 26 workers in that hospital at that time. 26 workers have been saved by this man. The man trained in Guy's Hospital, came down to Nigeria with Professor Ransom Kuti, but was barely surviving in practice. And I was able to compare the two. And I have seen a lot of things happening to the private sector. Unfortunately, my friend Akin has left. I said, I can't see the signboard of your hospital again. He said, private hospital go up like this and come down like this. I am praying that it won't happen to any of us here. That a lot of hospitals will survive the way St. Nicholas has survived. This is one of the resilience we must build into our hospital. We must cooperate with each other. I went to also the zone of this association once when this laboratory or service delivery center in what do you call it name now? In also the bus stop there. Mikio. I said, why are we allowing Mikio to come and take our meal from us? Why can't we come together as a zone? Have a central laboratory where all of us cooperate to build there, build quality there. And as many of you will not even consult anymore very soon because the amount of money we're going to get there, instead of you having your PCV lab in your hospital, one small blood bank, when everything is put together and everybody send their sample there, send patient for investigation, that place will grow. The Indians have taken over our bread from us. And I think we can still replicate that. So as much as possible, we must work together. Let me give you another example of public-private partnership that we need to do, or working together. I'm in FMC to try to establish a pediatric hematology oncology center there. And that is my goal. That is why I have been asked by Dr. Dada to come there. The second thing that is happening is that I have the privilege of being appointed as the chairman of bone marrow transplant program in Luz. And we have started. We've done 3. The third patient is actually day plus 110 today. And we are looking forward to doing 3 at a go between October and November. But the issue there is that almost the whole hospital, including private sector, are involved in that program. SynLab is involved because some of the tests we are doing, we can't do them in our labs, and we have to send them abroad. In fact, the HLA typing, nobody is doing it in Nigeria here. We've just got, I'm saying this now, if we have interest, there was an interest I was selling to Dr. Dada, drug monitoring. Unfortunately, we have not been able to, I think maybe these people have taken your interest from it. Drug monitoring. We have to do, I'm selling this to us because we can take it up now. Drug monitoring, for example, we need to monitor when we give tricholimons, which we give for about 1 year. And we do the test every week for the patient. Every week we monitor tricholimons. We monitor CMV, HSV8, if we have diarrhea, we monitor all sorts of viruses almost every week for at least 9 months. This money is going out of the country today. And that has made the practice of bone marrow transplant to be very costly for us. So are we coming together and getting a laboratory to start doing drug monitoring? We give gentamicin, we don't monitor the blood, we don't monitor the blood level. We give vancomycin. And people we are cooperating with abroad and say, how are you practicing in Nigeria without knowing the vancomycin level? Without knowing gentamicin, amikacin level? Can we come together and set this thing up? Don't let somebody else come and do it for us again and be taking the money out of this country. This is an area where we can have public-private partnership. We try to use St. Nicholas to do cyclosporine. Because we have to do it almost 3 times a week for the first 1 month, we consume all the reagent of St. Nicholas in 2 weeks for just 2 patients. And I think it's about 300,000 per sample. I think I'm selling some ideas to people too. That is what Dr. Dada and I wanted to do. He ran away to this. Maybe we can still start it again. Because the machines are available. It's just for us to set them up. So, in bone marrow transplant, there's a lot of public-private partnership that can happen there. And this is somewhere where our association, ANPMP, can do a lot of things. I'm soon going to move out to join you. Because those of us practicing government, eventually when we move out, we come to join her. I was there before, I'm coming back. So if we can work together, I have a central area where all this thing goes. And we have our hospital working together. We should have private partnership, and we should have the public-private partnership. If we can make this to work, it's going to be to the benefit of everybody. And at the end of the day, many hospitals will outlive their proprietors. And this should be our goal. I thank you for this session, and I hope at the end of the day, we get something very good and unique in it. Thank you very much.
Prof. Thank you very much. Thank you very much, Prof. Maybe the next time we are going to discuss about pediatrics, we also bring him as a teacher to come and teach us. Thank you very, very, very much. I know the panel section and the panelists are gladly waiting. Gladly waiting. But 2 announcements are going to come up. The first one is that ideally, 12 noon is the checkout time. Anytime beyond 12, it means you're paying for the next day. If we are not sleeping over, I think one of those things that we should cleverly do is to just try to check out of the room and come back here. That's one. The second thing, yes, we have pleaded for another extra 2 hours. which is usually allowed internationally. Actually 1 hour, but we pleaded for 2. The second thing is that I'm craving the indulgence of the panelists, that the sponsors, in fact, the headliner, meaning the major sponsors of this program, was going to start accusing us and fighting us, and we do not intend to put the brand ANPMP in a bad name. They are going to speak to us in 10 minutes. 2 minutes out of that 10 minutes was used yesterday as an introduction. And we were negotiating if we were going to send another bill for that 2 minutes or they're going to be parts. So we have agreed that we're going to use 8 minutes. So distinguished ladies and gentlemen, we have the pleasure to invite to the podium the is it DP or DJ now? DP World. Please, can we put our hands together for him as a round of applause? As agreed.
Yes, sir. No problem. Good afternoon, distinguished gentlemen and ladies. It's an honor to be here to actually talk to you on what I would like to call Knowledge Lab, which is one of the projects we are currently running. My name is Olubenga Isaiah. I work with Worldwide Healthcare. We are now known as DP World. So DP World has been into the distribution of pharmaceutical products for over 20 years now, and we've been distributing for multinationals like Pfizer, Roche, Bayer, and also in some indigenous companies like Drugfield, Nimet, and Afrab. So that's what we've been doing. And we decided to say, okay, fine, let's give back to the community that has served us all this year. So we decided to partner with Knowledge Lab, and that's why I have come to present Knowledge Lab to you today. Knowledge Lab is actually an educative and interactive platform, which is actually meant for you guys to get engaged, run courses, upload certificates, and so that you would have everything together in one particular space. One of the things about Knowledge Lab you get to understand is we run seminars, webinars, and also you can also, if you're having meetings and so with, just as you are now, you can actually run it through this kind of platform. So I'll be taking you through the slides on what Knowledge Lab is all about, and then would go from there. Knowledge Lab is actually an online training tool which provides pharmacists and HCPs with access to accredited medical education and information and leading CPD compliance features to guide and support them on their professional development journey. We're actually interested in your development journey. That is why we decided to come up with this platform. So these are some of the things you would definitely find on the platform, which is actually the online training platform, which can be hybrid, and we have the state-of-the-art online learning features and tools. We're actually working on the CME compliance features and the CPD compliance features, so that your when you want to register we learned that when you want to register, you need your CME points. You can actually get that by joining seminars on this particular platform. Then we also have on this platform engagement opportunities for key stakeholders via platform features. That's with the healthcare professionals, voluntary associations and societies, regulatory bodies, councils, NGOs, corporates, hospital groups, and multinational companies. The benefits for HCPs, that's the benefits of Knowledge Lab to the HCPs is one, the online educational aspect. That's where you can join online education, which can actually be maybe a moderator can actually do a presentation, things like that, from another country, which can benefit your practice, or you can actually have access to journals as they are coming out, because they will be posted on the platform, and you'll be able to help your practice. As I said earlier, we are here to actually help you on your professional journey. Another thing that Knowledge Lab is about is automatic certification For any course, webinar, workshop that is done on this platform, you'll be given an automatic certificate because you have completed the course. And this certificate will be stored on this platform. You can take a printout if you want, but you actually have it stored on this platform. Another thing you have on this platform is the consolidated learning portfolio. This means that whatever course you do on the platform, all the certificates will be kept on a page where you can actually see what you have done, what you still want to do, and how you'll be able to manage through. Then lastly, what you can also do is external certificates that you've gotten from other courses that you've done can also be uploaded so that you have all your certificates together in one particular place. So this, as I said earlier, you have medical journals and courses, live webinars, events, recording, and highlights. These are the things that you definitely will find on the platform. Automatic issuing of certificates, as said earlier, so all your certificates on workshops and courses will be given to you immediately you've completed each course, and that would actually be stored. So when it's stored, it comes like something like this, with your name and everything, and it comes with each course you've done, and the certificates are actually seen as the PDF files. You can click on them, and then you get your certificates printed out if you want them printed. Then, as I said, you can also upload certificates that you have from other courses that you've done. You can actually have the avenue of actually uploading them on this platform, and so you have everything in one particular place, so you won't be looking for them elsewhere. It will all be together. So those are the benefits that we have on the Knowledge Lab platform, and we believe that this would actually be of good help to your practice and help you all the way on this your journey. Thank you very much, and we hope to see you at our stand where you come to register. Thank you very much, sir.
I think you deserve my hug. Honestly. Thank you very much. Time. I will always believe you. I will always believe you. Thank you. Distinguished ladies and gentlemen, we still have about 3 product presentations, but we're going to go into the panel section right now. The topic of this panel section is private medical practice and medical association. And what comes after that? What is the insight and the future sustainable goals? And this is the way it's going to go. We have very distinguished 5 erudite panelists that is going to come on board. And we have a lead panelist that we're going to introduce to give us an overview before we now start the question and answer section. Distinguished ladies and gentlemen, not in any particular order, but with some form of bias. And that bias is starting with this profile. He is a product of College of Medicine, University of Lagos, and a fellow of both the National and West African College of Obstetrics and Gynecology. He has lectured at the University of Ilorin Teaching Hospital and currently is visiting consultant to the Nigerian Navy Reference Hospital. He runs an IVF clinic and a private hospital in Festac Town. He has authored several articles in both local and international journals, and has served this association in the capacity of the first vice chairman of this association in Lagos State, and also a past zonal chairman of Amuwo-Odofin Zone. Ladies and gentlemen, this is the only lawyer, this is the only doctor that is married to a state attorney. So he's protected front and back. And like I always call him, my teacher, Dr. Segun Akeredolu. Please, can we put our hands together as it comes to the top table. Ebole, camera. Yes. Thank you very much. Please sit. Of course, the arrays of panelists you are bringing in, you will agree with me at the end of the day that they're worth it. The second person, I call him my boss, because practically all the position I occupied, he taught me how to rule there because he was there. He is a Moby scholar and a graduate of UCH. He's a seasoned private medical practitioner and a health administrator, a fellow of Institute of Healthcare Finance and Management. He is a director of Royal Cross Medical Center in Ikoyi, Lagos. He has served this association as a social secretary, as the general secretary of Lagos branch, and then the national treasurer of this great association and secretary general. He also served as a member of Lagos Task Force on Illegal Private Facility, member of Malpractice Insurance of NHIS. He is a founding director of HICO Multishield HMO. He has also been the chairman NMA Committee on Managed Care. He also represented Nigeria at UNESCO 34th General Conference in Paris, France. A chairman of Health Subcommittee on Nigeria Economic Summits Group, a member Ministerial Committee for Unlocking Private Sector Investment in Nigeria Healthcare Delivery. He's also a member of the drafting committee of Lagos State Contributory Health Agency Bill, of which I am also a member. He's a member NHIS IFC TWC for state insurance in Nigeria and is currently working as MD of HICO Multishield. Distinguished ladies and gentlemen, I have the singular honor to invite as a panelist at this section, Dr. Leke Oshunoyi. Can we put our hands together for this man? My boss. My boss.
Also the current chairman of the body of HMO.
Wow. Yes. Now that he has mounted the podium, can you recognize that he's also the chairman of HIMCAN? Please, can we put our hands together for him? Distinguished ladies and gentlemen, he is my own brother within and outside medical field. I asked him, send you your profile. He just typed 3 lines because he doesn't want to be recognized. And you remember I invited him to the white chair this morning. He said no. He said he's going to be among the populace. He's another astute medical practitioner and a distinguished public health physician. He's a senior aviation medical examiner with over 4 decades of experience in Nigeria health sector, and is a fellow of National Postgraduate College of Medicine, Faculty of Public Health, Dr. Akin. Dr. Akin. I hope he's in the hall. He's seated here sometime. Okay. Maybe he just excused himself to the convenience when he's coming back. The next person is somebody that is going to take general practitioner eventually as the bedrock. He graduated 2006 from Ahmadu Bello University. and is a fellow of both the National and West African College of Physicians in Family Medicine. Is a member of SOFON, Endocrine and Metabolic Society of Nigeria, an Association of Clinical Endocrinologists of Nigeria. Is a past Secretary General and President of LASUT ALD, PRO of NALD, and past Treasurer of MDCAN, LASUT. Immediate past Chairman of Medical Guild Lagos State, past Chairman NMA Committee on Young Doctors and Quiz, and the Mentorship Committee Chairman. He has a landmark achievement as Guild Chairman, especially on land and welfare funds. He has also served on NMA Review Committee 2022 to 2024. That historically passed delegate voting recently. He is the immediate past HOD of Department of Family Medicine, LASO. Distinguished ladies and gentlemen, I have the pleasure to join the panelists, Dr. Oluwajimi Shodipo. How many of us here knows that UCH has just only one son? We are not aware. Okay. How many of us knows that UCH is just only one protege? And the son name is also UI. The chairman of this association today is a product of UI. The special guest of honor, the consultant pediatrician and oncologist, is also a product of UCI. And quite a lot of other people. And I know there is a rivalry between UI and UCI and University of Lagos. But I'm going to introduce somebody and call to the podium now. The only son and protege of UCH, is a product of that school. This man is ANPMP working. He was a state secretary, general secretary, and a national secretary general. And he appears at all AGMs. You will agree with me that he speaks and works AGPMP and ANPMP. He has represented our interests anywhere. And the whole hall goes quiet once he raises his hand up to speak. I'm talking of no any other person than Dr. Ernest Ezeukoye. Please, can we keep putting our hands together until you approach the table, please? Dr. Ernest Ezeukoye. Very critical. And the only son of UCH is UI. You ask me, because I said their son name is both UI. University of Ilorin Products. Can somebody make a noise if you are from that school? Either as undergraduate or postgraduate. No, please. You can see. A product of University of Ilorin as well. Postgraduate. UI. Please, can we put our hands together for all of them as they are seated? We are going to enjoy this section. They are going to answer 3 questions. One was generated by me. One was generated from them. And one was generated from members, just handpicked. But we cannot go into that topic without having a lead lecture. And that is very, very important for us to understand the subject that we are discussing. And the person that is going to do justice as a lead panelist. You understand? Okay, I will do that. They're not. He is no any other person. He was here yesterday. We introduced him, and he gave us a very fantastic lecture that actually excited a lot of questions. And that is Dr. Ademolu Owoyele. Please, can we put our hands together for this? Very fantastic man. So, Dr. Ademolu is going to lead. Please, can we put out the slide in this discussion? But meanwhile, the Communique Drafting Committee, Dr. Wale Oladubo, Dr. Clement Edobo, Dr. Folarin Olasogba, and Dr. Nnena. Please, can you please converge at the table? Because this is the reason for the season. Dr. Oyele, you have the floor.
Thank you very much. Okay, good afternoon. The chairman, in person of Dr. Jonathan Esegine, Professor Temiye, good afternoon. Dr. Molola, good afternoon, sir. Distinguished elders and leaders. Once again, my name is Dr. Ademolu Oyele, popularly called the business doctor. I know I was here yesterday speaking about artificial intelligence and healthcare and how we can use this to revolutionize healthcare in general. But today, I'm going to be speaking about something even more pressing, even more important. And to do that, I'm sure we have some lead experts in front of us. I will just be a routing discussion. If we look at the topic over there, we have private medical practice and medical association, a sustainable future, need for a paradigm shift. What if the future of private medical practice is not in competition? What if the future is in collaboration? Just exactly what Professor Temiye said. It's as if you have seen my slide already. What if the future is not in competition, but rather collaboration? How can we ensure a sustainable future for our businesses, for our association, and the need for us to begin to reimagine and rethink our present situation? Allow me to burst your bubble. Allow me to give you certain statistics right now. Are you aware that 50% of private medical practices have shut down in the last few years? Is anybody going to argue with me? That figure is not from me. I think there's someone on this table or this chair that represents the Guild of Medical Directors. They released it. 50% of private medical practices have ceased to exist in the last few years. And if you don't believe that, let me also tell you, according to a report by the Business Day, 20%, over 20% of small to medium private medical practices have shut down. What does that tell us? Pardon me, Yoruba people will say, or not just the Yoruba people, you cannot continue to do the same thing, the same way, and expect a different result. This is the reason why we need to have a paradigm shift. This is the reason why we need to begin to reimagine what we do. And this is why the discussion today is very important. I'm not going to waste your time. I'm going to run through my discussion. So what this tells us is that we need to have, if you envision a future for yourself, let me use this analogy. Let's say you are in secondary school, SS2, and you intend to be a medical doctor. That is the vision you have for yourself. The question is, how do you get there? It's a single word. In business, we call it strategy. You must have a strategy. And if you're going to have a strategy, our discussion here is about strategy. If you're going to have a strategy, 5 key questions must be answered. The why, the who, the what, the when, and the what. Thank you, sir. The how. Those 5 key questions, if you don't answer them, you cannot leave the table. When you say the who, as medical associations, who are the people that are important to us? Can you tell me, please? Your members. So what is the vision
vision of the association for its members? Are you meeting your KPI? Are you meeting your mission with regards to your members? You need to rethink that. And who are the members? All private medical practices. And I just told you that what? 50% of your members are shutting down. So you need to begin to rethink. That is the who. I don't want to bug you. I won't take too much. Think about the how. So how do you do that? How do you achieve it? What is the strategy to ensure that you get to that sustainable future? The sustainable future is the one that will ensure that what? There is strength in numbers for you. The ANPMP prides itself on what? Strength in numbers. You must be keeping your members. You must ensure that you grow, not that you're reducing. So without wasting much of your time, if you look at the slide over there, we have the vision. If your vision is to ensure a sustainable future, you need to have what? A strategy. And I kept on saying this all the time. And that is the reason why we are consultants to the ANPMP. This is the reason why we are here as consultants to you. For all members to take advantage of our opportunity. And we support ourselves in that journey. This is the reason why we set up the Business Doctor Mentorship Academy, where we mentor members of the association to ensure what? Any problem within the association can ensure sustainability. Going on further, as I said, I won't take your time. The perfect storm. What are the challenges facing private medical practices right now? Financial pressures. As an association, we must be concerned about this. Administrative burden. We must be concerned about this. Competitive disadvantage. You are facing a lot of competition from who? A lot of pharmacies. Pharmacists currently are what? They're consulting. A lot of people are being called what? Doctors right now. A lot of big hospitals are coming into the country, pushing smaller practices from existence. So we need to think around how to ensure sustainability by collaborating well between the association and the private medical practices towards ensuring that everyone is happy at the end of the day. Technology and innovation, I spoke about it. What technology can ensure to make and to mar you. And we spoke about AI last year. The next generation, they feel isolated. That is the truth. The next generation, those are the younger doctors. You know, it's almost as if the ANPMP is for the older generation. We must bring them closer to us. And I said it before. Yesterday I said it. You don't have to chase people when you do what? When you create value. It is value that actually attracts people to you. When you create value for your members, they will come to you. What is the association doing for its members towards ensuring that they come to you and you maintain your strength in numbers and you support them in the journey? The ANPMP mission versus performance. We know our mission. If you look at the website today, we have the various mission there. It's all about members, it's all about. But bottom line is that, are we performing on those missions? In business, there's something called the balance scorecard, the BSC. And this is the reason why yesterday I said we doctors must begin to see our healthcare practices through the prism of what? The business. Every doctor must have the business mentality, the business mindset. And this is what the balance scorecard tells you. This is what it does. I won't waste much of your time. The balance scorecard is 4 parameters. Number 1, as you can see over there, you have what? The financial perspective. It has a financial perspective. Number 2, it has a customer perspective. Who are your customers? Those are your members. That means you must focus on your members. What are you doing for them? The financial perspective, you must ensure that what? You have some money within the association, because you cannot pursue anything when you don't have money to pursue. The association must also ensure that what is financially sustainable. Number 3, what are your internal processes to ensure that what will create value for yourself? Number 4, it must be a learning organization. What's a learning organization? You must contribute to policy making. This is how you ensure that what the government and every other stakeholder is part of you. When they know that what you're formulating policies, you're formulating standards and things like that. All these are relevant to sustainability. Now, can there be any leader without followers? I say no. You are only a leader when you have followership. When you are having reduction in your numbers, you are no longer a leader. So the association must also think about this. The first goal should be, medical association should be what? A pillar of support for all its members. So let's think around that. How do we ensure we get to that goal of being a pillar of support to all members? That should be the first goal we should be chasing as an association. Number 2 is to strengthen our financial resilience. You cannot achieve anything when you don't even have finance to pursue your goal. So the association must also ensure that what is financially sustainable. And this is the reason why I said you must even run the association as a business, and you must have metrics to measure all this. Number 3, facilitate technology adoption and integration. We spoke about it yesterday. Artificial intelligence, EMR, all forms of technology, because this is the future of healthcare. This is one of the ways you can improve your operations, efficiency, and the rest of them. Number 4, create a learning organization, collaboration, and ensure work-life balance. So, a call to action and the way forward. As I said, number 1, develop a roadmap for sustainability, have a strategy session. Beyond that, manage the association like a business while using the balanced scorecard to achieve a renewed vision for the organization. 3, what are the perspectives? Number 1, focus on your members. You must have a member perspective. Your members, what are you doing for them to ensure that you continue to create value for them and they continue to come to you? Next, after that, financial perspective. The organization must ensure it's financially sustainable so that it can pursue its aim. Number 3, your internal processes. And finally, create a learning organization. Thank you very much.
Laid the foundation, but I need him to just sit beside the BOT president to look at how that teachers are responding to that excitement that he has created. Doctor, please can we put our hands together for him once again? Private medical practice has been the major source of dispensing compassionate medical service for decades. The then private medical practitioners has come together to define their interests on how to grow the practice using the instrument of advocacy, training, and sharing of experiences, plus hand-on skill association. Association were formed, were affiliated to NME, parent body. These progenitors committed their finances, time, intelligence, and they have written their name in gold. In the very recent past, they are often consulted before health policies are taken by the government of Nigeria, who trusted their judgment. They earned those judgments. They were a medical association with etiquette, dignity, prudence, and profound respect for each other. Over the period, that institution has been eroded with loss of trust by citizens who see their services. They have been betrayers of the Hippocratic Oath. We see on social media how elections into our station has been marked with lies, thuggeries, national influence, and indeed the use of explosives. Today, our concerns are how do we get to this stage? What can be done to stem the tide? And how do we regain the trust of the citizen whom we serve once again moving forward? And equally revert the betrayal of oath we all spoke. Today's panel discussion on the topic private medical practitioners and medical association, a synoptic path and a sustainable goal. Distinguished ladies and gentlemen, I want to drive us through a path. We will be discussing the first shot at Dr. Leke Shuri. And the reason is
obvious. And I need to ask you, Dr. Leke Oshinu, my boss, we are your direct proteges. What lesson or lessons did the founding founders handed down to you, and in what form did you hand it over to your next successor? Dr. Leke Oshinu, please educate us.
Distinguished ladies and gentlemen, I stand on existing protocol. I am happy to be here today, about 40 years since I became a member of what was then the ANPMP. Very significantly, in that year, from the floor of this house, we decided to visit the new Minister of Health. The Buhari crew had given way to the Babangida crew, and Emmanuel Insan, 1975 graduate of the University of Ibadan, had been excused out of office by Babangida, who now brought in the legendary Professor Oliko Erason-Kuti. So we decided to visit Professor Oliko Erason-Kuti in his office using some data I had compiled in a pilot scheme we did on a private level. And during this visit, the Honorable Minister was confronted with the question, why can't we have insurance, health insurance in Nigeria? And immediately he called his technical assistant and appointed him as secretary to what became the, I think it was Marine Committee, which traveled around the world to decide on the model of health insurance we should adopt. So I think a round of applause is deserved by this house. Please give yourselves a round of applause. Because the health insurance you're seeing in Nigeria today started from ANPMP and Lagos State, even though we were only about 10 members back in the day. And we appointed one of our numbers to go out with this committee, which was considering models. Eventually, they decided on the capitation fee-for-service model, which is still being practiced today. The law went through many stages. There was brown paper, there was white paper, there was so on and so forth. And it took, from that visit in 1985, it took 14 years till 1999 for the eventual law to be passed. During that period, we were trying to advocate to members to say, look, this thing is coming. Let us be prepared. Let us put up the structures that will enable us to have the advantage. Unfortunately, many members here do not believe in the concept of health insurance. And when I asked someone who was here earlier, I asked him then, I said, so when do you think health insurance will begin to work? He said, maybe the year 2050. So it was an impossible task. We tried to register an HMO or a preferred provider organization from ANPMP, as it now is. But that attempt failed because there was so much pushback. So it was difficult handing over the legacy to successors because of the lack of belief in the system. So that's how I will field that question. That we did our best, but what we certainly did was to grow the organization through the presidencies of the chairmanship of Dr. Alalade, the late Dr. Alalade, and then you had on the national level Dr. Fatai Williams, Dr. Gabriel Oga. We rallied the troops nationwide and try to build a viable association. And I think that has been successful, and it has become a chain. I forgot to mention my president, Dr. Wolala, also part of that chain of leadership that builds the association to what it is today. Let me say that figures always make an impression. Dr. Dada mentioned the growth in revenue from 17 million to over 700 million a month. Let me tell you that the health insurance industry is still in its infancy. But in Lagos alone, the revenue from health insurance is over 100 billion a year, if you count the private scheme alone. Now, by law, at least 65 to 70% of this money goes to the private sector healthcare delivery. It's called the medical loss ratio. So HMOs only get about 10% of this money. The rest goes to healthcare delivery itself, hands-on. So there's a huge industry, and the regulator estimates that the market is actually in the region of 6 trillion nationwide. Of course, Lagos is half of whatever happens elsewhere. So how do we prepare for this 6 trillion naira industry? The question is before you. Thank you very much.
Thank you very much. Unfortunately, this other mic, we need to get it to work. I am so excited. And it was like you've been here since yesterday, because some of those solutions that you have, few of those solutions that you have mentioned now were actually part of the discussion that we've been having since yesterday. But let me quickly go to Dr. Essien Ekong, because you've been able to answer that the complete work that the founding father put in the brown paper was not everything that was accepted, because our members were looking at 50 years before some of them can work. But you went ahead and continued to build the association. Now I want to ask Dr. Essien Ekong, as a past General Secretary of this association, as a past Secretary General of this association, what is the role or the performance target of this association leadership in the next 10 to 15 years? What is your assessment of what it is currently? What do you think has faltered, and how can you advise us moving forward? Dr. Essien Ekong, I think there's a mic beside you. Yes, it's working.
Yeah, good afternoon or evening, colleagues. GMP members and
Hello, this is working now.
Thank you very much. ANPMP has come of age, and we are
have had a very robust organization from the time of Dr. Andem Ewa, who was the pioneer president of ANPMP in 1976, to the present stage. We have a very good hand of very good leadership successions. And we have been producing very fine executives who have been working. And that's the product of what we're enjoying here. You see, whenever we gather together, you see the good number. I can say that our elections has been credible, and that's what is happening. We have been producing people who have merit. I give credit of that one to AGPMPN. They have been electing dedicated officers, and those are the people who have been carrying on the activities of AGPMPN. Unlike what the moderator said, that at times you see people bribing people with money and doing all sorts of things to get into the position. ANPMP has not been in that category. And that's the credibility, and that's the reliance, and that's the trust of the people. When you call them, they will gather. And then they know that these are the people they elected, or the people either currently or the people they elected previously. Now to the question, where are we going? What is the trust of the future leaders of ANPMP? It is as wide as what we expect to achieve. First of all, let me start with what happened during this conference. You call the Commissioner for Health of Lagos State is not here, and he's not represented. So to say, is that, which means we are failing. We have to go, there's some link somewhere that is missing. It is true that many of us as members of ANPMP are here, but it means there are some governance, there are some infiltration, there are some representation in governance which we have not entered. So based on that, I will recommend that future leaders of ANPMP will find a way so that we have a directorate of private practice in the Federal Ministry of Health and the State Ministry of Health. If you have a directorate of private medical practice, then anything that is happening with us, they will continue to remind the commissioner, they will continue to remind the minister about the activities of ANPMP. The second one, that there's something that is trending now. They want to extend the training of medical lab scientists to doctorate in lab sciences for 6 years. That's a way of solving the brain drain. But if we are active, we should have a legislative committee, ANPMP legislative committee, both at the national, at the state. This committee will deal with every legislation at the national level and at the state level. Once you hear that any legislation is about to take place, they meet and then gather together to get the opinions of members on the way forward, on what the association stands, and how good it is for the general practice. So so that you can make a reliable input into it. And of course, we know that we need to involve our members, doctors, in politics. If we are in politics, we'll be on the driving seat. We influence a lot of things. If you are in politics. Through the lectures we have been having here, we have been told about having a very good practice. Before, we used to talk about group practice. I don't talk about group practice. What I talk about is mega practice. Mega practice. That's a practice that is well funded. You can see how Dangote's refinery is working. He didn't go and look for millionaires and billionaires to join him. He floated a mega company that he can employ anybody. If you have mega practice in Nigeria, we can get specialists even from abroad to come and work there. All specialists, you get them. How do you get specialists? What you pay them. If you pay them well, then they come and you employ them. We have a lot of them abroad. If you pay them very well, they come back and join us and then develop the healthcare system in Nigeria. And of course, as I said, we have to have credible elections, produce credible leaders who will project the good image of the association and the practice. Thank you very much.
Thank you very, very much. I think just hold on to the mic. What is important is that, first of all, you are refute that allegation that the election violence is not common with us, or is not there at all. The topic is very broad. It's not limited to ANPMP.
Very, very broad.
But is within the medical practice. So I want to ask Dr. Jimmy Shodukpo, who is also a very strong member of NMA, if that allegation can be refuted. Dr. Jimmy Shodukpo, you will answer that, and you will also tell us, are you happy with the trend of leadership of medical associations generally, and how have you identified the challenges? You need to tell us that. Dr. Jimmy Shodukpo, please.
Okay. Thank you so much, sir. And let me just appreciate the leadership of ANPMP Lagos, the chairman, and all distinguished members, and of course my Oga, Dr. Akin, for this opportunity. Well, I would just want to speak about the issue of leadership. Of course, speaking at such a forum where we have a lot of senior colleagues, elders, past chairmen of NMA, I don't think there's much to be said, because we have people that have seen it all and done it all. But the leaders matter. Yes, sir. The leaders matter. I've been listening. I am happy that I was able to attend this conference, and I was able to get some snippets of what has been said. We might remember that I tried to contest for NMA Lagos chairman in the last election. And there were some points that have been brought out, such as governance, welfare, and policy. And at that time, I felt that it's something we need to drive. I will speak to the first comments by our keynote speaker during this session on the issue of welfare. So I was the chairman of the Medical Guild between 2019 and 2021. And something happened. During COVID, we lost about 7 to 8 doctors that died. But what I observed was that when people were sick or unfortunately died, we would go there maybe just with some token. Somebody would look as if they are squeezing out some small stipend to give to a colleague or senior colleague that had died. In fact, we went to visit a colleague. I went as the guild chairman. The NMA chairman came there. We came with a check of about 100,000 naira. NMA didn't even come with anything. And we visited the person, and I saw all the challenges that were there. So, to cut a long story short, instead of lamenting, because I think sometimes we complain about some of these things. So I came back to our colleagues. I said, see, we have a number of doctors. How do we prevent a situation where when a doctor is sick, you go around begging, or somebody dies, we will now be shouting to the commissioner, give us money. They'll say, are you not the one that has been complaining all along? So we set up what we call a welfare fund, taking 1,000 naira from our doctors. But we know that people have lost trust in doctors. Even within ourselves, we've lost trust in what we can do in terms of managing money. So we set up a very strong board of trustees. Professor Akin, the former Sogon president, O&G, is the chairman of the board of trustees. As I speak to you today, though I'm no longer the chairman, that fund is going to 100 million naira. Yes, I can say it. And we've spent more than 30 million supporting doctors. I'm no longer the chairman. I have no concern. But on 2 occasions, 2 doctors in my department needed that money. It was so bad that a colleague had a very serious obstetric emergency delivered in our hospital, Lasuth. I work at Lasuth. And even within the hospital, they said, run here, go and buy. It was like a dramatic situation. Then I was the HOD. I went in to even visit them at the ICU. As I was entering, they just said, quickly go and buy midazolam or something. So by the time I got to the pharmacy, I told them at the pharmacy, I said, see, I paid for that one. I said, don't collect any money again. This is a doctor, we will pay. They said, are you sure? I said, we will pay this money. But I could say that because we had a fund. I was sure that the fund was being managed. In fact, now people are saying that we should invest that money to be able to triple, because the money is just growing. So that is on the issue of welfare. On the issue of policy, sir, you mentioned it. We are having a meeting. The best brains in the profession when it comes to business and growth are in ANPMP. NMA, we are for fighting, the government people shouting, but when it comes to how do you make money, I sat down beside my Oga there, and he was asking me, he said, where's your card? I said, I didn't come with my card. He said, you are not in business, you are a government person. Because if you are in business, you would have had your card to network. So what is my point? Have we allowed ANPMP to make useful contributions? I'm talking about contribution beyond election. Because, yes, when it comes to election, everybody, have we said, okay, we want to talk to a farmer, what is your idea? We want to talk about health insurance, we are going to the table, so that is on the issue of policy. And on governance, we still have a major problem with governance of our medical associations. I don't want to, we were all there at the last election. It was unfortunate. Not because anybody won or lost, but because I was there. Some of my colleagues saw me, they said, Dr. Shodipo, I never knew you could behave like this. I said, what happened? They said, the way you were shouting, fighting, I thought it's a normal election. So my point is, we need to now move towards consensus building, sir. The problems facing the profession are real and they are drastic. Even those of us that work in public sector, we've seen that there's no pathway. Prof mentioned it, that it's coming back to private. So I'll just end, sir, by saying that the leadership matters. We need to, but it's not about one person. That's the advantage of governance. If there's governance, even if I want to go left, the system cannot even allow me to pass. They will stop me somewhere and say, please, come back. But unfortunately, we have lost a lot of our governance structures because we have trusted in individuals as against the system. NMA, ANPMP, NAD, whatever system is a system. We must build that system. And when we have leaders that can listen to everybody, I told people, when we came up with that fund, it was not my primary idea. Of course, I thought about it, but I asked colleagues. We set up a committee. I was not involved. When they came up with their recommendations, I said, well, let's look at the 2-3 options. And we took it to the members, and they chose. But of course, people will always associate it with me. But when you are able to bring everybody together, you are able to harness the maximum, and we make progress for the profession. Thank you so much, sir.
Yes, thank you very much. Hello, thank you. I know it's going to be very interesting. I want to thank Dr. Shodipo for giving us an expose into that and invariably accepting that there were actually an election that can be marred with violence sometimes. But Dr. Ezikoye differs that that does not belong to this association. Maybe you've not been able to see it. Having said that, I want to go to my teacher. I want him to tell us, how do you improve? And that question is actually coming because Dr. Ademolu Owuyele has said, yesterday he was asking us, what do we think AI is? And how is it going to take over from us and all that? And I remember a member of this panel says, AI is not going to be for us and something that is already with us. Now, I want you to tell us, how do we improve, as a way Dr. Faduyile has pointed to, the sense of allegiance of our members to this association and make decision more acceptable and binding on members? And that is very, very critical. He has also said to us, for us to be sustainable, we need to define the interest of members and keep growing in numbers. Give us the statistics that the Guild of Medical Directors actually quoted, that 50% is gone. So you need to speak to us on this. And I will come back to Dr. Leke, who is still going to tell us on the policy of this medical association and medical practice. Dr. Adedayo. Hello. Hello. Yeah.
Thank you, Dr. Akin. Before I go ahead, I'll crave the indulgence of the media to please put back the title for this panel discussion on the screen for everybody.
Okay, that is fine. Media, please. Each speaker can speak for 3 minutes.
Please, quickly.
Please, so that we see the timer. Thank you.
While they are doing that, just as an aside, I'm happy because I'm going to be different, and I'm happy I'm the only one not wearing a suit here. Because the reason I want that topic up is when I read it, I said to myself, whoever prepared that topic wanted us to tell ourselves some home truths, or like they say in local language, the person wanted us to scatter the table. Now, it's still not coming. It says private medical practice and medical associations, semicolon. Synoptic insights and sustainable future goals. There are 2-3 ways you can look at that. Private medical practice and sustainable future growth. Private medical associations and sustainable future growth. And as far as we are concerned here today, we've had beautiful presentations about private medical practice and future goals. What we have not discussed is private medical associations and future goals. Now, I must start by thanking Dr. Jemesho Dupo, the endeavor with the Medical Guild. That's a sustainable future goal for the Medical Guild when a colleague passes. Dr. Oshoni has talked about rhetorical questions that we should look at. Dr. Essien Ekong mentioned same thing, things we should be thinking of. When I started attending meetings here, I think about 2005 or so, we would have attendance of 300, 350 colleagues. Now you look around, in this hall now, I'm not sure we're up to 200, and that's because it's the AGM. If Dr. Esegine and the secretary were to give us a breakdown of monthly meetings, we are lucky when we are 40. And even now that we are between 100 and 200, if we were to look around this hall, I doubt if there's anybody below the age of 50 here. So the question is, that same question again, how come when we say we want to look at sustainable goals, we are a dying association? Let's face that. The question is, how do we keep it alive? That's the sustainable future goal. So, to keep it alive, you must bring in younger blood. How do you bring in younger blood? You may argue that, okay, they are because of JAPA and everything. But then younger colleagues are starting, some of them are staying and setting up practices. Okay, if they are refusing to come or for whatever reason, we can borrow a leaf from other associations, maybe bring in what we would describe as associate members. In other words, young doctors working in your practices, even if it means the association will waive membership fees for them, we give them right to attend meetings. We give them right to make contributions. Yes, they may not have voting rights. That's one way, because except we want to deceive ourselves. All of us here would agree we were more vibrant 15, 20, 30 years ago. We had better ideas than we probably have now. And that's the same thing. Think of all of us in your families. Your children have more vibrant ideas than you do right now. So that's one way to go, looking at that topic. Secondly, the lead discussant talked about strength in numbers. That's a no-brainer. That is something we all would agree with. But we are losing the numbers. So how do we get numbers? We need better collaboration right now between the medical associations, especially between ANPMP and NMA. When the concept of continuing medical education came, because everybody needed the 20 points, there was an improvement in meetings, in involvement of members. The minute the Medical and Dental Council stopped insisting on that, membership attendance started waning. Because people did not see that sense, they didn't have that sense of belonging. Today, I can go to NMA, and for a cheaper amount, I would get the verification letter. So why do I need to come to ANPMP? Why do I need to attend meetings? Suppose we go to NMA, now especially that we are starting to have good rapprochement with the NMA, and have an agreement, a decision that, look, we are the private arm. Anybody who wants a letter of verification, for example, has to come to us. Let's agree with NMA. Trust comes in here. For every letter of verification we issue, you get so much. We can work it out. Because that's why I said we should put that topic back up, so that everybody is looking at it and is able to follow my line of reasoning. We need to do some of these things.
Hello?
We need, sorry, am I over?
You're on course. We're just trying to prompt you.
Point has been made about complete lack of respect from government. Okay? I know the NMA has their program next week. Maybe they will be there. But like Dr. Essien Ekong said, given the amount of money that a farmer acting under the auspices of the government makes from private hospitals, there's no big deal about setting up a directorate of private practice. Because that is, and if that directorate was there, even if, because yes, there will be competing engagements. Even if the commissioner couldn't come, the PAMSEC couldn't come, that director would be here and would be giving a feedback to his or her seniors in the ministry. Okay? So when we talk of sustainable future goods. Those are the kind of things we should be looking at to improve the future of this association and the future of every one of us. Because, like I said, every other thing about individual practices have been discussed. I'm keeping it to the association. Thank you.
Thank you very, 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 very much. I think before we go to the next speaker on this, I need to remind us of our introduction. One of the things we said at the inception was that our founding fathers earned the trust. And in what form was this trust handed over to their successor? And in what sustainable way are those policies still maintained? And I want to tell you and our team members that the founders created the need to drive membership using registration to increase our membership. And that was why the letter of good standing was there. That was very impactful, and that actually helped us. In the same vein, the smart public doctors, and Dr. Jimmy is here, they sat down and say that the private sector have been ruling NMA forever. And they started a project. How are we going to take NMA back into their hands? It is not unusual of the nature of human being to think that wise. But at one point, we expect the private practitioners to say, no, we're not taking over. We're actually working for the progress of your bedrock. And some of our leadership opened our vaults to this smart enemy. And they used that, and they took over the entire structure of enemy. And for 17 good years, ANPMP was trying to take possession, not actually a total possession, but to look at it in a more administrative way and let them know that this association, we're actually preparing for your bedrock. We had that opportunity. We went in through legislative arm, and we eventually secured the opportunity that this rotational leadership should come in. But eventually, when the time to have the slot came in, that bidding was also destructed by our own members. Dr. Jimmy is there. He's still going to speak to that aspect, and that is the form that we need to understand. There has been a process. Even the government were ready to work with us as Adedayo. But what happened? They thought it was because of an individual. No, it's not. It's because that individual knows the structure and how to take that back so that it will be beneficial to all of us. Dr. Leke Oshini, you are my boss. And you have been involved in a lot of policies. You have been involved in a lot of policies. If you can speak to us, what policy in terms of welfare, in terms of clinical governance, anyone that you can think of, that government has propounded outside insurance, because I know that you are an institution in that area, that government have walked through involving the private sector that has been able to see the light of the day. Policies. And is there any policy that they actually generated from us, we put on the table of government that will walk through, that will assist
our sustainable future goal. Thank you.
Thank you very much, Mr. Moderator. Yes, that's a very tough question, which I didn't prepare for. But let me just tracing the history of the NMA. I would say that up till the mid-80s, the leaders of the NMA were grandees. They were medical people with a huge reputation. People like Dr. Banjo, Professor Lurin, Professor Lebute. You know, these were people who had treated people in government and were highly respected members of society. So they could call Alhaji Shehu Shagari and say, look, we would like to come and see you on a medical matter. But partly due to General Babangida's intervention in medical politics, remember he gave us 20 million then for NMA House, and that scattered the NMA for over a decade. That donation. It was the NARD that now took the ascendancy in NMA. Of course, these were much younger men at the time. They were in their 30s and had not built the kind of reputation which was required, which, for example, the lawyers have. If you go to a law conference,
MBA Ikeja,
MBA, everybody's there. Because the lawyers are highly respected, they've intervened in so many matters, and they are in contact with the commanding heights of the policy ecosystem. In my submission to the recent conference on health financing, I pointed out that more than 70%, perhaps even up to 75% of healthcare is delivered by the private sector in this country. How come the private sector has no voice in health policy? And this just echoes what has been said here today severally, that if we have such a powerful role in healthcare delivery, why are we not part of the policy-making machinery? So I would say that it's important in choosing, because NMA is still the global umbrella body. In choosing leaders in the NMA, those choices must be made very, very carefully. If you make Olusola Saraki the chairman of NMA, former president of the Senate, if you go and meet him and say, sir, we need your intervention, come and be NMA president, things will change within months. I guarantee you. You know, and there are many other governors of good standing, former governors, former senators, you know, stalwarts in the society. And I think this model may help us to strengthen our medical associations and strengthen the profession, and it's much needed. Thank you very much.
Thank you very much. I know there will be other time for you to respond to the ones that you are yet to prepare for, because this panel is actually collating those information, and we are going to present it to the state chairman to see that we address each of those points and develop implementation plan on the outcomes. Thank you so much. Dr. Ezekwe, that mic has been passed to you. In what trajectory is this association going? Right now that we have started speaking with you, the elders, and is it appropriate for the old dreams? Does it align with the aims and objectives of the founding fathers? You will speak to us in 1-2 minutes, and you had a roundup as an advice that we will take as an LOC to the State Council for deliberation on how to move forward. Thank you.
Yeah.
Sorry, before you start, there's a vehicle, Lagos SD872JE, is a Corolla that needs to be moved or reparked. Thank you. Go ahead, sir.
Moderator, I love ANPMP so much.
Much. I can testify.
The way they do things, I will tell you I love it so much. You see, when ANP discovered that NMA Lagos State is becoming an albatross in the progress of healthcare in Lagos State, they make all way to find a way to becoming a chairman of Lagos State, the part of the chairman leadership of Lagos State NMA. And they worked towards it, and then it was yielding fruits. When somebody go there, he will change it and try to moderate things the way the private sector sees things so that things will go on well. Now, only a few years ago, our own Essien Ekong here with Dr. Odo, who was the national president of ANPMP, they changed the name into Association of Nigerian Private Medical Practitioners. That goes a lot. Some people don't want to hear general. Once you say, oh, but now we are carrying the umbrella of all the people who are practicing as private medical practitioners in Nigeria. If the public health has their own directorate, the private practice should have their own directorate. In short, the officers at the Ministry of Health, Federal Ministry of Health, and State Commissioner of Health supposed to be divided into two. Those attending to the public health and those attending to the private health. Therefore, the issue of directorate of private practice is very important in all the stratas of government in this country, be it federal, state, or even local government. Then, the other thing you are talking about, are we doing it the way the old, our founding fathers? I continue to say we are moving very well. So far, our modalities of electing our officials has not been polluted. We elect credible people at the state and national levels, and these people give us what they want, what we want. They give us what we want. We see Esegine we elected the other day, see what he's giving us. Are we not happy with what we are seeing here? So I think the way they handed us over is see the way we're carrying. The zeal with which Oga, Eruaga, Oshini, the other panelists we didn't see here, Akin Akilade, in short, the part they laid for us, we monitored, when I was a member, I monitored what they do and the enthusiasm they have in serving the association. And during my own time, I exhibited it, only that I see that you have a very good, knowledgeable people. Dr. K. Adeshola has been the national secretary, and he's the national president. So there's nothing I will advise him about ANPMP. So he knows almost every nook and corners. That's why I stepped aside a little bit. Mr. Moderator, as I've said, they have to organize themselves for entering the government, decision-making. That's what is remained of us. Of course, Dr. Akeredolu talked about mobilizing our members, the younger want to be part of us. That is very important. But we have to enter the government system, and be part of the government. Everything we can do by lobbying, by every way, get a legislative body, a committee for legislation, get a committee for data from the data committee. During my own time as national secretary, I wanted to establish data committee. And if we have a data committee, not only getting the data, we have to analyze the data and process it. Then it means we are getting close to taking part in AI, as Dr. Uwoyele told us. Then we are getting ready to be part of the AI and improvement and technological paradigm shift in healthcare. So that's my own submission, sir.
Thank you very much. I think at this point I need us to put our hands together for Dr. Essien Ekong for accepting that the AI is something that we should adopt. And I also want to tell you that you don't need to step aside because we are looking for you. Your name is in the record. And what you have done, the part you have laid, will keep on tapping from it. Lastly, I also want to tell you specifically that ANPMP, that name, was actually generated from Lagos. And Dr. Austin Aipo, the current national president of HCPAN, we attest to that after this time. It actually started in Lagos, and we know how it was routed before we sold it to the national presentation. That same body that coined that word have been accused of being a cabal over a period of time. So I think our members also need to be informed that if some rough names is generated from wherever, they should look for a way to ask questions. That look, these leaders are just there. They're not going to benefit anything except to sustain this association for the future. And that is what our elders. We lost two very important members who are doing advocacy for this association behind without any gain. And it has actually affected us in the last 5 years. And those are Dr. Orefalomo and Dr. Tosin Ajayi. They are very, very important members. That is for our own information. But I want to quickly go to Dr. Akeredolu, also as a round-up. I know you from time as a very complete gentleman, an accomplished gynecologist. Do you feel, in terms of government policies, legal routes will make government to revert on some of those things they are propounded that is affecting the sustainability of our practice? If the process can be changed, or the process of changing it fails, or do you still think we should intensify the use of advocacy to get what we wanted from government? And you use that opportunity to also do a wrap-up as your final submission to this panel. Thank you, sir.
Thank you again, Dr. Akintade. Now, before I go to answer your question, Dr. Oshunayi made a point which I don't want us to lose sight of. And we should think about it and think about it seriously. Imagine a scenario. If a small me here is sitting in a governor's reception because I have an appointment to see him, and the chief, Dr. Sonny Kuku, walks in, or a Papa Finney, Dr. Finney walks in, the governor might have kept me waiting for the past 2 hours, but the minute his private secretary goes in to say any of those two people is in his reception, he will come out to meet them. Yes, the only slight divergence I have with Dr. Oshunayi is we may not be able to make people like Bukola Saraki and these people like chairman of, but let's have something like, if it is board of trustees, if it is a committee of elders, so that major issues would be passed through them. The lawyers, you can't become, even at least Lagos State, not to talk of national, you can't become state chairman if you are not a senior advocate of Nigeria. Meanwhile, to become senior advocate of Nigeria, your local bar must sponsor you. You must have been paying annual dues for the last 10 years. And they take their rules seriously. I know somebody who applied for the first time in 2015 when he realized he hadn't paid. I'm sorry I'm taking more time than you've. When he realized he hadn't paid his dues, he quickly went to his local MBA branch. Whoever the secretariat people were probably bribed them, paid the 10 years at once. They made a mistake. So receipt number 001, 2005, receipt number 002. So he submitted. And when the committee in the Supreme Court found out, they banned him for 10 years from, he just became a senior advocate last last year, I think. So they don't play with their rules. And because of that, by the time you are becoming a senior advocate, you've interacted with people who will become ministers, governors, and like he said, so that is that. Now, coming back to us as a group, we still need to get to that point where we really take the association more seriously than we do now, which is why I alluded to the verification letter and all that, because there has to be a way to tie us to the association. There has to be a way. If there is no, call it a deterrent for me, why would I associate with you? But if I know that, yes, there is a way the association can get back at me, then I would play ball. So, going forward, one, we must instill that sense of belonging among members. We must come to that point where members see a need and a reason to belong. I made a point once in one of the state meetings when we were still having meetings at
MRC.
last week. I asked the question. Said, since I started attending meetings, as far as ANPMP goes, I'm a baby. But since I started attending meetings, what I have noticed is that people hold positions when they hand over, they don't even attend meetings again. And if the people who are our leaders do that, what's the incentive for me? I wouldn't bother, because I would then see it as, oh, they used it as a stepping stone. The association shouldn't be a stepping stone. The association should be key. Unfortunately, we don't have, the lawyers have what they call a body of benchers. We don't have anything akin to that. The body of benchers are so strong in the legal profession that they see a lawyer not well dressed entering a court. That body of bencher member has a right to say, you can't go into that court, go back. That lawyer can't enter that court that day, irrespective of who he or she is representing. So we need to look out and borrow some leaf from some of these associations where they are doing the right thing. We follow. Thank you.
Thank you very much. Please, can we put our hands together for Dr. Akeredolu? That's your last statement has actually answered what was actually coming from the mind of some of our members. That's why is Dr. Akitade being made the chairman of an LOC? He's just disgracing himself. As a past chairman, he needed not to. He needed not to. He's a past chairman. He should not be bringing himself down as an LOC chairman. We had it, but we are just committed to the association and we're not going to look into that as a distraction. And that is what we have actually done. Thank you. Dr. Jimmy Shodipo, you a very vibrant clinician and a family physician, a consultant in the institution, well-recognized institution in Nigeria. Do you think there is a collaboration? If there is any, is it adequate? Or there is a parallel service in both public and private sector? And why does that exist? How do you intend to bridge that gap? You've said something that's endeared me to you, that even if you have you as an NME chairman, you're going to work with the private sector. And I want you to use that answering this question to do your wrap-up so that we go to the floor. Dr. Jimmy Shodipo.
Thank you so much, sir. Well, for the collaboration, I think that there's already collaboration. I always like to look at why we are where we are, what had happened, and where we are going, sir.
The collaboration is not about medical outstation, it's medical practice. If we send in a patient as a referral, how is our referral paper treated? That's what I'm speaking to.
Okay, thank you, sir. I think I'll just maybe give, like a brief overview. So, for the issue of the private sector and the public sector, I work in the public sector. I also do some work in the private sector. And I keep telling, yes, there's more money in the private sector. But, of course, the private sector, too, brings a lot of discipline, quality of care, and it's a different dynamic to when you work in the public sector. And one of the things that I thought, and I think for some people that interacted with me, one of the systems that I think we need to fix is our referral system. In fact, I believed that one of the first things we should have done was to have organized what we call an emergency care summit. There is nobody that is not going to need to refer a patient from one facility to another facility. And I know in the past, it has always been as if you are referring because you don't know what you have done, something went wrong, but that is not the case. And I believe that if we are going to develop influence, one of the problems I think we have lost as a medical profession, and based on what our senior colleagues have said here, is influence without power. So I believe so much in that concept of you mustn't be in power or have a title to have influence. For example, like what has been mentioned by our senior colleagues, you know the governor, you know somebody, simply by your name, you go somewhere and automatically what you are saying is heard. The medical profession has lost that ability to drive policy. So anytime they hear us, it's as if we are making demands. And the question had been, what had been your own contribution to the system in which you are making demands from? So I believe also that as we move forward, as has been mentioned, the issue of those that will lead us, it has to be a question of service above self. Now, I'm going to give an example, because for me, personally, I know NMA is still there. I'm not sure I will ever contest in NMA again. No, that's just by the wayside. Not that there's an issue, but many people don't know, I've never held position in NMA, sir. But I attend meetings, I go for, I've never held an elective position. Because once or twice that I should have held, the general consensus was, let us go with this person, let us step down. So, and I don't believe that you must hold a position to attend meetings. If you must hold position, as you said, sir, that means that once you hold position, you are gone. I still attend our medical guild meetings. I was still at a negotiation yesterday, even though it was not convenient. Because I'm a past chairman, I didn't want to be there, but I just have to. So I don't believe that all of us can hold positions. There are so many very intelligent colleagues. They have ideas. But what all of us need to do is we need to support the process. We need to see that even if we are not in those positions, we can still make our contributions. Of course, the way our system is structured, because we lack governance, and that's why I will keep on speaking to governance. The person at the top now determines who should talk, who should this, who should make. So all of us are now fighting to get there. Because I'm going to come to the issue of the challenge that occurred between the private sector and the public sector. I'm a young doctor, but coming into Lagos, what I discovered was, there was some tension. But what worsened the situation was when we had the problem with Governor Fashola, and it seemed as if there was a division. Professor Timiyi can give some of the information because he was involved. There was a division between the private sector and the public sector, because when the public sector doctors were asked to leave their jobs, the private sector seemed to be ready to fill that void. And so it seemed as if there was a lack of trust that, instead of using that influence to say, solve the problem, you are using the influence to want to sort out your own personal problem. And it created a lot of problems. But luckily for us, when we had the crisis in Lagos State of the election, and new people came on board, the concept of we have general problems, we need to work together. And that is why we were able to get to the point where we even have rotational chairman.
It was a very big sacrifice. I was the chairman of the medical guild. I know people that met me and said, please, we want to contest. Why are you even thinking of such? But I said, it's not about wanting to contest. If we need everybody to have a sense of belonging, let us at least get to that level. Unfortunately, since then, I think some of the trust has been lost again because the processes that led to that were a bit faulty. So for me, sir, I think we need to continue to discuss. We need to continue to have leaders that can listen to other people, see what they have to say, and you may not agree with the person, but at least you would have exchanged some ideas. That way, going forward, we'll have a situation. I mean, I can be going for a meeting. I was the chairman of medical guild. I met with the governor 3 times because of crisis anyway. Since then, no other person has met with Mr. Governor. It was not, but I didn't meet with him because my name is Shodipo. I'm sure if they went, they would have thrown me out of the place. That who is this person? But it's because of the association. So I see a situation where we say, oh, we have a meeting. We shouldn't wait for there to be salary crisis. Oh, we think that a problem is healthcare financing. NMA has sat down. They've come up. We have, see the suggestions, the brains that have come up. We have a policy that we have come up with. We are writing to the commissioner that please we want to discuss, not that we are writing to the commissioner to say, okay, medical guild is on strike, or no. We are talking about we want to come up with a policy that can improve healthcare. And when I'm going to that meeting, I mustn't go along with somebody that does not have an idea. I say, oh, please, Dr. Lekesa, you are one of our top people. Can you come along? Even if I am the chairman or whoever is the chairman, that person takes the lead and comes up with suggestions. So I think we need to have those kind of models. That way, we build trust. And last but not the least, for me, NMA cannot control the associations. It is not the role of NMA. The same way you have the federal government and you have the states. Every state is developing. So NMA should be interested in a vibrant ANPMP. Not that I want to weaken ANPMP because I'm thinking of 2029 or 1 year that you may have even jackpot and you are not even interested in this situation again. I want to have a vibrant medical guild so that at the level of NMA, I'm talking of policy. Medical guild is fighting, and when they call me, I'm even like, I don't know the right word to like an elder that will say, no, okay, we will look into it. But if I am at the forefront of all these battles, I will lose that influence that comes without power. So I think, sir, we need to just have these conversations, but I still think we are making progress. And luckily for us, for me, even sitting down in this meeting, I've gained so much that I will still go back and talk to our people and say, because the distrust is still there. But one thing that all of us have realized, whether you are in public or private, you can only make money if you are in the private sector. So if the private sector dies, the profession is gone. The Bar Association thrives because of the private sector. And that is one message that we must strive to everybody. Thank you so much, sir.
Thank you so much. And I think at this point, we need to remind ourselves that all these panelists have actually made the future of the association very simple. They have given us results. It is now left for us to tap into it, develop a policy, implementation plan, and monitoring of those plans. And I want us to put our hands together for all of them for a job well done. I don't need to remind us that essentially what they are saying, we still need government. I don't need to remind us that I've also mentioned that we need a stronger advocacy, better than what we have now. And I don't need to remind us that they have told us that we need to improve on our membership welfare. They also told us that we need to institute a governance system. They also told us that there's nothing wrong in tapping from the system that is workable, particularly those of the MBAs. And finally, we need to also leverage on the resource that is embedded in some of our members. There are a lot of resources that are embedded in our, but we need to identify it and make sure it is tappable and it is usable, it is replicable to be used. And on this note, because I'm getting the feeder that our AGM is supposed to come up. So I want to thank the chairman of this association that have given us the opportunity to work this out, generate interest in discussion. And I want to thank also all our panelists that have graced this occasion. We are happy to have you as our leader, and we want to say we're drawing the curtain at this point. Thank you very much. But you can't go. You can't go. Mr. Chairman, you have to climb the table. Thank you much. Thank you very much. You are going for national president. Thank you. Please, our teachers, please come. The chairman has something to give to us. LOC, where are our throw pillows? Please, can we put them here? Hello, sir. Hello, sir. They have a gift for us. They have a gift for us. LOC, the throw pillows. Please. Dr. Adedayo, please, can you join us? You're part of us. We can't throw you out. It's because all hands to us. Mr. Chairman.
Well, if you found that panel discussion stimulating, I want you to put your hands together one more time for these very cerebral geniuses that we have in our midst. We want to thank you so very much. In fact, all of these men that are standing here have impacted my life personally. And I am, truly very, very grateful to God for allowing my path to cross yours. And as an association that I am privileged to lead now, I cannot just allow you to walk away like that. We want to give you a token by way of appreciation to tell you that we are grateful. It is not in the value, but it's in the spirit that is behind it. So many things that you have said that we will need to chew on and determinedly pursue as a way forward. I particularly like what has come out of this discussion. One very particular thing, one very important thing that we must go home with, that I hope our leaders here, our elders are listening to. And that is what I personally believe has been killing this association, apart from the hostile environment in which we operate, is the notion that you attain a position, run your tenure, and then graduate out of the association. And if that is your attitude, then you don't have any moral right to criticize anything. Because if you don't look at what the younger ones are doing, then you cannot say that you're performing. You should be there to give guidance. You should be there. In fact, we expect the elders to be the key with which the association will open the doors of government. And I hope our leaders are listening to us. If you are not playing that role, please sit up and begin to take responsibility. Thank you so very much. And that does not mean disrespect. All right, so are we ready? Are we ready?
Yes.
Okay, let's go. All right, in no particular order, I want to express my profound gratitude, our profound gratitude as an association to you for that which you have done, that which you have been doing, and particularly that which you have done, seen to the success of this conference. Where are they? All right. Adebolu Oyele, thank you so much for your very thought-provoking contribution to this conference. You have enriched us, and that which you have done will remain indelible in the annals of this association. Thank you so very much. Okay. Okay, our elder, our delectable, respectable elder, very cerebral. Anytime he participates in a discussion, there is always something to take home. We are so proud to be associated with you, and we want you to recognize that your position is high up there, and many of us are looking up onto you. We want to thank you particularly for all your contribution during this panel discussion. On behalf of the association, we present this to you. Thank you so much. Because I know that I'm also aware that beyond this throw pillow that I'm holding, this will be souvenirs that you will relish, that you will appreciate for a long time to come. But I know that that is not all we prepared. As you step down, we will add something else for it. Of course, Dr. Leke Oshuni, the encyclopedia when it comes to medical health insurance. He keeps telling us that is the way to go, and it will profit our business. Is that what you're saying? This is Dr. Essien Ekong. We have a few secretaries that have performed so creditably well in this association, serving the association and bringing innovations. I think it's our president, now current BOD chairman, that coined the name Kofi Annan to properly define those secretaries that have done so well. Number one amongst them, Akin Akilade, then Iruaga, and Essien Ekong, of course, number three. The people that have eyes for every detail, to dot every I and to cross every T, and to make sure that everything is appropriately recorded. You are one of them. We are so glad that you participated in this discussion. In fact, we have been missing you for so long. I said I was going to come to Oshodi and look for you. I hope you will not be missing anymore. Thank you so very much for your contribution. So, of course, like I said, it was not in any particular order. The last, but certainly not the least, I came in contact with this young man some few years ago when I was struggling to become a diplomat of the National Postgraduate Medical College. And he was to teach us some anatomy, the joints and all of those ones. And the way he handled it, a complex, seemingly complex problem became very simple, very intelligent, very calm, very understanding. And that is why I have taken every word he has spoken here at this time to mean the whole truth. I believe that he meant everything, that there can be better collaboration, cooperation between the public and the private sector. We can redefine our referral systems such that those that are in public space will not assume that we refer patients just because we have messed them up or we don't know what to do. It is legitimate, it is right that when you come to the end of your level, you refer to the next better place. Thank you so very much, Dr. Shodipo. Right from the time we met, I call him my teacher. You remember my teacher anytime, any day. Thank you so much. Please, a round of applause for that. Yeah.
Dr. Ibironke Dada, please, can you come to the top table? Can you come to the podium? It's gone. Dr. Ibironke Dada, or any member of our team, should please come here to receive this on her behalf. Meanwhile, we have this Corolla still obstructing. SD872JE, Corolla, white Corolla, as I was told. SD872JE. Uzo Dima, please, can you come up to represent?
Good evening, ladies and gentlemen. My name is Pharmacist Paul Chukwuebuka, and I'm from Seagreen Pharmaceutical Limited. This evening, I will briefly take us on a very concerning topic. Anal disorder. Hemorrhoid hemorrhoid is actually one of a very concerning disorder that we come across in our various practice. There are two different types of hemorrhoid. We have the internal hemorrhoid. This particular type of hemorrhoid actually occurs inside the anus, and it doesn't bulge out of the anal canal, while the external ones bulges out of the external canal. So the hemorrhoid, by definition, is actually a pool of blood vessels that get swollen and sometimes inflamed, leading to bleeding sometimes. As you can see, the internal hemorrhoid is actually the one that actually causes the bleeding because it is formed from embryonic endoderm of the anal sphincter. So sometimes because of the embryonic endoderm, it can easily burst and cause bleeding. So like I explained before, the external hemorrhoid is formed from the ectoderm, while the internal hemorrhoid is derived from the embryonic endoderm. Because of the embryonic nature of the endoderm, it can easily fracture and lead to bleeding. Permit me to say that I'm not here to teach you pathophysiology. It's just to remind us, refresh our mind of what hemorrhoid is all about. So this is also another type of hemorrhoid known as thrombus hemorrhoid. This thrombus hemorrhoid is also an external hemorrhoid, but it contains some clotting factor inside it. It can actually cause pain, and this is one of the reasons that made Decrew Pharmaceutical Limited to look for a particular product we call Anumes that can be used to manage the pain that comes as a result of this thrombus hemorrhoid. Thrombus hemorrhoid can also be managed or can also be taken care of through surgery. It might also interest us to know that about 20% of patients with hemorrhoid will sometimes come down with concomitant anal fissures. So, this is how inflammatory response leads to generation of a hemorrhoid. This inflammatory response can actually happen as a result of straining during bowel movement. This straining can actually cause inflammation. When it causes this inflammation, the inflammation leads to a cascade of events that eventually leads to the formation of hemorrhoid. And this cascade of events can also lead to the production of cytokinins and some free radicals that will eventually lead to the formation of a hemorrhoid. So these are the symptoms of hemorrhoid. One of the symptoms of hemorrhoid is bleeding, pain, anal discomfort, anal discharge, pruritus, and swelling. Therefore, any medications that is supposed to be used to manage these symptoms should be able to act locally on the hemorrhoid. Since hemorrhoid is a local disease, should be able to act in order to take care of this bleeding, pain, anal discomfort, and discharge that comes with it. Because this is actually discomforting to the patient. And if the agent is not managing these symptoms, it becomes a problem to the patient because the patient wants to have instant relief. The patient that already come to the hospital and is bothered is coming to the hospital with pain. And also, it is important for us to know that many patients, they feel embarrassed sometimes to seek medical attention. And that is why I'm encouraging us today that as we go about our practice, as we go back to our various hospitals, it's also important for us to encourage this patient. Majority of the time, we tend to talk to the patient about diabetes, about hypertension, but some of them, I can tell you, by March this year, one of my cousin brother called me and said that he was feeling dizzy. And I encouraged him to go to the hospital. Unknowing to him, he went to the hospital, and when he got admitted, he found out that his PCV was already 18%. Imagine somebody that was having PCV of 18%, he was already feeling dizzy. And on proper examination, the doctor found out that he was having hemorrhoid. And when I inquired further, I discovered that this guy has been bleeding since November last year. He was unable to open up to anybody because he was feeling embarrassed. But after that, he was managed carefully, and I also sent him some pack of our medication called Anumes, and he has been using it since then, and is getting a very good result. So these are grades of hemorrhoid. We have grade 1, grade 2, grade 3, and grade 4. In grade 1, it's just what we call internal hemorrhoid. Grade 2, the hemorrhoid bulges out but does not come out of the anal canal. While in grade 3, it bulges. In grade 2, it bulges out from the anal canal, but after normal bowel movement, it goes back. In grade 3, it bulges out, but after normal bowel movement, it doesn't go out. You can actually take it in through mechanical means. And at this grade is also a grade where our product is also very, very important. Because sometimes, because of the pain that they are passing through, you will need to apply. Our product Anomes contain lidocaine, which when you apply it at this 3rd grade, first of all, it will numb the area and the person will not feel pain. And you can carefully push the hemorrhoid back without the person feeling pain. In grade 4, immediately it gets to grade 4, automatically knows that the person have to go through surgery. But still yet, Anomes ointment is also powerful enough that it can be used to manage patients while they are waiting for surgery, and also it can be used postoperatively after surgery because it contains allantoin, which can also help in the healing of the wound as a result of the operation. So these are causes of hemorrhoid. Other causes include analysis, straining during bowel movement, low fiber diet, lifting heavy items regularly, and sitting long in the toilet. This is a common practice that the majority of us do. We go to toilets and think that the toilet is a place where we can press our phone for too long, spending too much long hour. And also for some of us that are into medical practice, sometimes we are not left out because we tend to sit at a particular place for too long a time, consulting, talking to patients. I might not even have time to even take our meal. So, like I said earlier, considering the case of my brother, sometimes if this hemorrhoid is not detected early enough, it can lead to surgery. And sometimes the complication can be very, very concerning. One of the complications include chronic anemia due to blood loss, then heart attack. Imagine somebody that's having a PCV of 18%. Definitely the person is going to be undergoing hypovolemic, and that can actually lead to heart attack if the person has already compromised heart. These are the diagnoses. And like I said earlier, sometimes patients, they feel embarrassed. They feel so uncomfortable to discuss this thing with medical practitioners. That's why there's a need for us to encourage them. At least we should also, when we are doing outreach, we should include rectal examination. We should also advise them in our various channels. When we are talking about health, we should also tell them to also be mindful of their rectal health. It's also important because sometimes this sign, this bleeding might not just be hemorrhoid. It might be something worse. It might be malignancies. So these are the treatments, options that are available in management of hemorrhoid, but I will be focusing more on the medication aspect of it. Then any agent that is going to be used to manage hemorrhoid should be able to take care of the itching, and for it to take care of the itching, it should contain a soothing agent. It should be able to take care of the inflammation, and for it to take care of the inflammation, it should be able to contain steroid. And it should be able to take care of the pain, and for it to take care of the pain, it should be able to contain analgesic and local anesthesia. And for it to also be effective, you have to take care of the swollen veins. And taking care of the swollen veins means that it has to contain a vasoconstrictor. And also, it should be able to take care of the tissue damage. And for it to take care of the tissue damage, it should be able to contain astringents. And also, therefore, Green Pharmaceutical, after a lot of research, discovered that ointment is an ideal treatment option in management of hemorrhoid. So these are the advantages of ointment in treatment of hemorrhoid. One of them is the lubricating action of the ointment. Ointment actually contains 80% of oil. So it's oil-based compared to cream, which is water-based. So when you apply the ointment, it lubricates the anal sphincter, therefore facilitating pain-free evacuation of fluid. It also acts locally. It has a localized action. Therefore, when you apply it, it actually stays for longer and allow the absorption, because of the oil content, it stays longer and allow for the absorption of the active ingredient inside the ointment. And it can be used to manage all the stages of hemorrhoid, especially grade 2 and grade 3. Like I said before, in grade 2 and grade 3, the hemorrhoid budges out. It can go back easily in grade 2, but in grade 3 it cannot go back easily. That is why you need Anomes ointment to apply on the surface of the hemorrhoid before manually pushing it with your finger inside. So we talked about this earlier, that ointments contain about 80% of oil, which makes it to be thick, greasy, and viscous. Therefore, it can stay for a longer time, permitting the other active ingredient to be absorbed into the rectum. Then, permit me to introduce to you Anomes from Seagreen Pharmaceutical Limited. Anomes contain 4 powerful active ingredients. It contains hydrocortisone, which is an anti-inflammatory agent that takes care of the inflammation. It contains lidocaine, which is a very fast-acting local anesthesia that takes care of the pain. It contains zinc oxide, which is an astringent that helps to shrink the hemorrhoid. It contains allantoin. This is very, very important because it has a lot of benefits. Allantoin, not just only an astringent, allantoin is a moisturizer. Allantoin is also an antioxidant. It tends to block the progression of hemorrhoid. By taking care of the free radical, it blocks the progression of hemorrhoid from stage 1 to stage 4. Therefore, a person that is using Anomes frequently might not necessarily need to progress to grade 3 and can easily manage hemorrhoid. So like I said before, hydrocortisone is a corticosteroid anti-inflammatory drug which decreases the pain, swelling, and discomfort. So with these 4 active ingredients, Anomes ointment accelerates healing process, reduces itching and swelling, reduces pain, reduces inflammation, and that is why we say it's 4-in-1 action. How do you apply Anomes ointment? Anomes ointment, like I said before, in all the grade of the hemorrhoid, it can be applied. But the easiest way to apply it is just, first of all, apply it around the area. Each of them comes with pain. And when you apply in the area, it numbs the area. And when it numbs the area, you can easily introduce it inside the
Grew Lab, please queue up.
Thank you very much. So please, our stand is behind this place. The first 30 people that comes around, we have a free sample from us.
Please go ahead, Grula, please. No, this is Oswald. Meanwhile, Murano GGE 386BF, Corolla EPE 4110JX, Corolla KSL 467. Please come and repark. Please. Murano, Corolla, Ekpe, Koshofe. Please. Thank you. Please let Oswald. I think the slide is not coming up until Oswald. Please. Oswald, you have 10 minutes. Please. Right. Please, can we put the timer, please?
Where is it?
It's there. It's on the table.
Okay. Okay. Good evening, distinguished doctors. My name is Ehis from Oswald Nigeria Limited. Oswald Nigeria Limited is a subsidiary of May and Baker Nigeria PLC. And today I'll be presenting to you a polyherbal antiseptic cream called Boroke Neem Cream. Boroke Neem Cream has about 5 herbal ingredients. And these herbal ingredients gives its properties such as astringent properties, antimicrobial property, antibacterial property, and all of these property gives Boroke the ability to be able to enhance the healing of wounds. So when you talk about healing of wounds, borough neem cream is very effective in handling those conditions. Also, when you talk about first and second degree burns, borough neem cream is very effective in that. And then why does borough neem cream has all of these activities in one? It's because it contains Azadirachta indica, also called dongoyaro. Yes, that's the neem plant. It contains dongoyaro. It also contains aloe vera. It also contains Serraca indica, Sesamum indicum, that's sesame seed oil, and also licorice. So all of these herbal ingredients have proven efficacy, which makes borough neem cream to be effective in those highlighted areas, which I will be elaborating in the future slides. So when you're talking about healing of wounds, because of the antimicrobial properties it has, and also the wound healing properties, borough neem cream is very effective in enhancing healing of wounds. Also, when you talk about first and second degree burns, what should come to your mind is borough neem cream. Then when you talk about some bacterial infections such as boils, borough neem cream is very effective for that. And when you talk about itchy skin, borough neem cream is also very effective. So the wound healing process, we all know that. I don't need to start discussing that. So neem, there are two active ingredients in neem that gives it its wound healing properties. It is azadirachtin and melantrol. And neem...
David Azora, we thank you so much. We thank you so much. I think Dr. Jayola, thank you very much. We really appreciate you. It was actually a complete teamwork. Thank you so much. You can have your seat. At this time, we want to call on the chairman, Dr. Jonathan Esegine, DMP, and his entire team to mount the table to commence the AGM. You're an next official, you be.
Permit me to say this.